1 second.
Okay.
Just a second, Rishi.
Okay, no problem.
Okay, Rishi.
Okay.
Please go ahead. Yeah.
Great. Good morning, everybody, and welcome to the London Hand and Wrist course. I want to thank Orthopedic Principles and say hello to all our viewers in India as well. So over the course of the day, we're going to be covering all things hand and wrist. So I want you guys to use it as an opportunity to really sort of develop your knowledge of hand and wrist, get a good understanding of what needs to be known for the exam, but also don't feel scared to ask any questions, no matter how minor. The aim is that you leave today with a full knowledge of what to pass for the exam. So when looking at biomechanics of the hand and wrist, I immediately see people's eyes starting to glaze over, and I see that sort of sense of trepidation and fear. But my advice is, before you can understand what goes wrong, you have to understand what goes right first. So you have a knowledge base to work back from if you ever get into a panic in the exam. So I'm going to keep it really simple. And I look at biomechanics on two levels. I look at the level of the fingers or digits and the wrist and carpus. Okay, so in terms of the fingers, just think that there's two motors, okay, and three joints: the interphalangeal joints, the metacarpophalangeal joints, and the carpometacarpal joints. So two motors, three joints. Okay, so let's start with those joints. So you've got the interphalangeal joints, all right? So these are simple joints. They're hinge joints similar to the knee, and they basically have one plane of motion: flexion and extension. And that's the distal and proximal interphalangeal joints. Next, we've got the metacarpophalangeal joints, and these essentially have two axes of movements. They're ellipsoid joints. So as well as flexion and extension, they also allow abduction and adduction. So just remember that, two axes of movement, ellipsoid joints. And then finally, the carpometacarpal joints. Again, two axes of movements, and these behave as saddle joints: flexion, extension, abduction, adduction. Okay, so remember that: hinge joints, ellipsoid joints, and saddle joints. One axis, two axis, two axis. That's what you're going to remember for the exam. So we then go on to the motors. Remember, I said there's three joints, two motors, and these are motors which control your movement. And I break these up into the extrinsics and the intrinsics. And your extrinsics are the extensors and flexors. And I think of these as the movements which give you power, whereas the intrinsics are more important for your fine tuning. So doing those sort of fine movements. So I'm keeping it very simple, very basic, but that's how I want you to remember it for the exam. So let's start with the extrinsics. And as I said, it's flexors and extensors. The extensors are the first part, and you will need to know about the basic extensor mechanism for the exam. So the way that I think about it is the extensor mechanism starts over the proximal phalanx, and it picks up contributions from the lumbricals and interossei on the radial side to form this thing called an extensor hood. Okay, that extensor hood then basically splits to form a central slip, which inserts into the middle phalanx and extends the PIP joint, and two lateral bands, which then will insert as a terminal extensor tendon into the distal phalanx and extend the DIP joint. Okay, so you've got that extensor hood, central slip, lateral bands. That's what buzzwords I want you to remember for the exam. Okay, and what are these things here, the sagittal bands? Well, these are important because I call these the locators. They keep the extensor mechanism in place when you bend your finger or when you flex your finger. Okay, so if you get, for example, sagittal band ruptures, which we see in rheumatoid arthritis commonly, and they bring these up in the exam, you might get dislocation of that extensor mechanism into the gutter. And the way that you can test for that clinically, sagittal band rupture, is you can passively try and relocate the finger. So passively extend the finger and see if they're able to maintain that position. If so, that means that it's a sagittal band rupture rather than a true extensor tendon rupture, okay? So remember those 4 buzzwords: extensor hood, central slip, lateral bands, and sagittal bands, okay? Those are the 4 parts of the extensor mechanism I want you to discuss in the exam. And one thing you'll learn from me is I love signposting. I love giving bullets to the examiner, little signposts, okay? So that's the 4 things I want you to remember going into the exam, those bullets. The next part is this buzzword called retinacular ligaments. And what do the retinacular ligaments do? Well, they also help to function to keep the extensor mechanism, in particular, the lateral bands, in place during flexion and extension of the finger. And there's 3 retinacular ligaments that I want you to remember for the exam. The first one is the triangular retinacular ligament, this one that you see here. The triangular ligament prevents volar subluxation of the lateral bands, and it's commonly injured, attritional injury, in a Boutonier's deformity. And I'll come on to that in a second, but just remember that triangular ligament goes in Boutonier's deformity. The next one is the transverse retinacular ligament. And the transverse retinacular ligament this time stops the lateral bands from going dorsal, okay? So it prevents dorsal subluxation of the lateral bands, and basically that gets injured in swan neck, okay? So triangular prevents volar subluxation, gets injured in Boutonier's. Transverse prevents dorsal subluxation, gets injured in swan neck. That's what I want you to remember. And the final one to remember is this thing called the oblique retinacular ligament. It's kind of like a diagonal retinacular ligament. A sort of other name that we sometimes use for it is the ligament of Landsmeer, okay? And this functions as a kind of connecting line between the PIP joint and DIP joint motion. So when you flex the PIP joint, the ligament will relax to allow DIP joint flexion. When you extend the PIP joint, the ligament will tense, and that will automatically allow DIP joint extension, okay? So just imagine it's a communicator between PIP joint and DIP joint motion. So those are the 3 retinacular ligaments. The last one that I'm going to mention very briefly is this thing called the volar plate. And the volar plate, the way that I think of it is it's like a check rein. It's a thickening of a capsule which sits volar to the joint to prevent hyperextension of the joint. So you've got one over the MCP joint, you've got one over the PIP joint as well, okay? And that's important because if you get dislocations of the PIP joint or the MCP joint, particularly with a hyperextension injury, you've got to be careful that the volar plate can be injured and can sometimes sublux into the joint as well, okay? And that can prevent extension. We then move on to the flexor mechanism. And the flexor mechanism is a lot simpler. You think of it as FDS and FDP, okay? So the FDS tendon, guys, it splits at the proximal third of the proximal phalanx to form a gap, which is known as Camper's chiasm. The Latin word chiasm basically means a gap. And that then rotates around the FDP tendon, which basically passes through the chiasm, and the FDS inserts into the middle phalanx and basically flexes the middle phalanx. Whereas the FDP, the 2 parts will go around and insert into the distal phalanx, flexing the DIP joint, okay? So FDS flexes the middle phalanx, flexes the PIP joint. FDP flexes the DIP joint. That's the simple things to remember, okay? What else do you need to know for the exam? You need to know that FDP is a mass action muscle. So the way that I think about it is FDP2, the FDP to the index finger is independent, but 3, 4, and 5, you can think of that as a mass action muscle, which means that one tendon will control lots of digits together and they will move as one, okay? Although FDP to the index will have an independent movement. Now, why is that important? Well, it's important because if one of those tendons to 3, 4, or 5 is shortened, for example, let's say you've injured your FDP tendon, it's been repaired, and as a surgeon, you repair one a little bit short, it means that all of those 3, 4, 5 tendons will be shortened. So they will never achieve full excursion. And that's known as a quadriga effect. It's sort of likened to a Roman charioteer, where basically one person takes the reins and controls lots of horses. So that's the analogy you've got to think of in your mind. Okay, so FDP, mass, action, muscle. That's the take-home message. Okay, so those are the extrinsics that I've talked about. So let's move on to the intrinsics, and these are responsible for your fine-tuning movements. And I think of these as the lumbricals or interossei. So let's start with the lumbricals. The lumbricals, guys, are unique muscles because they originate from one tendon, the radial side of FDP, and they insert into another tendon, the radial part of the extensor hood. So they go from tendon to tendon. And the way to think of those is they're guy ropes. So they basically fine-tune movements between flexors and extensors. That's what the lumbricals are responsible for. And they flex the MCP joint and extend the IP joints. Okay, that's important. All right. So in the exam, everybody goes on about, oh, EDC extends the IP joints. No. Think of it as lumbricals, and interossei is responsible for that. Okay, lumbricals specifically extend the IP joints. All right, EDC is responsible for the MCP joint. Okay, so that's an important point to know. There's things that people often get confused with. Let's move on to the interossei. The interossei, again, these guys will flex the MCP joint and they will extend the IP joints. Okay, they're not as strong extensors as the lumbricals. Okay, so the lumbricals are more powerful. Do any of you know why the lumbricals are more powerful than the interossei as extensors of the IP joints? So it's all to do with the center of rotation. So the center of rotation of the lumbricals is further away than the interossei. So they have a longer lever arm. So they have a greater biomechanical advantage. Okay, so that's really important, guys. I know a few of you mentioned about intrinsic plus, intrinsic minus. Remember that in the back of your minds. The lumbricals and interossei extend the IP joints and they flex the MCP joints, but the lumbricals are more powerful because they've got a greater mechanical advantage. And the interossei also abduct and adduct the fingers, okay? So remember the mnemonic, pad and dab. Palmar, adduct, dorsal, abduct. Pad and dab, okay? I hope I'm making you interested in biomechanics now. Okay, good. So we're surgeons, all right? And at the end of the day, it's all very nice having a biomechanics lecture, but what you guys want to ask me, I hope, is, well, Dr. Rishi, what is the actual relevance of biomechanics? And I like to say biomechanics in action. Let's put it into action and think of it in a practical point of view, okay? And these are the three conditions that often come up in the exam. Intrinsic plus, intrinsic minus, and lumbrical plus. So I'm going to go through those with the knowledge that we've talked about. So let's start with an intrinsic plus hand, and that's where you've got some sort of muscular imbalance between the intrinsics, the lumbricals and interossei, which become spastic, and the relatively weaker extrinsics, FDS, FDP, and EDC. Okay, so if your intrinsics are more powerful than your extrinsics, bearing in mind what I've told you about the movements, what position will your hand be in? Yes, so you're going to get basically a flexed MCP joint and an extended IP joint. Does that make sense, guys? Because the intrinsics extend your IP joints and they flex the MCP joint. So think of it as a seesaw between the intrinsics and the extrinsics. The intrinsics are relatively spastic and more powerful. So you will get that thing. It's what we put people into in an Edinburgh position after we often do sort of finger repairs and injuries like that. Okay, so it's muscular imbalance and you get that classical positioning there. And there's various things that can cause it. So it can be caused by trauma. You can get it in rheumatoid arthritis. So trauma, for example, it could be direct, indirect. It could be a vascular injury. It could be compartment syndrome, rheumatoid arthritis. It could be somebody who's got an MCP joint dislocation, okay? And then basically ulnar deviation, and that causes the intrinsics to go into spasm and become sort of extra excited. And then neurology, for example, CP or a stroke. So on examination, you get that classical appearance. And the way you will test for this is, what's the test for a intrinsic plus hand? Does anybody know? Yes, it's called a Bunnell's test, okay? So with a Bunnell's test, what are we doing, Miraj? How do you do a Bunnell's test?
So basically, ideally with fingers in flexion, if the intrinsic are working and both are controlled, we can still extend the MCP joint. But if the intrinsic are tied with the wrist in extension, we can't flex the MCP joint.
Yeah, so exactly. So you guys might be asked now, and this is one thing to just as an aside, guys, in the new exam, because you often don't have patients because of COVID, you might be asked to talk through clinical tests. So the way that I would talk through Bunnell's test is I would literally say, right, what you're doing is you're basically testing MCP joint extension, and then, sorry, you're testing the PIP joint flexion with the MCP joints extended, and then with the MCP joints flexed. And what you find is when you basically extend them, when you tighten up the intrinsics, you'll find that PIP joint flexion will reduce. And that is a positive Bunnell's test, which you can see here. MCP joints are extended, okay? MCP joints are flexed, okay? So you can see here, when they're flexed, the PIP joint will flex more. When they're extended, the PIP joint doesn't flex as much. So that's intrinsic tightness. We next move on to intrinsic minus, or the more common claw hand that you see, okay? So this time, basically, it's an imbalance between the extrinsics, which are strong, and the relatively weaker intrinsics. So Sahel, bearing that in mind, if I've told you the extrinsics are strong, the intrinsics are weak, what position will the hand be in?
So then you get clawing of the hands.
You just describe that to me, though.
So you get flexion of the interphalangeal joints, and you'll get extension of the MCP joints.
Very good point. So guys, the biggest thing people say in the exam is they all go, oh, what's the claw hand? Everybody goes on about you get flexion of the IP joints, DIP joint, PIP joint. Everybody misses out that you get hyperextension of the MCP joints. So true clawing is also hyperextension of the MCP joints, okay? So now I hope you guys, rather than learning this by route, you can work it out from what I've told you in the biomechanics. If you just remember my seesaw analogy, intrinsic plus, the intrinsics are more powerful than the extrinsics. Intrinsic minus, the extrinsics are more powerful. Then if you just work out what each of those does, you don't need to memorize this. That is the way that I would learn for the exam, especially part 2. That is what they are testing. Okay, and what causes that? Well, just think of anything that can cause the intrinsics to become weak. So it could be a nerve palsy, ulnar nerve, median palsy. We've seen it with those sort of low and high nerve palsies. Median nerve, it could be Volkmann's ischemic contracture. It could be leprosy, Hansen's disease. It could be a failure to splint following a intrinsic plus, following a crush injury. So that's why we split them in that intrinsic plus position. It could be a Charcot-Marie tooth. It could be a compartment syndrome. So there's lots of different causes, okay? One question people say to me is, well, Rishi, okay, so why do they have a clawed position if EDC is still working? Why is it clawed if EDC is still working?
Already been contracted to extend the MCP. So.
Yeah, but it's actually, the EDCs are actually not very significant at the IP joints. And that's why I wanted to, my point I said earlier, EDC acts mainly at the MCP joints. It has very little action at the IP joints, okay? So that puts it into proof. So if they say to you, what's the main function of EDC? You would say it's an extender of the MCP joint. An example of this would be a claw hand, because you would not expect clawing if it was a strong extensor of the IP joints. Does that make sense, guys? Okay, good. And again, a provocative test basically is if you bring the MCP joint out of hyperextension, the flexion deformity at the IP joint will correct. Okay, so how are you going to treat this? You can treat it by contracture release and also a passive tenodesis or active tendon transfer. And your goal is to act before they get the MCP joint hyperextension. That's what you want to prevent. Okay. The last one I want to talk about is a lumbrical plus. And this is a paradoxical extension of the IP joints while the person's trying to flex their fingers. So they're trying to flex it, but the finger's going up, okay? I won't be rude and show you for the middle finger, okay? But If you want to remember it, it's kind of like giving someone the finger, all right? And that's the most common site for it to occur, is the middle finger. But I won't do that to the delegates, because you'll start throwing things at me, okay? So what's the mechanism of this? Well, basically, go back to what I said in the biomechanics. FDP to 3, 4, and 5, they share a common muscle belly. And they can't independently flex 2 digits without pulling on the third, okay? Does that make sense so far? All right. The index, however, has an independent FDP belly, okay? So what it means is when you try and grip an object or you try and form a fist, 1 digit will stick out or get caught in your clothes. So for example, someone might try and grab a can of Coke and a digit will basically stick out, okay? And the mechanism is because the FDP has been disrupted distal to the origin of the lumbricals. So that's the reason why you get this, okay? So it means some sort of transection or avulsion of the FDP, but distal to where it's given off the lumbricals. Because remember, the lumbricals come off the FDP, okay? Or it might be that you've amputated the DIP joint, or you've used a tendon graft, which is too long. So what that means is, if you've got a laceration of the FDP, okay, when you try and flex your fingers, when you try and contract the FDP, it will send a signal to the lumbricals, okay? Because remember, the lumbricals flex your IP joints and they originate from the FDP. The lumbricals will then pull on the lateral bands, and that will cause your PIP joint and DIP joint to be extended, paradoxically. Does that make sense? Yeah, because your lumbricals are extending these things, all right? So it's an injury distal to the origin of the lumbricals being given off. And that causes a lumbrical plus finger. You try and flex, but one of the fingers is extended. Okay. Slight thing to remember, guys, is, so just remember the first and second lumbricals. This is a bit more complex. I'll just touch on this. The first and second lumbricals, which is supplied by the median nerve, they're unipennate. They have one muscle belly, and they originate from the radial side of FDP2 in the case of the first, or FDP3 in the case of the second. The third and fourth lumbricals, okay, that supply the ring and little finger, they're bipennate. They've got 2 bellies. Okay, so first and second are unipennate, 1 belly. Third and fourth, bipennate, 2 bellies. Okay, the third lumbrical basically originates from FDP 3 and 4, and the fourth lumbrical originates from FDP 4 and 5. Have I still got you at the moment? You still understand that at the moment, okay? So all it means is it comes from 2, whereas 1 and 2 just come from 1. And so what that means is, that's important, because if you cut the FDP to the middle finger, okay, the FDP will shift in an ulnar direction because it's being pulled by another one. Does that make sense? Yeah, because it's like a seesaw, both are pulling on it, all right? So how would you treat this? You can tenodese the FDP to the terminal tendon, or you can reinsert it into the distal phalanx if there's a laceration, basically. Or if the FDP is retracted and you can't fix it, you can do a lumbrical release, okay, to get rid of that sort of extensor tone. You do not transect the lumbricals 1 and 2 if they've also got an ulnar nerve palsy. That's the key thing. So the final thing I want to quickly go through, are we okay for time, Sora? I'm just going to be 5 minutes for. Sorry, I've run us slightly over, okay, is basically biomechanics to the wrist and carpus, okay? And the way to think about this is 2 main rows, all right? The distal row is this one here, and the distal row is relatively rigid, whereas the proximal is more mobile, okay? The proximal's got no tendon attachments. It's relatively mobile, and it's often referred to as an intercalated segment because it sits between the distal radius and ulna and the distal row, okay? And this is where you come on to where you were mentioning before, I'm not sure how to pick up injuries. It's looking at these 2 rows, okay? So what are your theories for how the carpus moves? We don't actually know, but there's lots of different theories. The first is the link theory. And the link theory basically imagines that the radius, lunate, and capitate are like a chain, okay? So you often see a lateral view on a radiograph, and people say it's like a cup and an apple in a saucer, essentially, okay? So radius, lunate, capitate are in a chain, and they think of this capitate as being the center of rotation. So that's the link theory of how the carpus moves. The next one is the row theory, which basically says that you've got 2 rows, a distal row, which is relatively fixed, a mobile row, which is relatively, mobile proximal row, relatively mobile. And the scaphoid is the bridge across the 2 rows. Okay, so that would be your scaphoid, lunate, and triquetrum, relatively mobile, and your distal row trapezium, trapezoid, capitate, hamate, relatively rigid. But the scaphoid is a connecting bridge, okay? And that's important, guys, because if that theory, if that connection is broken in some ways, then you might get pathology. I'll come on to that in a second. The column theory basically states that there are 3 columns, okay? So it says that there's a medial or ulnar column, which you can't see very well on this picture here. But basically that's responsible for rotation, and it consists of the triquetrum and distal carpal row. The central bit, this bit in red, is responsible for flexion and extension, and that consists of the lunate, capitate, and hamate. And then the radial or lateral column consists of the scaphoid, trapezium, and trapezoid, where the center of rotation is the scaphoid, and that's relatively mobile. And that kind of explains why we see STT arthritis, this column theory, because those 3 kind of go together, okay? So how is this wrist stabilized? We've talked about how it moves, but how it's actually stabilized. Well, think about extrinsic ligaments that run from the radius or ulnar to the carpus, and intrinsic ligaments that run between the carpal ligaments. And the extrinsic ligaments can be broken up into the volar, which are the stronger ones, or the dorsal ones, which are relatively weak, okay? The dorsal, weaker, I should say. They're not weak, but they're weaker. The volar ones are stronger, okay? So basically, let's start with the, I'll come on to the dorsal in a second. Let's start with the volar ones, the stronger ones. You've got the radioscapholunate ligaments, okay? You've got the long and short radiolunate ligaments. You've got the ulnocapitate ligaments, and you've got the radial collateral ligaments. And you may be asked those probably in part 1, okay? The key point is the apex of these ligaments is on either the capitate or lunate. Radioscapholunate runs from the radius to the capitate and wraps around the scaphoid, whereas radial collateral runs from the radius to the scaphoid, okay? You've got the extrinsic or dorsal ligaments, and these basically run from the radius to the distal carpal bones in a distal ulnar direction. And there's the radioscaphoid, radiolunate, radiotriquetral, and dorsal intercarpal. What do I want you guys to know for the exam? I want you to know that basically these are sort of arranged as 2 Vs, okay? So the dorsal is 1 V, and the volar is another V, okay? So that's the way to think of it. There's 2 Vs. Okay, and that's important, guys, because when you do a dorsal approach to the carpus, we try and preserve these ligaments by basically doing a trapezoidal type retinacular flap, which you may have all heard of, called a Berger's flap. You guys heard of that, yeah? And you're trying to preserve these ligaments. That's why you do a Berger's flap. Okay, so what's the relevance of this clinically? Well, the relevance is I've talked about there's these 2 Vs. Between the 2 Vs, there's a relative point of weakness, okay, which becomes more prominent in dorsiflexion and disappears in palmaflexion. And that is where the lunate can sometimes be dislocated into, called the space of Poirier, okay? And that's a common thing that comes up in the exam. The intrinsic ligaments, basically, they are the ones between the carpal bones, and they're tight in the distal row, they're loose in the proximal row, and the only ones I want you to know for the exam are the scapholunate and lunotriquetral ligaments, okay? So the thing to remember, guys, this is my buzzword I use for the exam, and I want you to remember it. The lunate is a torque converter. That's the way it works, buzzword, torque converter. It transmits a flexor force from the scaphoid and an extensor force from the triquetrum. So when you radially deviate or dorsiflex, the scaphoid will flex to get out of the way, to give you more movement. So the distal radius can directly contact the trapezium. When you ulnar deviate or flex, the scaphoid will extend. Does that make sense? So scaphoid flexes in that position, radial deviation. It extends in ulnar deviation. That's an important point to know. Okay, and the lunate will go with it normally. Okay, because of those intrinsic ligaments. So it's a torque converter. So that's what happens in normal anatomy. What happens when things go wrong? And I call that uncoupling. The chain is broken. So the lunate, the way to think of it is as a seesaw. The lunate goes with the intact part of the chain, okay? So basically, and that will give rise to the instability after which it's named. So for example, in a scapholunate injury, or a scaphoid non-union, if the chain is broken, the lunate will go with the triquetrum, because that's the intact part of the chain. So this time, when you radially deviate, the scaphoid what's going to happen? The scaphoid will flex, but the lunate will extend. So as a result, the scapholunate angle will become bigger, giving rise to a dissi deformity. Scapholunate angle greater than 60 degrees. Easy. You don't have to memorize this. You can work it out. Okay. Opposite side, if you get a lunar triquetral and a radio triquetral dorsal ligament injury, this time you've got no extensor force. So this time what happens is basically the scapholunate angle goes down and you get a visci deformity. That's all that's happened. It's going with the intact part of the chain. So this time the lunate will go with the scaphoid rather than going with the triquetral. Okay, and then final thing to say is wrist motions, you've got flexion, extension, radial ulnar deviation, and the main functional movement of the wrist, I want you to remember for the exam, is dart thrower's motion, which is a composite movement consisting of radial deviation and dorsiflexion, going to palmar deviation and ulnar flexion. Sorry. No, so dorsal, so extension and radial deviation goes to flexion, ulnar deviation. That's what dart thrower's motion is. So that's the main functional motion in the wrist. Last thing I'm going to touch on, I'm just going to mention it. There's 4 types of instability that you see in the hand of wrist. CID, which is carpal instability dissociative. CIND, which is carpal instability non-dissociative. CIA, which is carpal instability adaptive. And CIC, which is complex. Carpal instability dissociative is the one that I've just mentioned, where you get a break in the chain, leading to a disci or a visci. Carpal instability non-dissociative is this time where you get instability between the rows, okay? So either radiocarpal between the radius and the proximal row, or mid-carpal between the proximal and distal row. Carpal instability adaptive is where some sort of problem outside the wrist causes a carpal malalignment. So for example, a malunion from a distal radius fracture causes a compensatory carpal malalignment. It adapts. And finally, carpal instability complex is your so-called lunate and perilunate dislocation, which is kind of a mixture of all of them. Thank you, guys. Sorry, I went slightly over there. Great.
I will hand over to Hitesh.
Hi.
Hi. Do you have any questions for Rishi?
Yeah, Rishi. Rishi, can you explain about ulnar paradox?
No, but I'm going to come on to that with the, I'm talking about nerve injuries later, so I will be coming on to that, Hitesh.
Okay, fine. Maybe the when you spoke,
But I can mention it.
The delegates. Yeah. Can you see me, guys?
Okay.
Let me. I'm just going to enlarge you a second, Hitesh. Sorry, 1 second.
We can hear your sweet.
I can see you now. I can see you now, Hitesh.
Okay, so to the delegates, ulnar paradox is if you have a low ulnar palsy, your deformity appears to be very severe, like this, because basically what happens in claw is the unopposed action of the long flexors. So the flexors are going to be causing a more severe flexion of the 5th and the 4th fingers. But what happens in an ulnar paradox is when you have a high ulnar lesion, the flexion is going to be less because the long flexors as well, especially the FDP, the ulnar FDP is also involved. So in a high ulnar lesion, the deformity is less marked. So that is ulnar paradox. Normally, what do you expect? In a high lesion, the deformity is going to be more severe, but it does not happen. What happens is in a high lesion, the deformity becomes less severe. So that is ulnar paradox. Rishi is going to explain about it later again.
Yeah, so that's brilliant, Hitesh. Thanks. Yeah, so we'll go over that in the nerve injuries bit as well. I'm going to mention that, but thank you very much.
Thanks, Hitesh.
So this is it for us.
Yes, please. Yes.
So my question is there any difference between the claw hand that appears in a nerve injury versus one that appears in Volkmann's ischemic fracture? And is there any clinical tests that you would do?
It shouldn't be, because again, if you think about it, anything which causes damage to the intrinsics, okay, is going to give you that appearance of a flexed IP joints and extended MCP joints, because you've lost the ability to flex the MCP joints and extend the IP joints. So the appearance should be the same. The only thing I was going to say is with a high or a low, no, the appearance, I mean, is there anything else? Would you be able to distinguish any test between whether the injury is from Volkmann's ischemic contracture or if it's from a nerve injury?
Nerve injury, sorry, I was not listening to the question and the answer, so I don't know what Dr.
No,
Rishi said.
yeah.
Nerve injury is because tendon length remains the same, so you can work on that
So
principle.
passively it should be able to move. Yeah.
Yeah.
Yes,
Volkmann's will not.
passively you should be able to correct it because the actual length is the same. It's just not working, whereas with an ischemic contracture, it should be.
Volkmann's posture will be different, so many things, you know. You do MRI, it will be different. So many ways you can differentiate.
But yeah, you're going on the holistic picture, so you'd also be going on what the history is, you'll be going on other investigations and things like that, rather than one specific clinical test. But you're right, it's a good question, because the appearance-wise, it will look very similar.
They asked about this scapulonate, pre-dynamic, dynamic, and static scapulonate injuries. Is there any difference? You need to know this in the SBA book. They talk about this pre-dynamic, dynamic, and static.
I think that's quite advanced for the exam. I've not seen that in the real thing.
The reason they have put it to you, maybe you're doing very well.
No.
With scapulae, sometimes, so there are intrinsic, is it okay if I take this question?
Please take it. Yeah.
So there is intrinsic ligament, there are extrinsic ligaments. Sometimes you may not have damage to both. So if you've only got damage to interosseous ligament, scaphounate ligament, on an X-ray, there is no disease. Scaphounate will almost look sick, sort of will not be classical signs and not be classical disease. So these are very subtle scaphounate injuries. Yeah. So if you're not, so patient comes to you, they will have swelling radii and pain radii. You will obviously think of a scaphoid fracture. You've seen it at week 1, week 3, you've done MRI, everything is normal. Patient still has pain. So sometimes at junior level, even at whichever level, you discharge the patient saying it's a soft tissue injury. So these are young men. Yes. So they have high pain thresholds, they get on with their lives, but the pain continues. They carry on, pain continues. So what happens eventually? Attritional rupture starts. The extrinsic ligament, which Rishi just showed you that V and back, will start going. And then at some stage, 3 months, 6 months, 9 months, whenever, depending on the force and the work, once the attritional rupture has happened, it goes into disease. Well, patient doesn't know, and he still carries on. And then he comes 5 years or 7 years later with slack. So these are subtle scaphounate injuries, which you need to have a very low threshold of thinking. And then even either do a clenched fist view and keep an or do an MR arthrogram. So those are pre-dynamic and dynamic. So this becomes a dynamic test. So that's the difference they're trying to make. It's a bit higher order thinking. We shouldn't be asking you, but I have one slide in my carpal instability just for completeness sake. This is what they meant. Does that make sense, guys? Morning, Hitesh.
Hi, Saurabh.
Hi, how are you?
Online.
Yes, pleasure. Pleasure is all mine, Hitesh. And thank you for supporting us. And morning to everyone in India and morning all. I think I know half of you, other half I've met during coffee break. And a big thank you to Ms. Raichar. She's from King's College. She's specially come and especially to correct my mistakes, as she's always done. I was a fellow at King's for 3 years, so I learned a lot from her. So big thank you to Ms. Raichar. And I'm going to just now load my presentation. So I'm going to talk about approaches now, hand and wrist approaches. As Rishi was saying, it is very important to ask questions. Yeah? I'm a 6th-year consultant. I still do not know how to give a local in carpal tunnel. I'm still learning. Yeah. So there's nothing like a silly question. Whatever comes to your mind, please ask. Good thing with less candidates is Ines is here, I'm here, Rishi is here, Hitesh is, you've got so many people. So please ask your question. Yeah. This is not a formal sort of a course. It's more talking, discussions, learning from each other. Yeah.
Can we tell an exam like lumbricals plus? Is it overactivity of lumbricals or just the counter force is not acting?
Lumbrical plus is when lumbricals are, they start acting because of FDP rupture distal to lumbrical origin basically.
Okay, perfect. Yeah. Yes. No, but I can't hear what you guys are speaking. No. No, I can't hear from the laptop actually. One second.
Then opposing,
Can you hear?
I know this patient is tendon transfer.
Hello?
Teaching
That's
my-
all. So if you see a tendon transfer in a patient,
No, you can start the PPT.
a tendon, either palmar fascia or FDS, so you will see a, so that is why tendon transfer is not done to the opponent's pollicis. It is done to the abductor pollicis brevis, because opposition is a abduction, not opposition is a composite movement. Does it make sense? Yeah. So you see any like a tendon going here to the APP, which is here, MCP joint, then you know you can talk about tendon transfers then. You can talk about why it is done. You can talk about thumb movements. You can talk about splaying. See how much you can bring up into discussion. So if you're given a case of carpal tunnel, this is what you need to know. Yeah. And this is all I think very relevant, simple sort of response. Any questions on carpal tunnel?
Extended carpet tunnel.
Extended carpal tunnel approach can be done for many reasons, and one of the reasons is the recurrence. Yes, so then you need to go up, then you need to do a GA, and basically you release the nerve. Why does the recurrence happen? Problem is distal or proximal? Proximal. Okay, so it's never distal, it's proximal. Yeah? So that's why you put have to put the proximal up. You release it. Some people talk about hypothema fat flaps. It is nothing but you take a little fat and you put it. That's the carbon. Extended carpal tunnel approach will do for you. You get dislocation basically. So those are the two things you do it very commonly for.
Do you do routine nerve conduction study for carpal?
I would do it for medical legal purposes. For the reason we
For
just said.
exam purpose?
Yes, you should. Because from moderate to severe, if the relief is not complete, patient may say, we haven't done a good job. When you repeat the nerve conduction, show them the current is flowing better. So patient is satisfied and no medical leak recover. So yes, I would do. I will do it in a very elderly 10 medical issues, why bother them? But then I make sure they're on the same page and they agree that numbness will not. For exam purposes, yes, you do it.
If the patient has severe pain, carpal tunnel symptoms, but the clinical exam is okay, but the nerve conduction study, somehow he got a nerve conduction study which shows severe carpal tunnel syndrome.
Yeah.
I can still offer them non-operative plan, isn't it?
A non-operative.
Yeah.
So see, moment you start losing muscles, that means we are already a bit late. That means there's scar tissue forming in the nerve, any nerve in the body.
Yeah.
So then you should actually jump and operate on the patient, because otherwise muscle wasting will continue to happen. In a mild carpal tunnel, it's up to you. Try stents, try steroids, try operation. If the nerve conduction is normal, but patient still has symptoms, I would send them for an ultrasound to see the texture of the nerve with a view to give steroid, to see if it's helping. If the steroid helps and takes away the symptoms, the patient is not waking up this night, then I'll offer them surgery, eventually, if steroids help them. Yeah. If accidentally I go distal, like I'm releasing the transverse carpal tunnel and I go distal, which branch will get damaged, superficial or deep palmar arch?
Superficial.
Deep palmar.
Okay, so let's have a show of hands. Before that, so cardinal Kaplan's line is here. Do we all agree?
Yes.
So where is the deep palmar arch in reference to my cardinal Kaplan's line? On the line, distal to line, proximal to line. And where is the superficial palmar arch? Huh? Distal and further distal.
Yeah.
Okay, so deep palmar arch is roughly at the level of the line, roughly, let's say. So superficial is a centimeter distance. The superficial is far away from my incision. Do we all agree? And deep is closer. Muti, you stay quiet. Deep is closer. Because he knows the
Because
other.
I know, yeah.
Because I thought. So now show of hands. So deep is closer, superficial is away. Show of hands, if I go distally with my scissors, which arch will go, deep or superficial? So deep for deep first, show of hands. 1, 2, 3, 4, 5. And superficial show of hands. 1, 2, 3, 4. And can't make up my mind, show of hands. So more hands are for deep, right? Deep arch. Deep means what? It is deeper to the tendons. So to cut all the 9 tendons to cut the arch. That's why you never cut the deep arch. That's why it's always a superficial arch. Okay. So it's such a simple thing, but these are the things I'll ask. Why am I asking this question? So if I'm doing it under a tunique and you've not taken it off, and you've done a beautiful dressing, patient will keep bleeding compartments. So if this you took a tunique off and now it's bleeding profusely, so you know superficial arch is gone. So what will you do?
Inflate the tunique, extend the incident distally, and
And
then
just like it. Simple as that. Okay. So next time when you're doing a duplitrons and you are into that region, see the superficial arch, how it looks, or in a cadaver. So next time, if that happens, it can happen practically. And you can extend the incision and ligate it. Doesn't matter. No way this works. It's an artery. It's going to spasm anyway, but ligate it. So these are the things they'll ask you about. Yeah. Not the variation of motor branch, even that is important, but like these are practical points. These things will tell you are a thinking surgeon. Yeah.
Just last question about CTF steroids. How long does it last, and what number do we normally give? Like when you consensus to say it lasts like for 1 year.
Steroid, you can give a
20%
steroid injection every 4 months. How long does it last? How long is a piece of string? Nobody knows. As body reacts, it may work for a few weeks, few months, 1 year, maybe curative. Yeah. How much do you get? 40 milligrams of depot, small dose, 40 milligrams depot.
Is there a figure for exam that we need to quote, or is there it's controversial?
I'm not keen on those. Those are theory things you can learn and do. I'm keen on practical things. If I give you a license to be a day one consultant, how will you supervise your rate? What are you worried about? What do you think? Consenting. What are you telling patient? Those things are important. Okay, good. So let's start anatomy and surgical approaches. You know, how does this move actually, cursor? Like this. Yes. So common approaches, I've told you, these are the ones we're going to talk. So volar approach. Again, I'm going to touch on practical points, not the theory points, because that you can sit and read. So important is modified Henry's approach, fine. It is between FCR and radial artery. Yes. This is the workhorse of a hand and wrist surgeon. Yes. It is extensile. Henry approach is extensile, right from shoulder, right to the wrist. Landmarks, FCRs, palmar crease. I put this here scaphoid tubercle because it's a bony prominence, but I'm sure you can almost always see the FCR, even if wrist is swollen. Sometimes it's a struggle, but you can see it. Incision in line with FCR tendon, we know that. Watershed line, why this is important? Because if your plate goes distal to it, then FPL tendon will rub on it. And I've got slides somewhere in some part of the course today to show you when FPL ruptures, what you do, how do you transfer FDS. So that's why watershed line is important. Yeah, you don't go beyond it. Volar approach. So some of the pictures, it's very easy if you think of it, just 3 steps. So any approach, practically anything, actually, you should break it into steps. So volar approach, according to me, is you see FCR, then you see FPL, then you incise PQ, job done. You're there where you want to be. So this is the sort of incision. That's the FCR tendon. Important is to preserve the sheath. Don't go through the sheath because then FCR can tether to the skin. If FCR tethers to the skin, patient will lose extension. So preserve the sheath. That's important. And then in this picture, what I've shown is I'm retracting FCR. Guys, can you see the FPL with my arrow there? So that's your FPL. And then in this operative picture, that's FCR. This is FPL. You can see the muscle belly. And now you've started to see PQ. There's nothing more there. Obviously, you're aware of where radial artery is. Now, PQ is there. Question to you guys. Where does PQ? So PQ can come off radial border, ulnar border, or mid substance. Show of hands, who will take it off from the ulnar border? 1. Ulnar border here. 2. Show of hands, who will take mid substance? Or who will take from radial border? All those people who have said radial border, why?
Because the pharmacogenous branch
You
of
were there last time, I think we were talking. Pharmacogenous, sorry, go on.
pharmacogenous branch of that begin rises about 5 centimeter approximately on the wrist and
On the radial side.
on the radial side. So
that's the reason you want to go further away.
yeah, so
Okay.
under incision of the plus.
Sure. Any other thoughts?
I think if we have to extend the incision towards the extended FCR approach, it's better to release from the radial border.
But PQ is a deep muscle. It's got nothing to do with my skin incision.
No, extended FCR, if we have to go slightly dorsal, if we have to release the first compartment.
If I have to release the first one, if I don't have to.
Still, I will go with the radial border.
Okay. Any other thoughts?
Cover the plate, try and cover the plate, reduce injury to the
Release of ulnar border. Any other thoughts? I discussed about covering
So
breaking my
release.
tips and tricks.
So
Always knows I've done 100 times with you.
in terms of release from radial border,
What's the nerve supply for PQ? AIN will come from anterior introitious. It's sitting on the introitious membrane, do we agree? So it will be coming halfway there. Yes. Ulnar radius. So the nerve supply to PQ is from the introitious membrane. So if I cut from the ulnar side, I'm denervating all this muscle. So it has to come from the radial side because of nerve supply reasons. Yeah. Simple thing, but important. Yeah. So once you've taken off PQ, you can put whichever plate you want to put. Yeah. Plate coverage and all this will come in tips and tricks. I'll discuss all of it. Yeah. So volar approach is just this much. But what is more important in volar approach is this slide. Yeah, this is the take-home message. Preserve FCR sheath, we've discussed why. Incise PQ from radial side, we've discussed why. Remind me later, I'll draw some line diagrams for you for half an hour to discuss a bit more about slack, snack, all this. Choice of plate. Why have I said that? I've said it, I say things sometimes. Choice of plate, obviously it is important in relevance to, I may have put it with watershed line. So what happens is plate, if you see, compare these two accurate plates, or whichever you have, the angle which comes out of plate. So if this is the plate on a lateral view and my screws are in this direction, plate has to sit a bit proximally. If my angle is like this, plate can go more distal, isn't it? Because it will not go to the joint. The choice of plate is important. And then, so it is not as if every plate has to sit right next to watershed line. Remember that. Yeah? For example, those of you who use Acumet plates, the silver plates angle are a bit more acute. Golden plates are a bit more obtuse. So plate can sit wherever. Yeah. Release brachioradialis from radial styloid. Why that is important? If there is a radial translation, you release BR to allow radial styloid to come back. Yes. So that's why it is important. Screws in the lunate fossa fragment first. Very, very important. So your key corner, and I've got some, I'll show you, is either the volar ulnar corner or dorsal ulnar. So ulnar corner of radius is important. Because if this corner collapses, then you have positive ulnar variance. You will have ulnocarpal abutment. So those of you who want to do an audit, bring out last 50 radial plates. I can promise you in 10, it would have collapsed. So this is the key corner. I see a lot of reference from my learning colleagues where this has collapsed and then I have to do osteotomies or whatever. You have to do something. So that's the key. So your screw should go there first. Yeah. And plate as an indirect reduction tool. I'll show you in my dorsal plating what I mean by that. And attach, you were talking about attaching PQ. I can ask this question. How many of you leave it?
Attach just the lower part.
You know that I'll show you. You attach it. Okay, why?
To cover the plate.
Okay, why do you want to cover the plate? Why is always important in life?
Prevent any injury to the field.
Elaborate. Maybe right. Maybe wrong. So why is important? So I don't have a picture, but I've shown it to Kiran in day surgery. So see, PQ is like this. Correct? Do we all agree? Once I've taken it off, we all know realistically it's very hard to attach it where it belongs. It's shredded. So what I do is I swing it. Yes. And even if it can come to the mid part of the plate, I attach it to the volar rim. So FPL, if you see next time, ask your consultant to show you, when you put a plate, FPL is right in the middle of radius, in the middle of the plate. That's where it ruptures. So if I can put something between plate and FPL there in the middle, chances are it won't rupture. But there's nothing to rub on. So that's where you swing and attach it to. And of course, it's a valuable infection. You can argue it like that, but that's the reason. Yeah. So attach it to the volar rim. So these are the few tips and tricks in your volar plating, even in day-to-day practice. So if you are ever shown a volar plate X-rays, bring these points up for discussion.
And plate now with the FPL run in between.
So Medartis, you are from Medway, Milindo, I know. So this is the reason they brought out that thing, that there is a gap in the middle of the plate because FPL goes right from there. So this is how surgeons design plate. So once you understand anatomy, you can design your own plates. There's no big thing about it. This is how orthopedics keep evolving. You see the complications, you design your plates.
Do you repair the FCR sheet?
I never incise it. If you incise it, there's hardly anything left to repair actually. So you don't incise it. You go just next to it. Yeah.
Henry's approach is between radial artery and the FCR, and that now we use the FCR base approach. But the Henry is if you extend the Henry's approach, proximally we can't go because radial artery crosses that our.
So proximally, how Henry described it, he said proximally radial artery and nerve.
Yeah.
In between. Okay. But as you come distal, it's a modified. So it becomes artery goes lateral.
Lateral one. Right.
Yeah.
Okay.
Makes sense? Okay. So let's go because it was a 20-minute. It's okay. It doesn't matter. Ideas. So structures at risk. So see, this is where we've gone from. And you can see FPL and FCR are protecting your median nerve, Bilindu. So that's why palmar cutaneous, I'm not so concerned. If you've done your good dissection, you've got two big tendons to protect these two nerves. Yeah. Dorsal approach to the wrist. Now, this is very important because at some stage you will be asked, because some of you may not have seen it. And a lot of the wrist work, as you can see, bad distal radius fractures, ligament repairs, parilunates, fusions, partial fusions, replacements, proximal pulls, almost everything is done through dorsal approach. So this approach you need to know. If you've not seen it, go on a cadaver in Hodgkin's building at Guy's, see there. But this approach you need to know because this at some stage will be asked to at least 20-25% of you. So again, operative pictures, once you've done all your who and all that, we're not going to waste time there. On our side table, that's the sort of incision, midline. And then, so dorsal approach, you have to think again in 3 steps, break it in your mind in 3 steps. Skin, retinaculum, capsule. Yeah, nothing more. Skin means every time you cut a skin in upper limb, you make big flaps with fat. Where does the blood supply to skin comes from? Sorry. Take fat with skin, you have good blood supply, good flaps. Also what it does is it protects your cutaneous nerves. Dorsal cutaneous nerve, dorsal cutaneous radial nerve. So next time you see when you make a skin cut, go right up to retinaculum, take a red gauze piece and lift the whole fat up. And the cutaneous nerves will go nicely in the fat. So not only does it heal good, it protects your cutaneous nerve, which is also your internervous plane. So that's your first step to think of. Then radialize EPL. So what I do is, this is my EPL. So this is thumb area, that's little finger. So you take it out. So obviously this is my 4th compartment. That's my 2nd compartment, my arrows. And then you subperiosteally elevate your 4th and 2nd. So can you see 4th? These are 4, 5 EDCs, whichever numbers. And that's the sheath covering them. So when I stick them back at the end of the surgery, they're not going to tether to anything because I preserve subperiosteal and preserve the sheath. So retinaculum taken care of, correct? Finally, do I have capsule? Okay, no. So here, because we're doing distal radius plating, so capsule you don't need to take off, right? Now, this is important. So you have to reduce the articular. So dorsal approach will be done for marked dorsal combination, correct? So once you've done this, you need to reduce the articular surface. Can you see me using this little periosteal elevator to jack up that dorsal ulnar corner? Yes. So my variance is neutral. Then I've used a K-wire in this case to maintain these fragments so that they don't fall back. You can even advance the wire into ulna if you want to. And then what I've done is I put my dorsal plate. That's an Acumet plate. You take any plate, it doesn't matter. Now this is important. Plate to correct the length, tilt and inclination. So radius only has what, 2, 3 things. 3 things you look for. One is shortening of radius, so radius length. One is your dorsal volar tilt, so you need to correct that tilt. One is that radial inclination, isn't it? All 3 you can correct with the plate, whether volar approach or dorsal approach or distal radius malunion. So this is important take-home message. So what I do in my practice, 90% of the times, once I've aligned it, I'll put 3, 4 dorsal screws or volar screws. So once I know I've got a good hold and plate won't back out. Now, if you think carefully, I can use this plate to push forwards there. So I can get the length right. If it was not right, I can push the plate in this direction. Sorry, to get the inclination right, correct? And here you can see this was a difficult fracture. Look at the shaft, how far it is and how much gap is there. But if you imagine if I was to now put a cortical screw, see the shaft will come back. So once I'm happy with my inclination length and my tilt, job done, shaft will come back, correct? So you can use plate as a indirect reduction tool. And obviously always check for prominent screws, because they can irritate the tendon in the front and the back, and you have to go in again to take it out. So lock your screws, and then that's it. That's your plate now. Check for prominent screw. This is me pointing to that prominent screw there. And then see, this is me showing how retinaculum will stitch back up. EPL should always be out. If they ask you, does EPL stay in the retinaculum or out of it? Confidently, you can say 100% cases out. If they ask you why, say already there is a metal there, retinaculum is going to be very tight. If I put EPL inside, it will squeeze EPL. EPL will get synovitis and irritation and pain. So always out. Yeah. And then that's it. Dorsal approach, of course, cutaneous nerves, very important. If they get damaged, I've told you how to protect them. Extrinsic ligaments and tendons, of course, but more important is these cutaneous branches, correct? Because if you get a neuroma, you touch it, they get shock. So, and it's very hard to deal with cutaneous neuromas. So you need to look out for cutaneous nerves. Styloid approach. So I think I've got two approaches here with this example. So let's see the styloid approach first, then I'll show you a relevant example. So styloid approach is here, very seldom done, but just for completeness sake. So first thing will obviously here will be cutaneous radial nerve. So you can see this, me pointing out. Second thing will be this first extensor compartments. We've all done decoherence releases. Yes. So you take the nerve to wherever it wants to go. Tendons will go dorsally. And so see, I'm taking this tendon dorsally. And then third thing to see is brachioradialis. And then you release it proximal to distal, because you've done a styloid approach for a styloid plate. That means brachioradialis was a deforming force. So you release your BR and see, I put a plate. And now this is my first extensor tendons, correct? And that's my volar approach there. So it was a double plating. So styloid approach is easy if they ask you, just 2-3 structures there for description purpose. And this is the example. Who wants to take on this? I'll take you through it, promise. So it's a volar Barton, we know that. Can we see this? CT scan, very comminuted styloid and volar on a corner. I'll show you how. So you can see the whole carpus is falling in the front. And that's lunate, we agree. So this has to be lunate fossa fragment, we agree. So this becomes lunate fossa fragment, volar, ulnar corner, key corner, yes. And then if I show you the axial cuts, this is the styloid area. Can you see how many pieces are there? So I know if I was to put a volar plate and put some styloid screws, normal screws, they will have no purchase, right? I'm only making x-rays look good. So in my mind, I'm thinking, even just looking at the x-ray, that I definitely need a volar plate. It's like a volar Barton. And looking at the axial CTs and my coronal CTs, I need to buttress this styloid. So that's how I decided I need a double plate. And yeah, so what I've done is I've put a, have I got a, no, I don't. Okay, yeah. So tips and tricks. So see, problem in this is when I take my carpus back, it'll keep falling back. Sometimes it's not that easy. So your first tip can be, beg your pardon, why not put 2 wires from the dorsum to hold the carpus onto the radius? So once carpus is sitting on the radius, I can peacefully work from the volar side, can't I? So what I've done is I put a lunate fossa fragment plate. Then I've done a styloid approach and put a styloid plate. Yeah, makes sense. And you can see how comminuted my styloid is. So do you agree it needed a double plating? Yeah. So in the exam, if you're shown a radius, ask for your axial cuts, ask for your coronal cuts, sagittal cuts. And I've got lots of double and triple plating x-rays later in the upper limb trauma, and we'll go through a bit more detail, as well. I'll be here for 1 hour. But this is how you work in your mind. Yeah, that's very important. But other little important thing here is this fragment, you need to have some screws. But remember, radius has a sigmoid notch and an ulnar head. So like your tibial play fawn, screws can come in this concavity. Yes. Equally, if I'm far away, I'm not holding the fragment. So this is one fragment which gives me maximum grief in my practice from my colleagues and from me myself also. So to get that balance right is not easy on table. So that's where you need to pay attention to in your radius platings. I'm sure your consultants have shown this to you many times. Direct approach to ulna, easy. Internervous plane is FCU in the front, ECU behind. You've all done these platings. Just be aware of dorsal cutaneous ulnar nerve. Remember, if you put a plate at the back, you may have to take it out as prominent. So you may want to put it in the front. Then you have to elevate FCU, be aware of ulnar artery and nerve. And that's just about it, actually. Can be done for ulnar shortening, osteotomy, or ulnar fractures. Correct? Any questions so far?
Can you approach?
For radius plating,
Yeah.
I have one X-ray later in the day. I'll show you triple plating.
And
Just for you, Mufi.
Yeah, watershed. To follow the watershed.
Watershed, Mufi, as I said, it depends on the choice of your plate. So you don't try and go beyond watershed line.
Is it for volar or volar and dorsal?
Volar.
Only volar.
Dorsal, I use, well, dorsal again, it depends on the plates. If you're using Acumet plate, you have to go right to the dorsal rim actually. If you're using Medartis plate, you're a bit proximal. So it's choice of plate. Every plate works different, like every hip replacement works different, every hemi works different. But as a rule, you don't go beyond watershed line.
Okay, so watershed is not an indicator also your screws not penetrate in the joint. You said about FPA.
I can design a plate which goes further beyond, but screws are at this angle, then it will never go into the joint. Designing a plate, yeah? So then let's go to the volar approach to scaphoid. So let's see an example to discuss this approach. VW, Volkswagen, yeah? W waist, scaphoid, V volar approach. Whichever way you remember, I remember it like that. So 24, young men, hyperextension injury, scaphoid. Moment you see cis in scaphoid, it's a non-union, like geodes in your hip. So scaphoid is an intra-articular fracture. So as you clench fist, you force the synovial fluid into the fracture line, like in your hip. When synovial fluid forces into the fracture line, it will create cyst. It will start going up and down on both sides of fracture line. So moment you see cyst, it's very easy. Just say it's a non-union. Yeah. So this is a non-union. So I've done a volar approach. That's the kind of approach. So that's the kind of incision. Yes. Curved, centered on scaphoid tubercle. And I've exposed the scaphoid. And once you carrot it out, this is the kind of gap. Let's say 1 centimeter by 5 millimeter. Then you expose your radius, you know how now. Take out corticocancellous chips. And now key is in the second picture. You put your wire first where your screw will go. Like as if you're doing an acute scaphoid. Check it in all your 4 views. And once you're happy with the wire, only then do you start. That's good actually. Thanks. Only then do you pack it with graft. The reason being, if I put the graft first and then start putting wire, and I may need 4 attempts, 5 attempts, then the graft will all disperse out. So key is wire first, then graft. Other little key is thin cortical piece, a thin cortical piece. The reason being, we know how bone will form. First, the graft will resorb, then new bone is laid down. So cancellous graft will resolve faster, cortical takes time. So thin cortical piece. Yeah. The reason I'm stressing all this is eventually they will all come on videos. And when you read it again or listen to the conversations, the lectures, it'll all come back to you. So that's why stressing it. So, and then there's nothing, once you packed it up, just close it. Yeah. Make sense? So scaphoid has only one ligament, radioscaphocapitate, which Rishi spoke about. You don't see it as a thickening of capsule. You just make 2 good flaps. And when you close the flaps, the ligament heals up, like in your dorsal approach or any approach in the body. Yeah, make sense? Any questions on scaphoid? It's a huge topic. I have a lecture on my YouTube and also on orthopedic principles, 1-hour lecture. You can see it and make your sort of, otherwise will not finish. Proximal pole, dorsal approach. Again, young man, hyperextension injury. This is the sort of dorsal approach we do. So dorsal approach, I told you 3 steps, isn't it? Skin, retinaculum, capsule. Skin is easy, you know that. Retina. So in a proximal pole, you only need 1.5 cm, 2 centimeter incision. So you will not see the proper retinaculum cut and all that. But if you see carefully, I've got a bit of retinaculum here. Can you see this is the retinaculum? Yeah, 7-8 millimeters or whatever you need. Yeah, so that's your skin and retinaculum. And then you start seeing EPL. You always see EPL in a retinaculum. I've taken EPL to one side. And then I've just cut little capsule like a modified Mayo flap. So you don't need a big burger flap. You just cut capsule transversely and retract it. And you will start seeing this proximal pole. This is me pointing the proximal pole. And then you completely palmar flex the wrist. And that's how you can put the, so when you palmar flex, look at this picture, the proximal pole of scaphoid comes out. It is hiding under radius. Once it comes out, that's the blue dot, which is very close to the scapholunate ligament. That's your entry point. And that's when you put your wire. So you put your wire from there and aim towards the tubercle. And do your 4 views. And then you put your screws. So you can clearly see here when I'm palmar flexing in this picture, that's the entry point. If you are extended, you can't put the screw. Yeah, simple. So every dorsal approach is 3 steps. How much you cut your retinaculum and capsule varies. Then I think it's the last few slides. This is for phalanx. So Ms. Reichert and I did this case, I think few weeks back. So if you are shown an enchondroma, and I've got some X-ray pictures, so I'll get one of you to describe it. But this is just MRI. So I give it to you. This is enchondroma. There's no periostal reaction. It's all localized. So this is enchondroma. We agree is sort of destroying the joint also a bit. So obviously you need to excise it, incurettage it, and put a graft, isn't it? So midline approach. So for phalanx, you can go either side of tendon. For exam purpose, learn one approach, which is easy. That I'll go right through the mid of the tendon, extensor tendon, because otherwise you have lateral band. You need to balance those. It becomes an issue. So go straight through the tendon and stitch it back up. Yeah. So what I'm showing here is, can you see this is the extensor tendon which I've cut? So extensor tendon, that's the MCP joint. He also had grade 4 MCPJ OA. So Ms. Reichert will do MCPJ replacement in the future. But what we have done is, that's the phalanx, MCP joint, grade 4 MCP head. Made a window, taken out all the enchondroma. And then I promise you, this is not phalanx, where you can see the muscles. So this is distal radius dorsum, taken graft. You can see distal radius graft, packed it up, stitched it up. Okay. We'll see how it heals up in 3-4 months. And that's the end of it. Thank you for your kind attention. Any questions? Yes. Right through the middle and then stitch it back up. It's easy indeed. See, it's not fair. There's so much to learn. And examiners will ask you 3 dynamic and static. It's a bit, so the simpler you can keep it, the easier it is for you. If you start going on one side, you say, what will happen to the lateral bands? How do you balance it? You say, what do I do? I'll just stitch it up. What do you mean balance it? But they can ask you anything. It's easy to ask, isn't it?
Even the finger is just
Through a whole finger middle. 5 by middle. So it's all middle. Then it becomes easy.
Saurabh?
Yes,
Saurabh, can you hear me?
Yeah, I can hear you, Hitesh.
Saurabh, can I ask a question to the delegates?
Yes, please do.
Okay, so all of you have seen some fantastic X-rays by Saurabh. He does such great surgeries on the wrist, distal radius. So, and many of times you've seen plates specifically designed for either the lateral side or the intermediate side or the dorsal. So my question is, what is the column concept of the distal radius? Can anyone tell me? Is there a column concept for the distal radius?
Yes. And so lunate, scaphoid and ulna. So you have to.
So Hitesh Milindu is answering. He said there are 3 columns.
Yes.
There's 2 columns, a radial column, a intermediate column, and there's a ulna column. And then carry on, Milindu.
So, I mean, as you said, the ulnar corner of the radius, which is the lunate fossa region. That's the most important one. And I know about 60% of the weight forces transfers through the it's the radius. So
Correct.
that's very important in correcting that.
Correct. So what
Okay,
he's
great.
saying,
So basically there's a radial column which has the radial half of the distal radius, and there's an intermediate column which has the ulnar half of the distal radius, and there's a ulnar-most part which is the distal ulna and the TFCC. So basically 3 columns. Okay, and this was first this idea came out by Rickley and Regazzoni, and it was a paper published in JBJS 1996, so almost 25 years ago. So this revolutionized the concept of, I mean, it brought into this column concept in fractures. Okay, what are the other areas which is now trending where you have the column concept? Column concept.
Maybe the elbow, foot.
Okay, elbow, it's exactly where exactly? It's the coronoid, right? It's the Wrightington classification.
Yes.
Okay, and what is a famous Chinese surgeon who came out with that tibial plateau classification?
Low.
Yes. So that is again Kong Fen Luo. Okay, Kong Fen Luo from Shanghai came out with this column classification. So you know now 3, and every day, I mean, people have started thinking about a column concept for whichever fractures they start fixing. So now very popular ones are this one, Rickley Regazzoni for the wrist, and Wrightington for the coronoid, and Kong Fen Luo's classification for the tibial plateau. Over to you, Saurabh.
thank you, Hitesh. That's very educational. Thank you very much. Perfect. Thanks, guys. I'll pass it on to my colleague Rishi. Sure. So while Rishi comes, guys, the last approach is Wagner, so trapezium. I think you can do 2 ways. I do a straightforward incision of trapezium. Wagner is lift off of the thenar muscles, and then obviously, so if you're looking, so your APL will tell you which is the base of your metacarpal APL tendon. So just proximal to it is trapezium.
Don't worry, my leg.
It's coming. Nice flaps. On, and then just take off the trapezium.
Trapezium on the.
You can do dorsal Wagners also. Dorsal Wagners.
Rishi, I'll give you the USB. Just take all of it.
Then you always watch the dorsal carpal drawn.
Yeah.
They are never exsanguinate because the vessel stimulation volume. You would see protected. You need to do a thumb replacement with the stride chart in conjunction and use that approach. So there are lots of examples of this approach later in the day. Whichever way you wish to go. Anything you want to add in terms of the thumb replacement? Take approval for the box.
In this dorsal approach to the wrist, sometimes they ask about this Burgess flap.
Yes.
What is the
Burgess flap? I'll show you. I have lots of examples for this orthogenesis. Then I can show you. Easy to explain with the slide. So, Burger flap is nothing. Once you visualize your dorsal ligament, they are in V shape sitting on the tricuptum. So, if I can make a big flap which encompasses those ligaments, so not damaging those, radial based. That's a Burgess flap. Obviously, in the exam, you will be shown a flap going next to the. Like, idea is to make a capsular flap, radial base, which has the dorsal ligaments, so that you're not damaging those. That's a Burgess flap. I'll show you those flaps. I'm not very school in my dissections. Any other questions while Rishi is loading up his presentation?
Finger incisions, one incision.
Mid-axis are hard if they ask you to pick it up, where the skin increases. And otherwise, I do most of the Jupiter with runners. Again, I have Jupiter dissections, operative dissections with runners with Z class teach. I show those people. Runners, yeah. I do runners.
Any questions about Bruno's that they asked in the exam?
So Rishi will be talking to you about Dugatron, how this is deformity on that. I will show you some digital nerves. Questions will be that will be asked in all sorts of forms. The names, what is the start of what, the relevance of it, how you can deformity, role of spin clock, what's the Z class speed, how you do a Z class speed. And the same thing is important to Dugatron again, digital nerve can versus and then your CAN mechanism in your city, you know CAN mechanism.
That is not
Exactly.
circular.
That's why you always put classes in this position because the length of collateral is longest in this position and shortest there. That's the CAN mechanism. So, and this is the reason in Dugatron because finger is curling up. Collaterals are in your favor. They are actually at natural length. And this is why you get maximum. I should be asking the question. That's why you get complete correction at MCQ. PIP, the length of collateral is the same whether you're fully flexed or extended. Collaterals are not stopping you from getting correction. The bowler blade. Bowler blade goes straight and then you say, well, I may not get it for you. These bowler blade, you can automate it, not automate it, size it, and you get the correction. But they still tend to curl back. So I always release bowler blade. I take a needle and release it. I'll get in fact hyperextension because once you release it, I still want it to curl back a bit. And these are the reasons for it. These are the questions will be asked.
So I think you're doing Harry and complex stability kinetics.
Am I doing that? Oh, sorry. Oh, I'm sorry, Rishi. I thought you were delaying. You went up so deep. I thought Rishi delaying. See how deep I am. Have you noticed?
It's okay. It's probably good because naturally this is a natural break for copies anyway. Nice to meet you.
Guys, let's come to that. We are recording it. Right, guys, so shall we start? Hitesh?
Yeah, Saurabh.
We're just starting in 10 seconds, Hitesh, I'll let you know.
You're presenting, right?
I am presenting, yeah.
Okay.
Oh, carpal instability we are doing, isn't it? Rishi,
Carpal instability. Yeah.
but this is hand and wrist trauma. Arjun, carpal instability. This is hand and wrist trauma, my friend. Sorry. अच्छा ना चेक किया तुमने कुछ बना लिया सिस्टम अपना you're a genius Arjun will you marry me मैं वही तो रिकॉर्ड नहीं हो रहा है होने दे मैं क्या करूं डर के मरना थोड़ी ना शिप्रा को नहीं सुनना चाहिए बस सुनेगी तो कहेगी अर्जुन वहाँ क्या क्या करता है लंदन में
Arjun, I can hear everything, okay?
Oh, so don't record these things, Hitesh. Shipra will listen. Arjun is in trouble.
No worries.
Okay. तो इनको क्वेश्चन रखो यार बेचारों ने कितने पैसे दिए दुख हो रहा है मुझे मुझे भी हो रहा है क्या अभी Very flow.
Hi, Murthy.
Can be warm a little bit. So
Yeah,
I think it's cold.
no, the heater. Oh, heater. I'll do that.
That's okay.
Yeah, I'll just check
But I
the.
ask other people, they say also they are cold.
Yeah, sure, definitely.
Thank you, Murphy. For your 150 pounds, we'll give you blanket also.
Okay.
Right, okay, yes. I didn't even get a chance to see what I've written actually. Okay.
Can you
Yes.
see us?
Hitesh? Hitesh,
Oh, that's fine. I can see you guys. I can hear you guys.
okay, fine. So we're happy to start then. So
Sure.
guys, our next topic is carpal instability and parallel unit injuries. Important topic, confuses us. That's why I asked in the exam, because they can assess a lot of your knowledge. Rishi has very beautifully told us the biomechanics. So I'm going to talk about the practical sort of aspect, if you like. Carpal injuries, isolated carpal bone fractures I've not covered in this talk because of time's sake. So we'll just stick to carpal instability. So pure ligament injuries followed by parallel units. Yeah. Ligament injuries, we need to think of scapholunate, lunotricutal, and parallunate. Intrinsic ligaments and extrinsics. Again, Rishi has told us, intrinsic is between the bones, like scapholunate. Extrinsic is which is bridging carpal bones to metacarpals to radius. Yes, volar and dorsal. So these are your intrinsic ligaments of relevance, scapholunate and lunotricutal. These are your extrinsic ligaments. So as Rishi told us, from the volar side, think of it as two V's, yeah? They're going from radius and lunate, and ulna, beg your pardon, to mostly lunate and capitate, yes? And the space in between is what? Yeah, because ligaments are thickenings of capsule. So wherever there is no ligament, that capsule is weak, space of poiria. This is where lunate comes out basically. Yeah. Extrinsic, centered over tricutum. Clinical relevance. Have you ever seen tricutal avulsion? Common in radius. And have you ever wondered why tricutal avulsion? Because of this reason. Because all the ligaments are on tricutum. So they avulsa, the capsule avulsa is a piece of tricutum. So carpal instability, again, we've discussed. Dissociative is Dissi and Vissi, we know that, yes. Non-dissociative is between carpal rows, which is this. Complex is all those bones and ligaments, you know, all sorts of nasty transcaphoid perilunates or whichever pattern you can think of. Adaptive actually is not instability. It is adapting to something. Classical is when you have a radius malunion, for example, lunate will try and follow your radius. It will extend a lot. So your carpus is adapting to a new environment. That is adaptive, basically. Yeah, it's not a true instability. Before I go on to anything, again, dorsal approach, because all this parilunate work, as we now know from approaches lecture, will be all dorsal. So I have put a lot of dorsal approaches throughout the day so that by the time you go home, you feel comfortable and confident. So again, as I was telling you, first, skin, retinaculum, capsule, 3 steps, nothing more. Skin, good flaps, and you can see the cutaneous nerve. See how it goes in the fat in the flap. And you can see now the retinaculum there. Then in terms of retinaculum, always look for EPL, take it out, radialize it. So that's thumb, radialize it. And see now subperiosteal elevation of 2nd and 4. So you can see this is 4 because you can see lots of tendons. The sheath should cover your compartment 4 tendons so that there's no tethering and there's no adhesions. And then sheath should cover your ECRL, ECRB. Okay. So once I've done that, I've exposed my radius. and someone was asking for a burger flap. I think it was Miraj or yes. So see Miraj, this is the capsule. So look at this picture there, operative picture. You can see the radius now. I can do a dorsal radius plating, but I can't see the carpal bones. So once I take off my capsule, I can start seeing carpal bones. So this is me who's taken off the capsule there. See, yeah, that's thumb. So radial based flap. Yeah. So all my extrinsic ligaments are in this flap. This is your burger flap. And you can now see all the carpal bones. Once you're seeing all the carpal bones, you can do whatever you want to. Total wrist fusion, four corners, scapholunate, RSL, wrist replacements, whatever you want to. You can do your proximal pole of scaphoid also there now. But we don't need such big incisions for those. So you don't want so big dissection. So remember this slide. That's your dorsal approach. Yeah. So now let's go to scapholunate. So again, let's start with an example. No marks for guessing this is scapholunate. Yes. Mention your Madonna or Terry Thomas sign in your whatever sort of disease and all that. But important here is, so let's introduce two concepts. Gilula lines, 3 lines, first through the proximal pole of these 4 bones, second line through the dorsal sort of distal rim of these bones, and third line is through capitate hamate proximal pole. Especially for your parilunate injuries, gilula lines gets disrupted. So always like quick 5 seconds, every wrist x-ray see these lines. Because if these lines are disrupted, you will see the step. Yeah. And the next thing to notice is your scapholunate angle. So you know normal angle is 45 to 60. When lunate will extend and scaphoid will flex, angle will become more than 80. Yeah. So remember, lunate doesn't have its own mind. It will either follow scaphoid or tricutrem. So if I was to have, so we know, so let's say lunotricutrال ligament injury. Yeah. So now lunate is clubbed with scaphoid. It will follow scaphoid. Scaphoid only does one thing in life, flexes. So automatically in lunotricutrál injury, lunate will flex. And the opposite will happen in a scapholunate. Lunate will extend because lunate is now following tricutrem. So this is how I remember. Yeah. Goals of treatment, of course, you want to prevent painful instability. You don't want irreversible. So if you miss it, as we were talking, irreversible collapse of carpus, slack will start happening 3 months or beyond. And then finally OA will happen, slack will happen. Yes. This is what you were asking, Vilendu. Problem is early diagnosis. So let's introduce another concept. Look at this lateral view. That's radius, that's lunate, dotted lines, that's scaphoid. Very important on a lateral X-ray is the relationship of the second line to third line. So your first line is radius, distal surface. Second line is lunate, proximal end. Fourth line is lunate, where lunate finishes, distal end. Third line is this proximal pole of scaphoid. So always from here on, every lateral X-ray to the wrist, look at this relationship. And the relationship is scaphoid proximal pole sits in the lunate, if you like. This line will come here. It will slowly come out. In a band or scapholunate, it will be completely out. In subtle ones also, it will be out. So your PA wrist may look normal, but this X-ray will pick up those subtle scapholunate. Is that okay, Milindu? So if they ask you pre-dynamic and dynamic, you tell them this on top of it. And then they will take a back seat. And of course, be aware of this slack, chronic slack, because slack can be acute or chronic. So always look for arthritis. So if you're shown a scapholunate in an exam, rule out slack, rule out snack, rule out arthritis. Yeah. So slack 1, 2, 3, 4. This I'll draw on a piece of paper and discuss with you once I finish this lecture. Okay. I'll explain to you. I'll make it easy for you. Treatment will be obviously close reduction. For exam purposes, sir, I'm going to open, I'm going to do a dorsal approach, I'm going to do a K-wire, and I'm going to stabilize my ligaments. All right, which we'll discuss how. So let's see an example. Scapholunate injury, 54, fine. So role of wrist arthroscopy. For all my ligament work, I will always put a scope in. Even if it is barn door as a habit, it takes 5 or 10 minutes. Do a dry scope. If it's completely, even if it's grade 4 on an X-ray, on a CT, on an MRI, still you put a scope in, you take pictures, at least you can see chondral damage. If patient is a bit middle-aged or elderly, you can rule out arthritis or diagnose arthritis. So scope is very handy. For example, for lateral J work in shoulder, I would always do a scope. 80% time dry, 20% if I have to debride something, I'll just then start the fluid. So put a scope in. This I felt was 3, not 4, which is fine. And then of course you open dorsally. We know the approach now. And then we do wires and anchors. I think I wanted to, can I take you to the board here for 10 minutes first? Otherwise my lecture is based on that. I should have done that. Hitesh.
Yes, sir.
Hitesh, can you stop the recording for 5-10 minutes? I want to do some slack and snack on a piece of paper, on a chart board.
Okay, of course, not a problem.
Thank you. Can I ask you guys to have a huddle? Thank you, Rishi. Very kind of you, sir. Can I have some lights on also, Arjun, please? Guys, can I ask you to, if you can see from there, fine. Otherwise, you can have come in a huddle. This was important. Sorry, I forgot actually. Thank you. I promise you this is a scientific drawing. I can prove it to you if someone is doubting me. So, guys, can you all see? I think it's better if some of you can come in. So, see, this is your scaphoidal ligament. Do you agree? Yeah, that's radius. Promise. Allah. Now, what happens is, if you think of radius, yeah, you can, it's like a saucer, and let's say this is like a ball. So they're congruous, like a hip joint. If the joints are congruous, hip arthritis or this arthritis will not happen. Now, if scaphoidal ligament goes, what does scaphoid do? Only does one thing. It flexes. The moment it flexes, now it's not a congruous joint, it's an incongruous joint. What will happen to an incongruous joint? Arthritis. So there are no marks for guessing when this is incongruous. Arthritis will start here, isn't it? These are incongruous. So that's your slack one, simple as that. And then this whole thing is incongruous, so arthritis will progress. 2. Now this is incongruous means it is incongruous to capitate also, isn't it? Makes sense? So this will be 3. And remember one more thing, the inner wrist, it is in this direction always. The force goes. Always. So arthritis will go in this pattern, pari-unit will go in this pattern because force transmission is in this pattern. So you can see now 1, 2, so 3 because incongruous, and because arthritis will progress in this pattern, so arthritis has to happen here. 3. And finally, radial unit. Yeah. So someone who was describing it should have said it 4 and 5, and that would have been easy. This is where a lot of registrars get confused. What's the difference between slack and stack? There is no difference because biomechanics doesn't change. The way forces go, arthritis will happen, won't change. Simple as that. So is slack very clear now, guys? Yes. It is very easy to understand once you know this diagram and the scaphoid is incongruous. Now, if you come to think of treatment now, slack 1, styloid arthritis, the scaphoid. What's the treatment? Take it off. Now, only one bare bone, second bare bone gone, job done, isn't it? Easy. Slack 2. All this is arthritic. What will be the treatment? Excisions, open the fusion. Taken the or taken the rough surface array, or you can even do RSL fusion. So once you know this diagram, you can work out the treatment. If you are ever asked slack, say, can I have a piece of paper? First, show the slack series, describe where this is happening, pen upon biomechanics, and say you're asking me for slack 2 state, I'll tell you all 4 slacks treatment very quickly. Because it doesn't take long now. Slack 3 is all here, capitate is gone. Can I do a PRC? No. Because this is rough surface, it will come down. Either I do 4-corner fusion, yes, I have to do 4-corner. I can't do nothing more. And skip quite exciting. Easy, folds, total this. So see how easy treatment becomes. It is not a difficult slack. Yeah. Same with slack. Keep this picture in mind. So unit articulates with both bones, right? Put tricutum there, bicycle sticks there, STT joint, capitate articulates with both bones. Fill the gap in hamate, okay? It's a true representation of how it is, whichever crude way, doesn't matter. So snack is what? Scaphoid non-union happens here. Do we agree? If it's a non-union, this part can only flex because this is still joined to unit. Do we agree? If this has flexed, now this is all incongruous, snack 1 will happen here. Do we agree? This force transmission is only in one direction. Where will snack 2 happen? So is it not same as slack? Yes. It's just this part is behaving as unit because it's attached to unit. So it's exactly the same. It has to be the same. Force transmission can't change. Same with snack 1 now. If arthritis has happened here, what will you do? You can do styloidectomy and deal with non-union. If snack 2 has happened, then I can deal with non-union, and I can deal with this, but I can't deal with this arthritis. So scaphoid excision, four-corner fusion, or PRC. If 3 has happened, four-corner fusion, take this bone out, 4 is go to this. Does it make sense, guys? Yeah, it's very easy. Same with parallel unit because the stop is parallel unit. So I'll draw one more picture. Scaphoid unit articulates with both bones. Put tricutum and bicycle there. STT joint, capitate articulates with both bones. Put hamate wherever the space is. Yes. Parallel unit. So again, force transmission is only in one direction. Yes. So and all these are hyperextension units. So either in hyperextension you get scaphoid fracture, scaphoid unit, or parallel unit. It's just a spectrum. So for example, if I was to draw you a force which has come in this direction like this. So it's taken off scaphoid unit, you know, tricutum. Lesser rock. Force could have come through my styloid, scaphoid, capitate, tricutum, ulnar styloid, isn't it? All bones. Force could have come from styloid, scaphoid unit, capital unit joint, tricutum, and styloid. You can work out any patterns. Force, rather than going through lesser arc, could have come like taken off my unit and gone out. So it can be any number of patterns. You can make your own patterns. Simple as that. Force would have come through styloid, scaphoid, capitate, tricutum. So parallel unit is not difficult. They will show you 2-3 bones are gone and ligament. You think, oh my god, this is happening. All of them will need a dorsal approach. All of them will have those 3 steps. All of them will have a burger flap. All of them you're looking at the carpal bones. If scaphoid is gone, put a screw. Capitate is gone, put a screw. Unit is gone, put a screw. Tricutum, normally you only have a chip or vulture. It doesn't go. If it's gone through the bone, it doesn't normally. You still put a screw. Scaphoid unit ligament repair and tricutum unit repair. And I will show you in a minute how you repair because then my presentation will become easy. So last thing to do is really not a detail. SCT, unit, tricutum, bicycle, capitate. Yeah. So if scaphoid unit is gone, my scaphoid has flexed. Unit has extended. It has gone wherever it wants to go. It's not in a normal orientation. You need to bring them to normal orientation. You've done a dorsal approach as I've shown you, and you keep seeing. Now, carpus is looking at you. You need to correct the orientation. How will you do? You can't hold with a finger and correct. You can put a wire, you put a K wire, and now you can joystick. If you joystick it, if it is flexed, you extend it. If it is extended, you flex it. Whichever way, that's not important. With joystick, you correct the orientation. Now you correct it. Now it's looking proper. Now it's 45 degrees angle. There's no missing, there's no missing. Once with the joystick, you've corrected, now how do you hold it? You can't hold the 2 joysticks for 3 months, isn't it? So how do you hold this? Why not from outside the skin, put a wire from scaphoid to unit, and because scaphoid is in both bones, as Rishi told us, put a wire from scaphoid to capitate. Now both rows are immobilized, isn't it? That's how you now hold, you've corrected the orientation. Once you corrected it, joystick wires come out. At this moment, you can leave it, close the capsule, get in and call it a day. Or one more thing which I do, or people also do, I'm sure, is put an anchor. The stitches come out of capsule. So capsule is now stitched. and put a knot on top of capsule, it slaps the capsule down. So those septars, which were coming from the carpal bones to the septa, to the capsule, longitudinal septars will heal up. So that's washing line technique. This is all there is in ligament repair.
So
Same with neurotracheal.
it's not from the scaffold to the lunate itself, it's to the scaffold to capsule, lunate to capsule, and then it will come up together.
Yes. So what happens is, I've got anchor. So I take stitches to capsule, the stitches are coming out. So when I put the knot, it will slap the capsule down. So capsule will heal onto the carpus.
So they articulate it.
Articulation will correct it with joystick and I'm holding with my wires. This will allow my ligament to scarf. Make sense, guys? So now we can do the talk like. Kiran, will you switch off the lights? Thank you. No, Kiran will do it. Thanks, Rishi. Kiran will do it. So guys, this is what I was trying to show here now. It's very easy now. Scapholunate, any ligament work in wrist, put a scope, any slack snack, stage it with scope. MRI cannot pick up the cartilage in a wrist, unlike a knee. So,
do you want to make sure Hitesh is recording again?
Hitesh, are you recording?
Yeah,
Hitesh?
sir, we are
okay.
on.
Okay, thank you. So acute injury, I put a scope, grade 3, grade 4, doesn't matter, fine, whatever it is, I need to do something. Open, dorsal approach. Now you understand why these two wires have gone after joysticking and why these two anchors have gone. Make sense, guys? Okay, good. So this is after 1 year. Most important here is DISC. See, it's corrected. Any DISC work, look at the lunate on a lateral view. If it's looking up in the right direction, you know you've done a decent enough job, basically. So this is what you will ask for in the exams and comment on in the exam, how lunate is looking. Yeah.
Point out that tubercle, scaphoid tubercle in the lunate you were talking about.
Tubercle is here.
On the left, you're saying that.
Oh, that's a good thought. So see, if you follow scaphoid here, that's the line. Can you see this?
Yeah.
See how beautifully it is sitting inside lunate. And remind me, I will see 3-4 X-rays today. What happens is this line will come out here in subtle scapholunates. That's how you pick those, and you do your dynamic, pre-dynamic, whatever. And then this is another case, but just to show you the operative steps again and again for dorsal approach. This was grade 4. So again, skin flaps done. Retinaculum, see, I'm holding in my tooth forceps. I've only cut a centimeter. In this, I don't need to elevate whole 2nd and 4. So why disturb the tendons, you know? So I've done this much, and see, I've cut this is my capsule flap. Can you see? But you can only see 3 bones: scaphoid, lunate, capitate. I don't need to see all 8 bones. So you've just partly horizontally done this and put a vest, and you can see enough. This is a modified Mayo flap. So in the exam, even if you, for everything, if you say burger flap is fine, doesn't matter. Remember 3 steps. Even if you say, I'm going to take whole retinaculum, doesn't matter. At least it's sensible and it's the right answer. Yeah. And then what I'm showing you here in this operative picture with my tooth forceps, that's the scapholunate ligament. Okay. That's lunate, that's capitate, that's scaphoid. Can you see a little rent here? That's where it comes off from scaphoid. So if you're very clever, you correct orientation, you can put a teeny tiny anchor and stitch the ligament back up also. Yeah. But idea is again, same joystick, orientation, wires, which I've shown you. This is joystick. Yeah. I've got a video also, different patient for joystick. If I think it is somewhere there. So see how these wires, can you see how you can move carpal bones? Follow these 2 wires. So see, you can move your carpal bones. Yeah. So I can correct the orientation whichever way I want to. You can basically do what you want to do. Yes. That's joystick basically. So let's go to lunotrichute. Is it clear, guys? It's very important you follow that diagram. Otherwise, everybody's confused. I was confused up until I had to think of this process. And now life has become a bit easy for me. So important. Lunotricutal. Okay. You can see a gap. Follow the gilula line. See, there's a step here. Do you guys agree? Lunotricutal gone. Do you agree? Gilula lines we've discussed. Lunate doesn't have its own mind. It's going to go with scaphoids. What does scaphoid do always? It's going to flex rather than extend. If it flexes, scaphoid is flex, angle will reduce. No marks for guessing. So whatever is your normal angle, 45, reduce 10, 15, less, say in the exam 30, job done. Yeah. Test is whatever you can cram up and speak. Treatment will be the same. Only thing to remember here is scapholunate will give you slack. Scaphoid non-union will give you snack. Lunotricutal, not that important. It doesn't give you wrist arthritis because it's already at the ulnar corner. Force transmission on my radial side is same. So I'm not bothered. My lunate is sitting right. So I'm not that bothered. So you can use ECU strip for reconstruction, but that's not good. They're not going to ask you. Example, young man, hyperextension injury. Again, see the step between the lunate and there? Can you see this step? Yes. And look at the X-rays, clear flexion. So if you see lunate in flexion, it is visci, it is lunotricutal, always in exam. If you see lunate in extension, it is always disci, always scapholunate. Gilula line's gone. CT scan shows what you already knew. That little flake is tricutum because capsule has pulled off, obviously, at the back. And this is knee in theaters showing this is how patient came with flexed, carpus falling off. This is how you want it to be. Lunate and looking up, carpus sitting back on radius for force transmission. Agreed? So this is again me showing with the forceps. Can you see? So same approach. See here, I've done a big burger flap. Have you noticed? Not done a small flap. So again, for exam purposes, you can do this big flap for all the cases. Keep it easy. And this forceps point to the intact scapholunate ligament. Can you see this? But this ligament is gone here. There's a clear gap, lunotricutal. If I put I should have put something here to show you that it's a gap, but there are other ways of showing. Watch this video now very carefully. That's tricutum, that's lunate, that's scaphoid, yeah? So see how, I'll try and stop it for you. See there, can you see a step now? So this whole carpus is falling in the front like you saw on the II images. So now reduced, now stepped, now reduced, that's your lunotricutal there, yeah? See, big step there. Can you see big step there? Sorry, I think I have, but anyways, you got the gist of it, guys. Did you see it? Yes. Yeah. And see, same, this corresponds to this II image now. See how the carpus will fall off. If I take it, see, falling off, agreed? And now see, it corrects, agreed? It falls off, it corrects, which is what was happening here in life, yeah? So all you have to do is, oh, hang on. So all you have to do is, like I told you, take your, so I've done joysticks, which is not here now. You can see a little hole for joystick. So once I've joysticked the wires, corrected the visci, can you see me putting 2 wires there? So I put 2 wires to hold it. Yes, like you put 2 wires from scaphoid to capitate, scaphoid to lunate, you do the same. Wire from lunate to tricutum, because a lunotricutal injury, and lunate to capitate or hamate, wherever it goes. So once I've corrected it now, see in the video how it will move as one now. See, no step anymore. Agreed? It moves as a wrist. Yes? Yeah? So at this stage, I could have just closed the capsule. I don't need the anchors, but anchors are only so that this capsule can slap down. So you can see the stitches, yeah? So I put 2 anchors then, stitches come out of the capsule and I've repaired the capsule. Capsulodesis, like tenodesis, yes? For your capsule to heal up. Is it clear so far, guys? And same here, these are my 2 wires. Once I look at my lunotricutal, no step, lines of gillulas are fine. And I put 2 anchors and I've done these stitches. Yeah? That's your washing line technique, basically. This is what happens. These vertical septas are broken from the capsule. And when you stitch and put 2 knots on top of capsule, capsule slaps down and these septas will heal up. That's all you're trying to achieve with the anchors. That's your washing line technique.
Both anchors are in the lunate.
You should put 1 in tricutum also. This is just a representation. Yeah. And if I go back, I put 1 in tricutum, see? Yeah. And if my scapholunate was also gone, then you can put 1 in lunate here and 1 in scaphoid. Yeah. Miss Reichert, in fact, is writing upon it as a technique. So another example of visci, I'll go a bit faster because of time's sake. You can see lunate flexed. It is visci. We know that. Role of, I've told you, arthroscopy. This is very subtle actually. That was a grade 3. I can play it, but is it playing? doesn't matter. If you play with the probe, this is lunate, it will bounce up and down, or triquetrum rather, it will bounce up and down, but it's not completely opening. So I know it's grade 2, grade 3 basically, or grade 3 rather. And yeah. So again, this time I've just shown you operative steps again. I've partly cut the, can you see the strip of retinaculum? So this time I thought I can get away with just 1 centimeter. I've preserved the proximal half. So my tendons are still inside the retinaculum. And then you can see this flap of capsule like last time, Mayo flap. You don't need a big flap. You can start seeing the carpal bones there just about. And you will see them more in a minute, I hope. Okay, which you will see in the next slide. But so here what I'm showing you again is watch this wire. Can you watch this wire? See how so now lunate is reduced and see how lunate is flexing and carpus is falling off. Can you see this, guys? So this is your joystick wire. Yeah. So what you do is see carpus falling off, carpus comes back. You ask your assistant to hold the wire in a reduced position, basically. So carpus falling off, comes back. So assistant holds it like this. And then you put your 2 wires from lunate to triquetrum and triquetrum to hamate. And so once I've done this, I have 2 wires and 2 anchors. You can see lunate is sitting in the right direction. So it's the same principle. I'm not doing anything different. It's just repetition for you guys to remember it. And this is, sorry guys, same thing. Stitches coming out of capsule, washing line technique, capsulodesis, that strip of retinaculum I've stitched. So you can see the tendons. I've stitched it back and covered this with soft tissues so that you have no tendons exposed, like preserving your FCR sheath. You're preserving the sheath here and retinaculum here so that there's no tethering, and then close up your skin. Yes? Can we go to parilunate now? All clear so far? Okay, good. Parilunate, I told you, hyperextension, whether it's scaphoid, scapholunate, parilunate, any is the same injuries, it's a different spectrum. So basically, this is how carpus will push lunate out, which is your Mayfield 4. So let's introduce another concept, Mayfield. This is what I have already discussed with you. He said the same thing, which we have said, scapholunate, then capitolunate, lunotriquetral, and finally out. So forces will come from radius and goes towards ulna. Yeah. Lesser and greater arc we have discussed. Same forces are coming from radius to ulna. Lesser arc is pure ligaments, scapholunate and lunotriquetral. You add any bone to it, it becomes a greater arc. Simple, it's just names. Same reason you want to treat them. You don't want collapse, you don't want pain, you don't want arthritis. Yes. And if lunate dislocates, you don't want median nerve symptoms. Fracture dislocations, same clinical acumen, because 15-20% are missed. Lateral X-ray, very important. That's where you pick those up. PA X-ray, look for Gilula's lines. Reduce, stabilize. Open, stabilize. KY anchors. Close reduction. So if you, what you do is you start with hyperextension, traction, counter traction, bit of pressure. If lunate is out here, otherwise you just reduce it and then just keep the pressure, because lunate may fall out now, and then put a plaster and then speak to your hand surgeons. So let's see an example. 77, he had all sorts of issues. I remember him. He had this, see, this is lunate here. Anyways, either ways, you will pick up something on PA, and see PA, there's completely empty. And lateral, you can see there's a big block of bone there. So you know something is going wrong. Even if you know that much and ask for CT, you'll pick up, right? It was an open injury and he was diabetic. So they can ask you BOA BAPRAS guidelines. You can just read and tell them. A&E management is how you wash, don't use betadine, take some pictures, big open wound, speak to plastic surgeons, all those things. Yes, antibiotics. So see where the lunate is. Yeah, we agree. It's a lunate dislocation and there's a styloid fracture there. Important was, that's the lunate dislocation. This bone lunate corresponds to where lunate. So it had not come out in the front here. It had come out on the styloid here. Can go anywhere. So see, that's one wound I've debrided, and this is where extended carpal tunnel approach. Lunate has gone back. That's me showing spacoporia. So I've reduced it through spacoporia. Lots of wires, which I'll discuss in a second, because they can ask you. So it's the same picture. See, same X-ray, wires, and let's discuss why so many wires. Who would want to have a go? I'll take you through it. It's easy. Okay, good. So scapholunate, we know everything is gone. It's a lunate dislocation. Scapholunate is gone. So where will you? So this wire is from scaphoid to lunate. You agree? This wire. So we needed these two wires. Do you agree with me? So I can't be criticized for this. This wire is holding my styloid. Can you see? There were 100 pieces. He's diabetic. I don't want to start putting now screws and styloid plate. Obviously, it's open wound. So can't be criticized for this wire. You agree? This wire is going from triquetrum to lunate. Am I right in putting that? This wire is going from hamate to triquetrum. Am I right in putting that? You have to put two wires. And this last wire, this wire is from radius to lunate. See, I'll show you. This wire. The reason was, despite doing all this, his carpus was still subluxing. These are the cases for good spanning plate also, or some sort of. So I was doing so many wires. So I just put one wire from radius to lunate. And luckily actually, because diabetic open, he did well. 7 weeks, everything came out. I bumped into him in restaurant after 2 years and he had good movements. I should have taken the pictures and put it here, but doesn't matter. Important is lunate is pointing in the right direction. Yeah. So even if you see so many wires, if you think rationally with these pictures, you can make it out. Yeah. And this is how you plan yourself. So this is transscaphoid, lunotriquetral perilunate. Now we know the pattern. We're not bothered. Which approach? Dorsal. What steps? Capsule burger flap, radial based. Okay. Scaphoid, whether it's proximal pole or whole scaphoid, can be fixed from the back. It's a difficult approach. That's why for waist we do from volar. But from volar, if it's proximal pole, it's almost not possible to fix. You can fix it still, almost not possible. Yeah. So wherever if you have a waist scaphoid here, don't say I'll do a volar approach, Volkswagen volar approach, and I'll put it. You are there, you fix it. Yeah. So as I said, scaphoid is fractured, you put a screw. Lunotriquetral, now you know how to repair the ligament. Simple as that. Joystick it, correct the orientation, 2 wires, 2 anchors, come out. So you can deal with any perilunate injury pattern. Yeah. So it's the same transscaphoid, perilunate. Yeah. This is me just showing scaphoid and steps and all that. But bottom line is this screw and lots of anchors and wires. Okay. Wires have come out now. Transscaphoid, another perilunate. Oh yeah. The reason I put this was scaphoid, lunate, triquetrum. Triquetrum, you only see this avulsions. Triquetrum doesn't have a proper, it can occasionally, if you see a little avulsion, which is a little avulsion, it is indicative of a lunotriquetral ligament. This is a higher order thinking. Now they won't ask you, they won't expect you to know. I've just put it. Same thing you do, scaphoid, put a screw, lunate, put 2 wires, 2 anchors. Now it's so easy to interpret, isn't it? So what I'm saying is go home, draw these pictures and see styloid. Injury starts from styloid, goes to ulna. So in this case, styloid and scapholunate. Styloid, you can put a screw, I don't care, put a plate, put a wire, whatever you want to do. Scapholunate, you know how to repair now. Makes sense? Lunate should point up in the right direction, means you've done a decent job. I think, so patterns, this is what I discussed with you, right? So I've tried to put a lot of patterns here. See, let's work them out. This pink line is styloid, scapholunate, lunotriquetral, ulnar styloid. This line is transscaphoid, transcapitate, transhapitate, hamate, hapitate, and transtriquetral. Let's look at these wires. So these wires correspond to these arcs. So let's start greater arc. Same, or start from styloid, either styloid, scaphoid, capitate, hamate. Yes. And then second line is your pure lesser arc, scapholunate, lunotriquetral. Third is going just pure through lunate. Yes. Fourth is just gone through the joint, so you can have a rest dislocation. So is it that difficult if you think of it? Approach is that difficult once you think of it. If you can do a big approach to, I don't know, humerus or hip or knee, how can a wrist approach be difficult? How can putting a screw be difficult, or 2 wires? So they're not difficult. Once you know what you're doing, they are not difficult. Biomechanics, I put it in the end because I knew Rishi will beautifully cover it, which he has done. Thank you. And one more thing, that's why I put it here actually, sorry. That's our normal rest. Whether lunate extends or flexes. In both views, so VISI or DISI, lunate only looks triangular. So lunate only has two shapes, a moon shape, boat shape in a normal rest, or a triangular shape in a VISI or a DISI. Remember that. So if you see a triangle, it's not whether lunate is flexed or extended. You have to see the lateral view for that. Yeah, perfect. Thank you for listening. Any questions?
So there's
These surfaces, neuroma forms again. If you're competent, very again, if not, send it back into some competence. They have
This
to
is the
be.
next one, okay?
Thank you. Thanks, Rashid.
Hitesh, you want to ask something?
Yeah, no, it's fine. Arjun, we'll go to the next stop.
Okay.
Okay, thanks, Hitesh.
Brilliant. Thanks, Saurabh. So, guys, we're going to move now on to the trauma hand and wrist component of the course. And we're going to break this into two parts. So I'm going to talk to you more focusing on some of the decision making, and then Saurabh will take you a bit more in depth about the actual operative treatment and how you do it. Because the exam is made up of two parts. The 6 and 7 is the decision making, and then the 8 is really the details of the operation itself. Okay? So let's start with some common cases. I'm going to try and do this in an interactive manner. Okay, so Miraz, this is a 24-year-old male, right-handed, who had a fight in A&E, fight 24 hours ago, has presented to A&E with a painful stiff hand. Tell me what you see.
So I can see there's a clinical photograph of dorsal aspect of the hand, so focusing on MCP joint. I can't specify which fingers are they, but I can see there are deep abrasions, probably puncture wound. I can see there is localized superficial necrosis or ulcerations. I think this is an open wound until proved otherwise.
Give me one phrase. What is this? You're the hand surgeon on call.
This fight bite injury.
It's a fight bite injury. So what are your concerns?
My concerns is wound communicating to the MCP joint.
Okay. What else?
With infection.
Okay, so you're worried about infection. What else are you worried about? With the place that it is.
So extensive tendon injury.
Okay. Which part specifically?
Which
zone, I should say.
MCP joint, so zone 5.
Yes, it's typically a zone 5 extensor tendon injury. And what structure normally gets injured in zone 5?
It can be either extensive tendons or it can be sagittal band.
Usually the sagittal band, which gets injured at this point. But yeah, you would check the extensor tendons as well. Good. So fight bite is a common complaint which they bring up in the exam. So typically it's a tooth mark at the site of the MCP joint, and it typically will take out the zone 5 extensor tendon or sagittal bands. So what would I do? Historically, I'd want to know about the chronicity since the injury. I'd want to know about what the nature of the injury was as well. Is their tetanus status up to date? And are they clinically unwell? Any history of immunocompromise? What's the classical bug which causes this? Typical bug, I should say. Typical bug, and then the classical one for the exam.
Typical will be staph and classical will be Echinella.
Yes, the typical is Staph aureus. The classical one they bring up in the exam is Echinella as well, corrodens. Okay, so your initial management should be about wound care in A&E. Okay, so tetanus, IV antibiotics, taking a history of immunocompromise, and then basically putting them in a Bradford sling for comfort, checking the neurovascular status, get an X-ray as well to make sure there's no fracture and also that there's no obvious foreign body such as a tooth, and checking the status of the tendons itself. So a very quick way that you can check if the extensor tendons are intact is by doing something called a tenodesis effect. Okay, so where if you passively extend the wrist, the fingers should flex. If you passively flex the wrist, the fingers should extend. Okay, so that's a quick way of me checking if the tendons are intact. Does this need to go in the middle of the night or not?
Yes.
Does everybody else agree with that? Oh yeah, so if it's a patient who's clinically well, they're not obviously septic or anything like that, then a fight bite injury could be treated with Bradford sling, IV antibiotics, observation overnight, and I'd probably take it first thing in the morning, okay? Obviously, if they're systemically unwell, that's different, but this could potentially wait. In terms of your treatment, what position would you have the hand in? So you've got to wash this out. It needs an operation, okay? There's no medical treatment for this. What position would you have the hand in when you're dissecting? So you'd have it in, so would you put the hand flat when you're dissecting, or what position would you put it in? Yes, the buzzword I want you to use for the exam is use a clenched fist position. You put it in the position that it was injured at the time of the injury, where the skin lines up with the tendon, lines up with the bone. The examiner will test that, okay? The next thing, Miraj, is you go down, you open up, you think that the capsule may be intact or not. Would you open the capsule if it's intact or not?
I would open.
That would be my personal opinion as well. I'd probably open the capsule as well. Would you do the same, Saurabh? Because my concern would be, could this be an in-out puncture wound? So you're never going to be criticized for opening the capsule. But if you leave it and they develop a septic joint, you may well be criticized. Okay? What will you do at the end of the procedure? Will you close the wound or not?
I would not close the wound. I would take the patient for the second look in 24 to
48 hours. Okay, great. So that's the fight bite case done, basically. Okay?
Good question.
Yeah.
What amount of radials where MCP when you're making a incision at the capsule, so you don't get like a kind of a drift of the tendons?
What would you do? Sorry, ulnar or radial to the capsule?
I tell you, you will give the answer. Did I show you in contour and proximal failings? Where you go on the tendon?
Right to the middle.
Right to the middle.
Exactly.
Tendon is taken care of.
Yeah.
Go through the same line with the capsule.
Yeah. Go for the same
Simple
thing.
line, simple. Keep it simple so that finally it will come out from.
For open or not open the joint.
Yeah.
Can you do a needle test with saline?
I would just open it to be safe. For the exam, you're never going to be criticized. Okay. I always think in these, and I think of it in the exam, what gets you a basic pass or a 6? It's basically you being safe as a day one consultant. All right. And in terms of, I know this is a very negative way of thinking about things, but I always think, what's going to end you up in a coroner's court? Okay, so always think of the question, what is going to get a complaint against me and that I cannot defend it? Now, I could always defend opening the capsule because I could be say, my concern, it was an in and out injury. You will never be criticized for it. But if you miss that and then they pus out within 2 days and they potentially lose that joint because of septic arthritis, you will be criticized for that. Okay, so that would be my honest answer for the exam. Okay, next case, Sahil. This is a 35-year-old right-handed male, works as a carpenter, got a splinter stuck in his finger 5 days ago, and now presents with a 24-hour history of worsening pain and also is clinically unwell as well.
So this is a clinical photograph on aspect of the right hand. There is a discoloration of the second level of the second MCVJ,
yep.
As well as the discoloration of the tip of the middle ring.
Now, I think that's probably projectional, but basically, it's fine. The main thing is this area here; it's all red.
The index finger itself looks more swollen compared to the others, and the creases are not as obvious. My concern that this is a flexor tendon sheath infection.
Right, so that's, guys, this is the thing which will get you struck off if you miss this. Okay, so this is the thing you do not want to miss. All right, so whereas I said the fight bite can potentially wait till the morning, if this person comes in at 2 in the morning eating a hamburger, what will you be doing?
So this is an emergency.
Yeah.
I'll discuss this with our anesthetic colleagues as to the risk of the anesthesia, and come to a sensible decision as to.
So this is rapid sequence induction. This is take it overnight. Okay, this is the one that you don't want to wait for. All right. So classically, how do we diagnose this?
This is a clinical diagnosis, including the history, examination. On examination, I'm looking for canal signs,
okay.
Which is fusiform swelling. Tenderness along the entirety of the flexor tendon sheath itself, redness and pain on movement of the digit.
So you got 3 of them, okay? So redness isn't one of them, okay? But for those guys listening, so Canaveral signs, that's the key thing you need to come out in the exam. So as you said, pain on passive extension, okay? Tenderness over the flexor sheath, fusiform swelling, and the last one is it has a flexed attitude, okay? So if you wanted to show higher order thinking in the exam, when you're given that, you could say, this is a clinical photograph which shows a fusiform swelling of the index finger with erythema down to just proximal to the A1 pulley. I note that it's a fusiform swelling. I cannot comment on whether there is a flexed attitude without looking at it. I also would like to test if there is pain on passive extension and also if there's tenderness over the flexor sheath. My concern is this is a flexor tenosynovitis. So what I've done is I basically named Canaveral signs without naming the word Canaveral. That's the higher order thinking. I'm showing that I understand that to the examiner. Yeah, those are little technique things that you can use. All right. So your initial management will be the same. History, find out about chronicity. Ideally, you want to get to these within about 6 hours if you can. Okay. History of immunocompromise. I'd want to know if there's any obvious foreign body. On examination, I would check for Cannibal signs. I'd check if they're systemically unwell. I may do a radiograph as well to look for any obvious foreign body. I would start IV antibiotics. I would splint them in a Bradford sling, and I would arrange for theatre. There's no medical treatment for this in a clinically fit patient, surgical treatment. What surgery would you do?
So in the consented marks anesthetize and he check his patient out, place the patient's spine with the arm table, and my incisions will be over the A1 pulley at the level of the MCD head, and a second incision at the distal interlocking joint at the crease itself, and I will go down to the flexor and the sheath in both positions and feed a cannula and perform a saline washout irrigation of the flexor.
So you described doing a dual incision technique over the A1 and A5 pulley, washing with a cannula until the fluid is clear. Now in this picture here, the swelling is almost to the mid-palmar crease. Do you have any concerns with the technique that you described then?
So the concern is you could actually advance the infection or pass deeper into the mid-palmar space.
Okay, but also just in terms of treating the infection, sometimes if the infection has gone proximal to the A1 pulley, that technique may not work. So I would always try that technique first if I could, but what is your salvage? What can you do after that?
Yes, would you do a zigzag incision to...
What do we call that, a zigzag?
Brunner's.
Yeah, so you could do a Brunner's incision and flay the whole finger over it if you have to. You just have to wash this out. Right, so that will be the first part of your question, guys. And at the end of the procedure, you leave it open, come back in 24 to 48 hours for a second look. The second part, if you get onto that in the exam, and most candidates don't get that far, is they will say to you, okay, how does your management change if this is a thumb or a little finger?
So because of how the finger sheets connect, there's a connection between the thumb and the finger, and you get horseshoe access. So
what do we call that connection between the thumb and the little finger? Where do they connect?
So it's not on space, because of the space.
So it's just proximal to the carpal tunnel. There's a space called the space of Parona. Have you guys heard of that? P-A-R-O-N-A. Okay, so always check for tenderness there. Now, I have seen them in the recent exam. They actually gave a patient with an index finger and they said, it's got onto the little finger. What do you think's happened there? This is one that they brought in the recent exam. Does anybody know?
In around 10-20% of the population, you can have an abdominal collection.
Exactly. So it's an anatomical variation where you can actually get communication between the index finger and the first or the fifth, or even the middle finger and the first or fifth. Just be aware, this question is normally divided into two parts. The first part being flexor sheath infection, the second part being palmar spaces of the hand. Okay, so that's what you've got to be thinking of, your higher order thinking in this question. Okay, good. Case 3. Right. You've done the exam recently, haven't you? Have you or not?
The part one.
Part 1. Okay, fantastic. Okay, so this is a 25-year-old gentleman, comes to A&E, has been using a circular saw, and you've been asked to come and see him as a surgeon on call.
So this is a clinical photograph showing the right hand of a patient in the frontal plane and the lateral plane. It looks like there are looks like grease marks over the.
I think it is blood. It's the appearance of the screen. Sorry. So that's blood. It's not grease marks.
And the shape seems to be in the middle finger. There seems to be some exposure of the underlying tissues.
Yeah. So
the attitude of the fingers is that the ulnar ones are clawed and the middle one is fully hyperextended.
So I'm going to help you a little bit, and I think it's because of the picture. But there's a laceration here. There's a laceration here. Okay. So do you think these fingers are abnormal? That's not grease. It's just blood on the hand. Which fingers do you think are abnormal?
The index and the middle.
Index, the middle. Yeah. This patient's trying to make a fist, and you mentioned that there's an extended attitude of these two. So that's fully extended. That's semi-extended. Okay, so we've got someone who's been using a circular saw who comes in with an extended attitude and lacerations to the index and middle finger. What's your concern?
So these look like a zone, could potentially be a zone 2 flexor tendon injury.
Fantastic. I'm so glad you didn't just say flexor tendon injury, you said zone 2. All right. Why is zone 2 important?
Because it is the area where the FDS and the FDP basically crisscross.
Yeah. So traditionally it was known as what area?
No man's land.
No man's land. For those of you who are up on your World War I history. Okay. So no man's land was the area where the two armies, you don't go because it's full of shells and bombs. Okay. So it was typically seen as a landmine area, like where lots could go wrong. And these patients typically had lots of adhesions and had very poor outcomes. Okay. So traditionally, these had very poor outcomes. Okay, so again, your wound care will be exactly the same as the fight bite. You will assess the patient in A&E, tetanus, IV antibiotics. I would want to know about the chronicity since the injury, and I'd want to know about what kind of blade it was. Was it a sharp or serrated blade? If it's serrated, it means, or dirty, it means that I'm going to likely have to take some of the tendon away to repair it. Okay, I'd also want to know about the neurovascular status of that finger, and I'd want to check if the tendons are intact. Okay, you can formally check FDS or FDP. So remember, to check FDS, you want to basically do that. Put your hand on the other ones and then get them to bend it. Or FDP, specifically just check that joint. Or if the patient's in too much pain, you could do a very quick Gross test by doing a tenodesis effect. I would do an X-ray as well to look for an associated fracture. Okay, IV antibiotics, Bradford sling. Does this need to go in the middle of the night or not? No. So this should be done on a designated hand or plastic surgeon's list. Okay. Now they will ask you, how do you repair this, or what do you do?
So a standard for a flexor tendon repair would be 4 to 6 strand core suture with epitendinous repair.
Okay, good. So if you guys are ever asked in the exam, how would you repair this tendon? I want you to talk generically. Don't go into specifics. All right. So remember Rishi's 6 principles of tendon repair. I've got to name them now. I've got to remember that 6. Put pressure on myself. Okay. So with the Brunner's incision, wash down to the wound. If it's more than 50% torn, you're going to repair it. Okay. So 6 principles. Number 1, 4 to 6 core strands, which gives you about 80% of the strength. Number 2, you want to use a circumferential epitendinous suture, which gives you the final 20%, normally a 6-0 proline. Okay. Number 3, you want to reconstruct the pulleys, if possible. Okay, A2 and A4 are the key pulleys to reconstruct to prevent bowstringing. Okay. Number 4, you want to minimize soft tissue handling to prevent adhesions. Okay. Number 5, you normally will cut out one of the FDS slips, and that's what gives you the gliding, so to prevent the traditional adhesions and poor outcomes. And then number 6, you probably want to do early active rehab, like a Belfast type of rehab regime. Okay, so the way to think about tendons is, another common phrase I use in my trainees is, everything in orthopedics is a payoff. There is no perfect scenario. Okay, so tendons are typically at their weakest after about 10 to 14 days post-repair. So the ideal would be, we would leave these guys for 6 weeks. But the problem is with flexor tendons is you get adhesions. So you have to move them. Okay, so the cost benefit is that you try and get some movement back. Extensor tendons are different. Okay, they tend not to shorten or retract because you've got the juncturi tendinums. Okay, so with those ones, you can immobilize them a little bit longer. So everything in orthopedics is a payoff. Okay, it's like, as an aside, if we talk about bone grafting, okay, you want bone graft with good biomechanical properties, osteoconductive, osteoinductive, osteogenic properties. But the more osteogenic the properties, the more immunogenic they are as well. So you kind of have to aim for a compromise between the two. Okay, so that's the buzzword to remember. So in terms of regimes of rehab, if they ask you, there is a passive or an active regime. Okay, so passive can be either patient-driven or it can be splint-driven. Okay, Durant or Kleinert. Okay, so Durant is where the patient themselves passively basically moves their digits. Kleinert is where there's sort of elastic bands, okay? Whereas active is the Belfast regime, where you're allowing flexion, but you can't actively extend past a certain point, okay? So that's the regime which is more commonly used nowadays. So those 6 principles of tendon repair I would remember. The other thing that they might ask you is if you're doing really well and they're pushing you towards an 8, they might say the patient comes back 6 weeks later, the repair has failed, or it's a missed flexor tendon repair. What would you do now?
So in that case, I'll be thinking about doing a 2-stage repair.
Do we call that a repair? What do we call it? Reconstruction. So your repair options have gone. You're going for reconstructive options, 2-stage. So what do you do?
So in the first stage, I would try to thread a silicone catheter just so that there are fibrous adhesions surrounding that. And then at the second stage, you move that, use a tendon graft, and hopefully the tunnel has formed with no adhesions. So
yeah. So you're trying to create a pseudo sheath with the first stage, silicone rod. Then you come back 6 weeks later and you're putting a graft, normally plantaris, or for example, you can use something like palmaris longus. Okay. And that's a 2-stage repair or reconstruction. I said it myself. Yeah. Good. Excellent. Right, Melindra. This is just a 30-year-old chef who fell from a standing height. Tell me what you think of these radiographs.
Yeah, the AP and lateral radiograph of wrist in a structurally mature patient, and looking at the X-ray of the AP view, see a distal structure with shortening of the radius, and the radial height is shortened, and inclination, radial inclination of, I would say is acceptable. And on the lateral view, there's not much dorsal tilting, but there is some evidence of angular translation or possibility of oval bottom type. So we need to get the history and proper history.
Do you think it's volar Barton type?
I mean, there is potential because it's shortened and then slightly angulated.
Okay.
And there's a dorsal comminution as well.
Okay.
And
well, let's imagine that it's treated conservatively. Okay? I was going to say I think you're quite harsh taskmaster. That's good. I like it. Okay. So let's say this was treated conservatively.
Yes.
If it's a distal radius fracture undisplaced, you bring the patient back in 6 weeks' time.
Yes.
What's your concern with anybody who has a distal radius fracture treated conservatively? What would you want to check when you see them in the clinic?
So, I mean, bony-wise, I would want to make sure that radiographic.
Bony-wise is fine. What else would you check?
So we need to make sure that the patient has any EPL ruptures.
Excellent. Yeah. So the patient comes back to see you in the clinic. Tell me what you see here.
So it's a clinical radiograph of left hand dorsal aspect, and on the thumb I could see an attitude of flexed IPJ. And but ideally, I should check the retropulsion.
Yeah. So how would you check retropulsion?
So I would ask the patient to put the hand flat on the table.
Yeah.
And ask to lift the thumb to the ceiling.
Yeah.
And I could that is non-palpable, but I should palpate, see whether there's any tightness of the EPL all the way from the thumb to the wrist, and see whether there's any tenderness, and also sometimes if there's a rupture. I would.
So how would you treat this?
So
there's an EPL rupture.
Yeah, so EPL ruptures, I mean, depending on the patient, if the patient is young patient, acute, in the acute stage, with I should not, if it's clinically possible, then there's no point doing ultrasound scan.
Yeah. No waffle. How are you going to treat it? One word, one phrase.
Tendon reconstruction with the EIP to EPL transfer.
Very good. So tendon transfer, you can't repair this. Yes, okay. All right, so that's the key point. This was a recent short case in the recent November Part 2 exam. So guys, whenever you see a distal radius fracture, the FRCS, you've got to remember it's a consultant entry exam. They have to think, how can I get this candidate to show higher order thinking? So they're not just going to give you something basic. If they give you a distal radius fracture, they may either want you to look at, oh, maybe that's not as benign as it looks. There might be a bit of shortening. There may be a bit of dorsal comminution. So this is one that could potentially slip. So even if you treat it conservatively, you're going to watch it very carefully, and that might change. Or the other thing to be aware of is always think EPL rupture, because then you won't miss it. You won't miss it. So this is what I tell all my trainees to do, and I used to do myself. I would call it cycling a topic, where I'd look at it, and I would just think of the higher order thinking. Where do I think that's going to go? And you're keeping it in your mind all the way going into the exam. Yeah. It's like if I see any child in the exam who has shoulder problems, Okay, any child in the exam who has shoulder problems, as far as I'm concerned, has an osteochondroma until proven otherwise. Because I've seen it so many times where literally they'll say this child has got weird movements, and then candidate doesn't examine, just looks there, doesn't examine them, and then the examiner will say in the very last minute, can you lift their arm up? There's a huge osteochondroma. So if you don't think about it, you'll miss it. So keep that in the back of your mind so you don't forget it. It's a common trick that they pull in the exam. EPL rupture is very common. Yeah. You don't worry too much about X-rays. I just literally grabbed one off the internet. I typed in undisplaced distal radius fracture. Now clearly it's not. I agree with Melinda. It's not a perfect position, and in a young person, there possibly is a bit of shortening. There's a radial styloid injury. There is a bit of dorsal comminution. So this is, even if I treat this conservatively, I would watch it like a hawk, because this is one which may slip. Okay, so don't worry too much about that. This is not an actual case. I wanted to focus on this. This was my focus, basically. Okay, good. So, yes, young man in the back, sorry. This is a patient who's been playing cricket, standing in the slips, went to catch the ball, and then presented to A&E with this deformity here. And these are the radiographs.
Yeah, radiograph of the lateral radiograph of the finger. I'm not sure entirely which finger that, or I would go for an AP view as well.
Okay.
However, on this view, the most obvious picture is that there is a dorsal UIPJ dislocation.
Very good.
I cannot see any fracture up there. I will need to make sure that this is a closed neurovascular that injury. I will reduce that.
How are you going to reduce it?
So with this kind of injury, I would be worried about the polar plate position. So I will probably increase the deformity a little bit, more dorsiflexion, accentuate, and then I will reduce it down. And I will put him in a dorsal flex.
Okay, so this is a volar plate injury typically, isn't it? So classically with these, if you reduce them fine, they're actually, is this a good injury to have or a bad injury if you were going to dislocate your PIP joint? Yeah. So classically with these, you can get them going pretty soon because it's usually a stable injury. Do you find that as well? Would you normally? Yeah. Volar plate injuries. And you can, as you said, you can worsen deformity, give a bit of traction, okay, to reduce it. Is this a good injury or a bad injury?
No, it's associated with a central instability.
Yeah, so the volar plate, the volar dislocations are entirely different. This is actually a complex dislocation because it's got a bony involvement. So we say simple if it's a pure dislocation, complex if there's bony involvement. Okay, so this is different and it has a central slip injury. So this one, even if you reduce it, you need to immobilize that for 6 weeks, probably in a cape and a splint, to keep that PIP joint in hyperextension. So it's just something to be aware of. Okay. If I give you this patient here, next person, what does this show?
Multiple dislocation, MCP joint dislocation of the premium finger. Looks like it is a fracture dislocation of the
Okay, I think it's probably just a dislocation, but the reason why I put this one up is, so what we say is simple and complex in a PIP joint dislocation means dislocation alone or dislocation with a fracture. Simple or complex in an MCPJ dislocation means what? It's reducible or irreducible. Why might this become irreducible? What's your concern? What becomes interposed? Volar plate. Okay, so I just said to you in a PIP joint one, you can apply traction. What happens if you apply traction with this one? The volar plate will fall into the hole and it will go from being simple to complex and you will have to open up. Okay, so what is your reduction maneuver here? Yeah, or sometimes you can even actually push the bits together and then just basically, if it's gone dorsal, you can give a bit of pressure on the proximal phalanx to push it down. Have you seen many of these, Saurabh?
3 or 4 in last 7 years. No,
3 or 4 last 7 years.
if I'm totally honest. Twice we had to open up when I was at Denmark Hill.
Yeah.
Here, it just came reduced closed.
Have you seen many of these as well? No, I was asking, sorry. No. So I just wanted to put this slide in. I've not seen, I think I've seen one MCP joint dislocation, but I wanted to put that slide in just to sort of show you about the difference between the two, because it's a common thing they bring in the exam. So you've got to understand about PIP joint dislocation, volar plate injury. PIP joint dorsal dislocation, volar plate injury, volar dislocation, central slip injury. But the one to be aware of is an MCP joint dislocation, where you can get a volar plate trapped. So please, please, please do not apply traction to reduce those. Yeah? Is that fair, guys? Yeah? Yeah, please, no, please interrupt. Yeah.
I would prefer a dorsal approach through the tendon.
Midline through the tendon, like
midline through the tendon.
Good. And then
try to go through the capsule, try to push out the volar plate.
So like your fight, midline, you're done, it's still not reducing. So volar plate has interposed, that's why it opened it.
So give an incision to the volar plate through the joint.
How will you get to the volar plate? Exactly. So you get a McDonald's or Freer elevator, because remember, to push it away.
So always think of one approach, dorsal, midline. Okay, they can ask you if you do volar, then what's the problem? The volar plate is gone, you should go volar. The nerves and vessels come in the midline, you have to get it ready of those, that's all. Volar plate, have you seen a volar plate in MCP? See it? How it looks?
As a no.
Next time when you're doing your duplitrons, tell your consultant to show you. It's just under the tendon, it's there.
Yeah.
So once you've seen it, your hesitation goes. It's a big bulky structure.
It is. So sometimes I've had patients who have fingers in palm deformity, and Dupuytren's patients, and I always consent them for a volar plate release. Okay. So basically, what you do is, you'll do your Brunners, and you'll start taking away some of the tissue, and gradually you can move the tendon to one side once you've freed it, and then you have the volar plate. You can make a little H-shaped release in the volar plate, but you have to be very careful. It's very good, because I had one of those where a Dupuytren's where I consented for a volar plate release, and I ended up making a nick, and I made a nick in the FDP tendon because it was so stuck down and scarred, and I had to then repair the FDP tendon. Luckily, the patient did okay, but now I'm always worried now about this volar plate tendon being stuck down. So you have to be very careful. But yeah.
It's the same as the thumb as well. Thumb MCP dislocation, same as the rest of the.
Same technique. I think it's the same one.
If I have to open, I'll still go dorsal because I'm converted. And whatever, the volar plate is the only structure I push it. I have to go volar, radial digital nerve is in a different orientation because it has to travel from the nerve, and I'm wary of those nerves. So I'll never go volar in a thumb if I can avoid it.
And all you're doing is you're just getting a Freer elevator or a McDonald's, just pushing it back. Yeah, that's all it is. Okay, good. So, next gentleman. Right. So this is a 25-year-old who was punching his friend and sustained this injury. Tell me what you see.
So this is a photograph taken lateral with 6 extra-articular base of the thumb fracture. There's a weak ligament attached to it, because of which the fracture sustained. It's a stable injury. I would like to make sure.
Did you say it's a stable injury, this one?
It's an unstable.
Unstable injury, sorry.
Injury.
Yeah.
Yeah.
What would you call this injury, this pattern? What's the sort of... Is this Bennett's? It's intra-articular. It's almost a Y-shaped type fracture, isn't it? Yeah. Okay. So you mentioned about Bennett's and Rolando's. What's the difference between them?
Bennett's just got a single intra-articular fragment, and Rolando's got a Y kind of thing.
Yeah. Rolando, not Ronaldo.
No.
He's the one who's on multi-millions every week. So don't get them mixed up. Yeah. So so there's 3 types of fractures that you'll see basically in the thumb, base of the thumb. So you might see an extra-articular one, or you might see intra-articular, which can be either Bennett's or Rolando's. Okay. So as you said, Bennett's is where you typically will just have one fracture line here. This bit here is attached to the beak ligament. Okay. And Rolando's is where it's intra-articular. It's typically a Y-shaped fracture. Now, usually with the intra-articulars, you're almost always going to operate. Okay, sometimes if a Bennett's is completely undisplaced, it's in a good position, you may be able to get away with treating that in a thumb spiker. but all the ones that I seem to have, they all seem to have been displaced. And so the difference for me would be in the type of treatment. If it's a Bennett's, it's just a single fracture line, I should be able to potentially just MUA and K-wire that, okay? And what they may ask you in the exam is, how would you do that? So I would typically get two people, consultant, registrar, or whoever. The consultant, I would always get to do the reduction, and I'll get my registrar to fire the wires. So I would typically put can I demonstrate on you, Saurabh? Is that right? Of course. So imagine Saurabh as the patient. I will learn something. And then, so I would typically put one thumb here, and I'm basically applying some traction there, and then some adduction here. And I'm getting my registrar to fire 2 wires. A bit of a deduction. Okay, brilliant. Okay, and I'm getting to fire 1 wire going from base of metacarpal into trapezium, and the other wire going from first to second. Is that how you do the same thing? Absolutely. Yeah. Typically 1.6 wires, depending on the size of the patient, I would use. Okay. The important point to a Rolando is, because it's intra-articular, it's like a Y, you may need to open up, and you might need to do some sort of T-play. Sometimes if you can get the articular surface really beautifully congruent, you can just go again, you know, maybe a wire across into the second and another wire from base of metacarpal to trapezium. But the ones that I've had to do, I think I've had to open. Have you had to open, or can you do them with wires?
Try and get away with wires.
I try and get away with wires if I can, yeah.
It's easy one.
And you don't want to open if you can, because yeah, it is a nightmare. It is a nightmare.
Depending on the.
I think the ones that I've been referred were both referred to me in 19 days, and that's why I had to open up with them. But it's not nice. It's not nice. So then that's where, when I was mentioning about to Saurabh earlier, is like, well, where does Wagner's come in? Okay, so you can approach these dorsal approach, or you can do a Wagner's approach at the junction of the dorsal and glabellar skin. But often with a Rolando, because that fragment is quite volar, you often have to do the Wagner's approach. Yes. Yeah, so that's just something to be aware of in the exam. Okay.
Volar weak ligament and that fragment is the constant fragment. So for dorsal to get reduction is hard. Tendon with tether to the plate, which I shot and I have taken over. And it becomes a bit of a fiddle.
It's a fiddle.
So you get away with K wires, it's better.
It's better, definitely. So that's why, guys, my key learning point to you guys so far, and I think this is quite important post-COVID, is we're seeing a lot of finger digit injuries referred to us after 14 days. They're really tough after like 14 days. They're all stuck, partly healed. You're often having to open up. So that's the one thing you need to be saying to your A&Es, saying to your fracture service at work, is fingers need to be seen quickly. They really do. You know, ideally, if you can get some within a week, better. But definitely after 2 weeks, they become real dogs to do. So is that fair, guys? As I say, I think digits really need to be prioritized, you know, even more. Even like I'm probably more of a shoulder surgeon than a hand surgeon, but I would say, you know, a proximal humerus, they're not nice, but I could do one at 3 weeks, okay? But fingers are really tough by that point to deal with, yeah, digits. So.
What happens if it heals like, sorry, Rishi, can I interfere?
Yeah, please interfere, yes, yeah.
What happens if it heals like this? Forget about the articular surface. There's not a big step there. Rheumatoid arthritis is very good enough, but you know that. It's fine. Articular surface will heal up nicely. Look into the crystal ball. I can tell you, articular surface will heal. This will also heal. Molar-weak ligament is intact. Good. So what is your thumb span? Show to all of us. This is your thumb span. See guys, if thumb is adducted, it heal up with this. His thumb span, his or her thumb span is reduced. What's the problem then? So you grab big things and need a thumb span, isn't it? So you can't grab things, bigger things, like your kitchen, opening doors. You need thumb span for those things, which I'll show you in two-bit rooms also. That's why you want to have thumb span in two-bit rooms and the cord goes to the thumb. Sorry, Rishi.
No, please. It's really important, guys. Interrupt away, because I want you to be clear on this. It's very important. Okay. And they might ask you sometimes, you know, what are the deforming forces? And what I was showing with Mr. Agarwal is basically just about how the reduction maneuver, traction, abducting the thumb, applying pressure at the base, I'm just trying to reverse some of those deforming forces.
Adductor policies and adducting the metacarpal.
Yep, here.
EPL at the base has caused a bit of proximal migration.
Yep.
Those two deforming forces you are reversing.
So you have to reverse that. So that's the way they'll ask that question in the exam. Okay. Right. Now, we are on a hand and wrist course, but Sora wanted me to put this one in because it comes up in every single exam and it's done really poorly. Okay, guys. So you might see this, you might think, oh, easy marks. But actually, what I found is the easy questions in the exam are the ones which are done notoriously badly because you have to be perfect on them. Okay, so I'm just going to run this very quickly for you guys. So if they show you this in the exam, they'll say 5-year-old has fallen from the monkey bars, come to A&E, DGH, 10 o'clock at night. Okay, what do you do? All right, so the first thing you do, describe the radiographs. Show higher order thinking, okay? It's a lateral radiograph of the elbow in a skeletally immature individual, which shows a Gartland 3 extension type supracondylar fracture of the humerus. You could also say the anterior spike, could that be open? It's just something to be aware of, okay? So what am I going to do? Well, clinically, make sure there's no evidence of NAI, but on examination, I want to basically document meticulously the neurovascular status, and you need to be specific about what you would do. So I'll check the peripheral pulse, radial pulse and cap refill time, and brachial pulse. I would also check each of the nerves. So you put it in terms that the child understands. So radial nerve by doing a thumbs up, median nerve by doing an OK sign, ulnar nerve by making a star. Okay, the examiner, if you don't volunteer that, they will get you to volunteer that. Okay, I would also check for compartment syndrome, check that they're nice and soft, and I would check for a pucker sign, which is a sign that the anterior fragment may have puckered through brachialis, and this may not reduce closed. All right, they will almost certainly say to you, it's a pink pulseless hand, 10 o'clock at night, what are you going to do? Okay, so my answer for that for the exam is you've got to think to yourself, how do I get through this question? Nice shallow waters. How do I avoid getting into an argument in the exam? And what you don't want to do is you don't want to be getting onto like SCAGs, you know, the merits of taking a pink pulseless hand in the morning or not. You want to sail past that and get onto lateral or cross K-wires. What's the evidence? Cubitus of errors. That's where you want to be going. So just say to them, you know, no, I would take it in the middle of the night. Okay. My reasoning for it is according to the latest BOST guidelines, a pulseless hand, even if it's perfused, is evidence of impaired vascularity. I would make sure that I speak to vascular surgeons before or have them on standby in case we need to open. All right, so you've covered yourself and you've moved on. So this exam is all about sidestepping the obstacles and getting onto the scoring opportunities. All right, so the next part will move to you're in theatre. So that will get you the 6. The 7 will be you're in theatre, what are you going to do? So 4 steps to reduction. Step 1, apply traction. And when you apply traction, don't just pull as hard as you can, orthopedic brute strength. I want you to stand there, you and your assistant, and I want them to lean back for 5 minutes. Just watch that clock and don't touch the patient. So literally leaning, both of you. Gentle traction, okay? Make sure the patient's nice and relaxed, all right? And that is to correct the length. The next thing I'm going to do is I'm going to get my radiographer to turn the machine slightly oblique and correct varus valgus, a so-called column view. So step 1, length. Step 2, varus valgus. Step 3, I'm going to flex it up, okay? And then step 4, if there's medial comminution, I'll pronate, lateral comminution, supinate. Now, I know in reality, we don't really do that. We just do this and this until it looks normal. But I'm just giving you words from the AO website. So just say that for the exam, all right? The next thing you're going to do is you're going to basically fix this, all right? So you can go either for a lateral or a cross K-wire construct. In vivo, there's no difference. In vitro, cadaveric studies have shown that cross K-wires are slightly stronger, okay? 2mm K-wires. The only thing is, whatever you choose, you've got to use the words or terminology for the exam. So if they're lateral K-wires, you've got to say, I would get bicolumnar fixation with divergence of my K-wires. If it's cross K-wires, you must say, I would make a mini open incision, visualize and protect the ulnar nerve. There is no room. I would not just say for the exam, I would say in real life, there's no room just to basically feel that, you know, without visualizing it. You cannot defend that. Remember my word at the very beginning, what can you defend in a coroner's court? I can defend it if I visualize that nerve and I've protected it. Okay? And you'll never be criticized for, forget this bullshit 1 centimeter incision. you make the incision to, if it's my child, I want a safe operation. All right. I don't care if the incision is 3 centimeters. All right. Scars will heal. I want you not to roger the ulnar nerve, please, if you're looking after my child. Okay. And I want you to safely do the operation. That's what I want. Okay. You can make tiny incisions when you're the world expert. You've done 5 million of these. Me as a day one consultant, I'm going to make a safe incision in any operation. Okay. That's my priority. Okay, good. So the next thing to do is medial. So if you do cross K wires, you want to say that you would cross proximal to the fracture site. Okay, and then there's what I call markers of reduction. How do you know you've got a good reduction? So you could compare with the other elbow on the AP, check that Bauman's angle has been restored, but you know, in reality, that's quite difficult to see. So on the lateral, just make sure the anterior humeral line bisects the capitellum. And then this is the other important point, guys, to get the top marks. Always, once you've done that, check an external rotation view and an internal rotation view. Okay, I say this from my own experience as a registrar. I did really nice from the middle of the night, got a beautiful review. Oh, it looks fantastic. And then it displaced. And the consultant was like, did you do that view there? I was like, no, I didn't. So I did all the views, I did that, but I didn't do that view. Okay, so that's taught me, you know, so everything I tell you, I've made these mistakes before. Okay, so you know, with you just giving you these tips so you don't there. And then afterwards, they may give you something down the line. The patient comes back 6 months down the line, they've got a cubitus varus deformity. What do you do now? So most of the time, you're just going to observe it, counsel the parents, and they usually resolve. If they don't, and they're symptomatic later on, you might do something like an osteotomy, maybe at skeletal maturity or something like that. Okay, any questions there, guys? Because that's quite a difficult topic, you know what I mean? So break it into 3 parts. The 6 is the initial management in A&E. The 7 is the steps in theatre. And then the 8 may be the evidence for lateral versus cross K-wiring technique and how do you deal with a salvage situation such as a cubitus varus. I've also seen examiners give you something like the patient's on the table and the pulse disappears when you flex it up. What do you do? So my answer would be, I would take one of the wires out, leave one wire in, try and extend it until the pulse comes back, and then maybe then put the wire back in. If it still doesn't come back, you may need to take the wires both out, and you may even need to explore if you have to. Okay?
There's something similar when everything fine, neurovascular, just on the bucket sign there. Would you take the patient overnight?
The pucker sign?
Yeah.
No, so I mean, I've had a pucker sign quite a few times, and what you do is really good traction and just milking it for 5 minutes. Milking it, it does come with good. The only reason I take it in the middle of the night. I mean, do you do that sort of? You don't have to take them in the middle of the night if there's no vascular injury. Oh, so you're saying there's no evidence of neurovascular injury, it's just a pucker sign?
Only pucker sign.
Oh, right, okay, yeah, then you could potentially leave it till the morning. But my own experience is, having done one last year, I left it overnight, pucker sign, and it just became incredibly difficult to reduce. And I had to make medial and lateral open incisions just to do that. Whereas Gartman 3s, when you take them in the middle of the night, they're just a lot easier. But sometimes logistically you can't. The theatre may be full or whatever like that. So
if we do up to 12 o'clock, I'll do it.
Yeah, if it's 3 in the morning, then leave it. Exactly. Then it's no point.
As which
Yeah.
includes swelling. It's not evidence says swelling makes close reduction difficult.
Yeah. So I had one which it came at like, I think 11 at night, and I left it. And in the morning it was really difficult I had to open up basically. And so after that, I'd probably do it till about sort of midnight, 1 a.m. And then after that, yeah, fine. Exactly. Just leave it.
You have a problem is next day.
Because the other thing you've got to consider as well is the staff overnight. You know, do you have orthopedic staff? Do you have safety? All that kind of stuff. Is the anaesthetist happy to anesthetize a young child at night? Some hospitals they're not.
I think the OA says you take it overnight, but in practice this is what happened.
Oh, it was a pucker sign.
Yeah.
No, for vascular injury.
Skin necrosis. Due to my developed skin necrosis.
I wouldn't do that.
Pucker sign means the bone has come off the
muscle. Yeah. So the way that you reduce that is different. You don't just put traction, you have to keep milking. So you literally have to, quite firm pressure, just milking. So I would, if I had a pucker sign, actually, if I can, get 3, I've done it with 2 other registrars. So one of us applying traction, counter traction, the third person is just milking constantly.
or if there's two of you, one applying calf traction and milking with their other thumb, you know, really good firm pressure. You can, and you actually see the bruising start to resolve. It starts to get better. You know what I mean? They're not easy. They're not easy at all. The other technique, just a quick tip, guys. One of my spinal colleagues showed me this technique, and he from his training, which I thought was a really nice technique. He actually said, "Look, you've got such a nice reduction. You do it at the start, and then you prep up and you lose it, or something like that." So actually, what he did was, before you even prep, he does traction, counter traction, gets a really nice thing, and then basically gets the registrar to essentially prep and drape themselves, put the thing on, prep just the lateral side of it, and then they put lateral wire in. And then what you do is you're holding the arm basically reduced with the lateral wiring, while the nurse then drapes, preps the whole thing, and then you then, so actually, and I use that, it was a much easier thing to do. It actually worked really nicely.
Practically yourself, but not for an exam.
Not for exam. No, but you're not doing anything wrong. I'm not saying you're not putting it in, not sterile. I'm saying they're actually going in and they're prepping the arm completely. So they prep, you know, all you're doing is just holding it, but they're prepping everything. They're putting one wire in. You're still holding it until they've, you know, the nurse has prepped, draped everything else, and then you go and scrub. But you've got to wire in. We always do that. We reduce it beautifully, and then we go and scrub, and it's gone. And you're like, well, why did I put in that, you know, effort and work and stuff like that? So, you know.
Last question.
Yeah.
When you talk about evidence, when you're stating it, let's say against something,
yeah,
we always say it in not so, let's say, like confirmed terminology, like quote the paper. Or is it better to say it if you know the paper, or can you just say studies have shown that you know, crosswise are better than
if they ask you specifically, I mean, you do not need to quote evidence, guys, to pass this exam. So, but if you do say something, then they may be prepared that they may ask you about that paper.
What would you advise people? Would you just stay away from it, not to say that at all, or say that studies have shown that crosswise are better than that, but I can't quote any papers that
I would stay away from it unless they specifically asked. So if they said, you know, the difference between the two, I would say studies have shown that in vivo there's no difference, but in vitro or cadaveric studies, it's biomechanically stronger. Can you, which study is that? I can't name the exact paper at the moment. Well, move on. Don't get stuttery. If the examiner pushes you, they've asked me, they've like, I stupidly said Parvise's criteria for MSIS infection. He's like, can you name Parvise's criteria? And I screwed myself. And I just said, look, I'm so sorry. I've drawn a blank. I can't remember at this moment. Move on. Score other marks. Yeah. It's all about sidestepping, you know, avoid don't let the great white sharks into the cage. Do you know what I mean? So
how frequently would they go to acute as far as, is it a common question?
Usually, if you are doing very well, I've seen the mark scheme, they will go to some sort of salvage scenario, but most people don't get that far because they waste time. So the other thing I've seen asked is, actually, I think, yeah, so one thing I've seen asked here is, so that's the standard, what I was saying, divergent for lateral K-wires. You can see here that the anterior humeral line bisects the capitellum. Oh, no, I didn't put the x-ray in. Ah, okay, sorry. I had an x-ray of one that had displaced with a cross K-wire, and it's because the wires were crossing at the fracture site. So I was going to get you to critique that x-ray. Sorry, but it's just to say that, yeah, so lateral K-wires, in terms of divergence, I have seen the AO website, and the way that they quote it is they say at the fracture site, the distance between the wires should be more than a third the distance across the fracture. That's what the AO website says. That's how much divergence you want. Does that make sense, guys? So if I look at that horizontal line where the fracture is, that distance there.
I'm going to draw some lines for them.
Oh.
Show me the K-wire, how we put it.
Oh, okay, yeah, very nice, very nice. Yeah, good one.
You can't escape.
Rishi.
Yes,
Rishi, can I take a question from the audience?
Yes, please, guys. Yes, please ask me an question.
Okay. One Dr. Ignatius Liu has asked a question. If I am in a district general hospital with no vascular surgeon backup, do I say in the exam to transfer? That means to transfer to where a place where microvascular or plastics are there.
In the exam, yes, or at least so you would discuss it with vascular, but ideally, if there's a potential that it's a vascular injury, you should transfer it, or you should at least say that you discuss it with them first. If they say, look, the transfer is going to be delayed and there will be an unnecessary delay, then you would say, fine, the thing which is going to relieve the pressure on the vessel is by reducing it. But my answer for the exam would be discuss it with the vascular team first. And if there's no vascular team on standby, transfer it to one which does have it. If there is a vascular injury, if there's pulselessness.
That's only if there is a suspicion of a vascular injury, right?
Absolutely. So if this is a pink pulseless hand.
Okay. Thank you. You can continue, Rushi.
Okay, so I think that's the end of my talk, guys. I was going to go on to Saurav next, but I think Saurav wanted to test the guys here about wire placement.
Just a little something came to my mind.
Yes, tell me.
Hitesh, give me 5 or 7 minutes and we'll be back on your
Okay,
live.
okay, Saurabh.
Yeah, so just pause for about 5 to 10 minutes. Yeah, great.
Brilliant. Check out the lights. It's just, you know, what the KY in general to test the radius.
Yeah.
Let's see how much. So guys, can we, you need to come forwards because these are wires. It's really hard. Shall we start with supracondylar?
Yes.
Rishi, great lecture. I learned a lot.
Is it?
Now put it into my practice.
Saurabh, can you show us the board? Is it possible to show?
Yes, we'll do that. Let's
Is it
just
possible?
Yeah, I can do that. So let me see this today. If I do like
This way, yeah, that way.
Yeah, and then we'll get the delegates to.
Can you see the board now?
They can see the
Yeah,
board.
we can see the board. Yeah.
That's the camera there.
Okay.
In fact, why don't we bring it as close as possible?
Can you see it now?
Is that better? Good.
Okay, brilliant. My diagrams will not be good, but yeah, it's fine.
No problem.
Right. Let's discuss some supracondylar and let's discuss KY because KY, we do it day in, day out. In fact, SHOs want to do them. What gives me maximum grief in my clinic is wires. Nothing more, wires. Miss Reichert knows firsthand. I discussed a case with her and she bailed me out. So again, I want to draw a humerus. Don't laugh, yeah? Whichever, yeah? The time is important. Let's say this is radius, this is ulna, yeah? So that's your, yeah?
She can you move a bit?
Oh, yeah.
That's perfect.
Supracondylar fracture. You've got a supracondylar fracture. Put 2 wires. Put 2 lateral wires. Wherever, you have the choice now, see? Take your time. Later you'll say I was not thinking, huh? Take your time. Once you've done it, you can't take it back. It's like chess move. You're not allowed to take it back, yeah? Take your time. I should have drawn 4 small. Anyway, it doesn't matter. Yeah, go for it, sir. Beautiful.
I'll end here.
That's fine. What's your name, sir?
Kazi.
K for Kazi. I'm going to draw a small more here because we should have drawn 4 here. Same radius, ulna. Another person draw 2 wires. Doesn't matter, you can copy this. It's only wires, right? So take your time. Otherwise you will say I was doing left hand.
Use left hand.
One wire done.
Cross outside the
This you can't come. Why are you doing it?
So this should cross outside the
You do what you want to do, sir. See, I told you take your time.
So this should slightly up here and then.
Do okay, 3rd wire now. Do 2 wires, yes? And take your time.
Is it only for lateral wires? Lateral cables.
We'll come to middle also, don't worry. So, N for yes. Okay, who wants to come next? Hitesh, you can see it. Hitesh?
Yes.
Okay, good. Who wants to come next? Radius, lateral wires. It's just 2 wires. We've all done them, haven't we?
Cross or both?
Lateral wire. You would learn from me and now.
And can I just say, I showed you an X-ray previously which showed the 2 lateral wires. So
Take your time, no 3 wires. Then we'll do the wire. And we'll do 4 and then we'll discuss, okay? Because yeah, your name, sir? Yes, Sohail. Great cricketer. Okay, last. Who wants to come?
I can come.
Beautiful. 2 wires, yeah? Don't be like Milind.
Miraj.
Miraj. Good. Right. So what's the thinking behind Miraj? Why did you do these 2 wires?
So my plan is to
keep it divergent,
Okay,
longer span,
okay,
and opposite cortex.
okay. So here,
So yeah, so you want to get at least more than 50% length of the fracture itself, and you want to have at least more than a third between the KYs fracture itself.
okay.
Why do you have it crossing within the bone?
Oh no, so I mean that's cross. That's
It's
probably
wrong.
diagrammatic.
I know that, it's wrong. Qazi?
So divide the fracture into 3 parts, one third, one third, one third,
Right,
and roughly in your mind, draw a point at the junction, 2/3, 1/3, 2/3, 1/3,
right.
and then these wires should be
So
there.
1/3,
but they
1/3,
should-
1/3. That's
yeah.
what you've done. Melindu?
Divergent, and then wire should cross outside the bone. And
Yeah, this is fine. It has to for you to do this. Okay. So what's your separation? So Qazi said 1/3 rule. What's your rule?
I'm trying to get the 1/3, 1/3 here, but it
You
ended
also
up in
have
here.
1/3 rule?
Yeah.
1/3, 1/3, 1/3?
Yeah.
Okay. Is this also 1/3 rule, 1/3 rule, or any other rules, or
Just to say that comes from Tajian.
the final roll of dice? What's the best possible construct if you were allowed in 2 lateral wires? I can if I do this and this, if I get a wire, yeah, this is me, let's say. Yeah. Which one should we accept out of all those 5 and why?
The entry point is same here.
You can see, I have to put a wire. To put this wire, I can start here, here, here. How does it matter? So this doesn't matter. What we're talking is here. So there are 5 constructs here. I may be totally wrong. Which one will you pick and why?
More stable and reduced.
More divergent,
Which is the most stable?
more divergent.
So I would assume this because it's most divergent, but then your wire is very close to the fracture site.
And why is it so difficult to put? You can with experience, at least you can aim for it. So why did none of you aim for it? Why could you not put a wire here? It may be difficult, but it's not impossible. At least you aim for it, then your wire will go there. So this is the strongest construct because there is maximum divergence. Yeah. I'll not spill the beans. I'll just invite one of you to do cross wire for me. So there are a few questions we are answering here. Radius, I'll not cross wires. Anybody? I shouldn't have actually done my bit because we don't waste time. It's completely wrong, sir. Completely wrong. Sorry, guys, I'm being hard. Because of time sake. Okay, radius, I'll not million. So see, in Supra model, how many construct, how much thought process, yeah? So that's why when registrar saying 10 o'clock, can I do the wire with me half asleep and trauma list next day?
Should always cross about the fracture site.
So I don't know, sir. You do it. I'll do 3rd wire now. Because you are a happy, okay, 3rd wire, you're my friend too. So I don't know, you go anywhere. Okay, you've gone there.
That's out.
Are you happy there?
It should go somewhere around here, but
So why do you not do it when you have a chance? Okay, I'll do dotted. Okay, there. Are you happy now?
I should cross this one.
It's crossed here, and then it will keep going. I'm only concerned here. Villain too. Okay, one more. Still not happening. Who wants to come? But where's nose? You want? Don't be like me. No.
Again, not going.
Just go to the practice, sorry.
Okay. Take one more attempt. No. I want it. Good. I like this. You like me. I like it.
Do you know what the easiest thing to do? Before you draw the wires, draw the. Oh, no, sorry.
That's fun. This is a young impression.
Yeah.
This is the only time I have some joy in my life, my sad life.
Okay, sorry. Curved wires, that's good.
It's not, yeah, okay, fine. Your name, sir? A. Yeah. Okay. So these are convergent, those were divergent. How what determines the biomechanical stability?
The distance of the wires at the fracture site.
Correct. So is this distance good? So again, you had a chance. Why can't in real life also aim like this? And aim like this.
Problem is,
Isn't it?
I can't engage the opposite cortex. It just slides through the medullary canal.
It will engage. You can never be this close. It always engages. It will engage far above because I've been doing it for 10 years. So I know it will engage. Yes. Maximum. So how you remember this thing is, I'll tell you. First thing first. So how you remember it? Remember just one line, simple line. Maximum separation at fracture site. Maximum separation at fracture site. Yeah, can you remember that? So whatever fracture you do, supracondylar, what is the maximum separation here? You can't go here, or it's impossible. So in your mind, when you're aiming a wire, you're going like this, and it will cross very high up. It definitely goes. When you're going here, it goes and crosses. Make sense? And if you're doing two lateral wires, again, I'm aiming for this point, and I can do two lateral wires. Yeah. If I'm able to achieve these two lateral wires, they are as stable as these two convergent wires, as Rishi said. But the problem is, and in real practice, try and put this wire so close to fractures is very hard. Because first, we do not know, second is night, third, we're tired, and it's hard. Yeah. Whereas to put two convergent wires in these two dots is easy. You can try it. That's why they are saying these days, do two convergent, nice guy, despite ulnar nerve being here. So they know at least you'll get two wires and they will not rotate. So another audit for you, pick up last 20 supracondylars, and I bet we've done the study here where it's hidden. Nobody gets this separation. And that's why they rotate. If you see plasters, week 1, week 2, and you put the wires, it rotated. This is the reason. There's no maximum separation. And go and see audit, you'll know. And then you've changed the practice in your hospital. That's why two convergent are better than two lateral, because they're easy to put, not because they are biomechanically more stable. Makes sense. Last question, ulnar nerve. Well, second. Ulnar nerve is here. How does it get damaged with this wire?
You put it in flexion, because in flexion.
Fine. You've taken all the precautions. Nerve is still damaged. How does it damage? You go through the nerve, or are you next to the nerve?
Next to the.
Next to the nerve.
Next to the nerve. It's next to the nerve, isn't it? So you've seen the boy now, and the nerve is damaged. Then what do? It's fine, you take it out or recite it or whatever you do or not do. So ulnar nerve has motor component and sensory component, isn't it? Now mom is not happy, child is 6, that's the age, it happens. Motor and sensory, they say, okay, what's going to happen to my child in terms of motor and sensory? What are you more worried about and why? Motor. You're worried about motor. Show of hands. Who's more worried about sensory? Who's more worried about motor? Nothing is right or wrong. It's thought process. Quick. Motor, who's worried? Motor 1. 2. Who's worried about sensory? 1. Why is important? Yeah. Who's worried about sensory? Who's not made up their mind?
Both.
Huh?
About the both.
Both. Life is which is more important. Both. Everything is important. Which is more important? Sensory more important. Why? Because motor, mom asks you. You can say worst come worst, I can do tendon transfers. You'll give some functions, ankles or whichever. Sensory, what do you do? Finished. Fingers are numb. Drop things. Sensory more important. Okay. So few questions relevant to this they can ask you. Last thing, distal radius fracture.
Well, the lateral, there's no difference in it.
Sorry.
The lateral view is there anything that you want to achieve in the lateral view of the
I will cross wherever. I can almost prove to you 3 wires are better than 2, and people will accept it, but we don't want to. We don't. The joke guys are giving time. Radius. Put 2 wires. Now it should be easy, I hope. Otherwise, I'm going to cry. Exactly. Think of this first. Beautiful. Take your stylac wire. Beautiful. And then there you go. Yeah. Where you start there or you start straight. So think of this. Yeah. And go and ask your colleagues for distal radius wires. They will all get it wrong. Think of just this thing, you will never go wrong. Then I should have actually kept asking these scenarios, and all
that's actually very nice because a lot of people don't appreciate that with distal radiuses.
Yeah,
but if you think of it as supracondylar, an upside down supracondylar, essentially.
And pick up distal radius and you do an audit. 50% wrong.
Is it called the working length of KY or something?
No. It's just maximum stability. Simple.
Hey, that's a
simple.
great order. I'm going to nick that.
You
My juniors are always asking me for
I learned
orders.
so much from the lecture. I have to give something back.
No, my juniors are always asking me for these orders. So.
Radius and the lateral condyle. How will you put two wires? Anybody, now you should know what you're looking at. Come, Nilindu. This time you do 4 wires. Maximum separation is where? There and there. And start here. One goes there and one goes there. Yeah. So the only way you could have had maximum separation in your lateral condyle in a child is with divergence. You can't converge like this. Because how will you put wires? It makes more sense, isn't it? So now you can pick up any fracture pattern. You think of two, you just think of fracture line, think of separation, and put your wires. Is that it? Does this help?
Yeah, definitely.
Good. Brilliant. Thanks, Hitesh. We'll do the lecture now.
Thank you. Thank you.
Yeah, sure.
Yes, brilliant. We'll do the lecture, Hitesh. Thank you.
Great.
So, Saurabh, you're next now.
I'm next.
You're doing trauma.
Brilliant. Thanks, Rishi. Thank you.
Yes, and how is this
Will you open my lecture? Guys, so it makes sense, yeah? Hitesh, we're starting in 2 minutes. They've gone to the toilet. They're nervous now.
He's upset them all.
They're nervous now.
No problem.
They want to pick up their guns from the car. They're upset. Simple, yeah? If you can break orthopedics into simplicity, then you are always fine. Otherwise,
opening sorry.
rotate, and then you tell your consultant, I did a good job. No. Because separation is not there. My data, I draw one more line diagram for radius splitting, whole radius.
Hitesh, can you see that?
In 5 minutes.
Yeah, Rishi, it's clear. Saurabh's talk, is it?
Saurabh's talk. Saurabh's doing the next bit. So I've talked about some of the decision making behind hand and wrist trauma. Now
Okay.
Saurabh's going to take you more through the operative tips and tricks.
Great.
Yeah. Okay. So just give us 5 minutes to let everybody settle down. Yeah.
No problem.
No worries, boss.
Move it to March.
So, shall we start, guys?
Yeah, Saurabh, are we ready?
I think we are ready, isn't it?
Yeah, great, perfect.
Okay, we'll just. Okay, brilliant. Thanks, Rishi. Great lecture. Learned a lot. So next topic, guys, hand and wrist trauma. Arjun, will you switch off the lights, please? So following on to Rishi's lecture, so I'm going to cover the other topics. Lunate we have discussed, right? Can I invite someone to have a take on this? I'll take you through, promise. Switch the lights, Arjun. Very bright. So what do you see on our X-ray, guys? Or a radiograph?
So I think we've seen this before. This is a lateral plane radiograph. It shows a fracture of the very styloid. There's an abnormality where the lunate should sit. So this is a trans-radial perilunate fracture dislocation.
Fantastic. Fantastic. Perfect. In A&E, you will do all your open fracture guidelines for time's sake. So I'm just rushing. Investigation, what would you do?
I want to document my neurological and vascular status in specific median nerve because of where the lunate tends to sit within the carpal tunnel itself. And investigation-wise, once if I can manage to reduce it, splint it, and I want to get a CT scan
okay.
to assess any further osseous injury.
Brilliant. So you've done a CT scan, it's confirmed your suspicion, styloid and lunate. And then, so that's your lunate, that's your open fracture, correct? So what am I showing here? What am I doing here?
Doing an extended carpal tunnel incision. And the tendon that you can see is that your FCR tendon.
Good. So lunate is no longer seen. That means I've reduced it. Yes. Where have I reduced it? Which space is that?
Space.
Why is it a weak space?
It's a weak space because it's in between the proximal and distal intrinsic and extrinsic ligaments.
Extrinsic ligaments. V-shaped, centered over lunate and capitate. So good. And then K wires, you know, so we're not going to waste time on this, isn't it? Like we've done for all the ligaments. So you put your wires. Yeah, happy-ish. Okay, so what am I showing here? So I think it's 37 male, he fell down. So Galeazzi fracture, do we agree? Yes, because drudge is all off. So see, drudge again is hard to pick up, isn't it? A lot of times I have registrars in clinic come to me, even consultants, saying, oh, I feel ulna is out, head is out. What do I tell them? What do you think I tell them? All of them. Is it a true lateral X-ray of the wrist? Well, unless it's true, how do you know? So anybody can tell me what's a true lateral radiograph of a wrist? How do you know, when do you know it's a true lateral radiograph?
So in the lateral X-ray, there's a line that we need to check between the scaphoid and the.
So pisiform should superimpose on scaphoid tubercle. That is very important. Unless that is the case, I do not comment on drudge, unless it's bando, like in this case. Yeah, because I can see so much radius angulation. I know ulna has to be out. Make sense? So please remember what's a lateral radiograph of a wrist, yeah, for you to comment on drudge. Not a very good fixation in the sense radial height is a bit, but it's okay, doesn't matter. At least ulna head is back in. So that's principle is you will reduce, you'll put a plate on radius, and then ulna head should come back in, and you will check your rotations to make sure you got it right, okay? This is just a cadaveric dissection because I thought ulnar collateral ligament is important. So this is how, like I've been showing you scapholunate ligament, so, ulnar collateral ligament. Have you noticed they're pretty similar sort of width and how they look? So same, this is your UCL there, right? So they can show you a skier's thumb or a gamekeeper's thumb, normally a skier's acute injury. UCL is gone. Remember on our X-ray, if it's with a bone and it's undisplaced, you don't want to do a stress test because you can displace it and cause a Steiner lesion. Yes. So always ask for X-ray first, see if it's undisplaced, never do a stress test, put them in a scaphoid cast. If obviously there is a Steiner lesion, then you have to operate. Yes. So this was just to show you how UCL looks and the precaution you take in a undisplaced, avulsed UCL injury. Sagittal band, again, it can be traumatic or it can happen in your rheumatoids. This is just to show a video for you to make an impression of watch these two fingers, middle and, I think it's middle and ring, or is it index and middle? See how, now, see, can you see the extensor tendons falling into the ulnar gutter? Yeah? Yes? So that's a sagittal band rupture. And see on table, this is how it looks, sagittal band. And you have to repair it. But idea was to show you how clinically it looks, and you open it, that's your tendon obviously there, and then you repair it or reinforce it or tighten it. Yes? Make sense? This is the case we were talking about, distal radius plate. FPL will rupture, rub on it, and around 1 year and a half, patient will come and say, oh, all of a sudden I've lost my thumb IPJ flexion. Yeah. So in that case, you have to do a tendon transfer. So you need to know principles of tendon transfer. So normally I would take a FDS. So let's go through these operative pictures and see what we're doing. So that's FCR. Yes. Obviously you have to have a big incision because plate needs to come out. And then I need to take a FDS to ring finger. So that's my ruptured FPL. Can you see? Compare this FPL now to the shiny FCR. So see how tendon lose their shape, their texture, their glistening surface. And we have other tendon transfers for Vaughan Jackson, which Miss Reichard and I did just 2 days back. So we'll show that also to you. But so it's gone. It's an attritional rupture, big gap. You can't do end-to-end repair. So I will show you what I did. So this is the first thing you do. The sling is holding the FDS to ring finger. When I pull on it, see finger flexes. I'm not holding the finger here. And I know it is not FDP because I can passively extend it. So I know FDP is not, it is pure FDS. Yeah. Remind me to check how you check FDS and FDP after this lecture. Clinically, we'll see. So once I know this is FDS and not FDP, then you'll take it off from A1 pulley. You'll take it out there, which I'll show you in the next picture. See, FDS I've taken out from A1 pulley, and then you take it under the median nerve. You don't want to compress the nerve. And normally your plate is there where my arrow is, but it's an attritional rupture. So your repair is not at the distal radius rim, it's further down somewhere here because there's a big gap now. Okay, so remember that point. And then if I take you to the next, see, that's where the weave is. Not over the radius rim, far down, 2 centimeters down. So it's a pulvotaft weave. You can be asked, who can tell me what's a pulvotaft weave?
Substance changing weave pattern.
Correct.
So you split the tendon and then use the other tendon inside and take some turning sutures, turning stitches like that.
Correct.
Is that when there is a longitudinal traction, it will cause compression at the repair center?
Okay, good. Very good, Aarti. I always knew you will make a better consultant than me. So see, what you both of you are absolutely right. So you take a knife, you make an incision, you pass the tendon as Milindu said, and then you put a stitch under maximum tension. So they will ask you describe pulvotaft weave, because if you can describe it, you understood tendon transfer. So very important, pulvotaft weave, yeah. And then you go at 90 degrees. So it doesn't matter. So easiest way is to show with a roll of paper. Do we have a roll of paper? So if we have a paper, you make it into a roll. If I make it into a roll, this is my tendon. You agree? Yeah. And let's say this is the FDS which I'm transferring to the thumb tendon. You take a knife, you cut artery comes and my tendon comes down. Under maximum tension, you put a stitch. So you have to just go at 90 degrees. When I've gone like this, next plane can be this, come out, next plane can be up, down, or this way. Like you keep going 90 degrees. Stab, tendon comes out, stitch. And what you do is, after 2 stitches, you now need to, so once you've, so like in this picture, you do 4 weaves and 4 stitches, but after 1 or maybe 2 stitches, you need to check the tension. Have I built in enough? Because post-operatively, there'll be myostatic relaxation. Muscles will relax. So whatever I build in, it will relax. So if you see here, see, I'm not holding this thumb. Do you guys agree? And I've got very good flexion in IP and even at MCP. So I've really tightened it because I know this will all extend later. So you do 2 stitches, you check if it's like this, you're happy, then you do 4 weaves and then you cut the remaining tendon if you have any length left. Yes? So that's one thing. Second is straight line of pull. So remember my FDS is coming from here and then going like that. So I have to release my tendon through and through like any adhesions or anything so that it's in a straight line, not coming this and this. Because so it should be straight line of pull. So this is what you mean by straight line of pull for your principle. Make sense, guys? And see what I'm doing here again. This is still intraoperative. When I'm putting pressure on MCP, if I do this, my thumb should automatically extend. It is still flexing. Yes, because I've got good tension. So now I'm happy that I've got enough tension. Make sense? And 3 months later, so you can see the scar, same patient. 3 months later, you see the, very good flexion there. Yeah. So if you build in enough tension, tendon transfers, good flexion will work well. Yeah. So that's your FPL for distal radius. Scaphoid unit we have covered is the same X-rays. You know that, you know this, you know the Gilula lines, you know the Dissy angle now. Do we agree? And again, same operative pictures. Yes. So retinaculum I've cut in my forceps. 3 bones I can see: lunate, scaphoid, capitate. That's my partial capsule flap, my Mayo flap, if you like, but you can say burger flap and make a burger flap. That's the scapholunate ligament. Again, you do joysticks, 2 wires, 2 anchors, capsulodesis, job done. This we have done, so I'm not going to even waste time on this. Tricuteral. Okay, so now lots of X-rays for distal radius. Are you guys, excuse me, asked distal radius in the exam, or is it or can you be asked? Okay. So see, as Rishi was saying, if you're shown a distal radius, it's not going to be a straight one. There has to be something going on. So for example, this looks fairly innocuous, but it's this step here I was a bit worried. And look at the dorsal tilt. So I said, okay, let's get a CT scan. And on the CT scan, as I've said, see the 3 slices. Volar cortex looks intact in all of them, correct? It's the dorsal fragments which have gone. Now, you could have done a dorsal approach, put a plate from there. Because dorsal approach has issues, I said, why not, in this case, go volar, like your tibial plateau. This wire told me where my step is. Can you see this fragment? Then I made a window, like your tibial plateau. This is a very nice accurate punch, and I'm punching it up. I've checked the volar plate. Yeah. So all I'm trying to say is, if you're shown a distal radius, it's not difficult, but there'll be something to think about. This is quite Bondo. There's a styloid fracture. There's a fracture dislocation here. You can see that, isn't it? What investigations would you do? To do a CT for anything complex CT. And you can see that scaphoid. So you can see scaphoid fossa fragment is very distal, very comminuted. Do we agree, guys? And then lunate. So lunate fossa fragment is all tending to come out. This is carpal instability. Adaptive lunate is adapting to the new environment, if you like. So it's all very distal and all very comminuted. Do you agree, guys? So I said, okay, I don't think I can put any plates to have some hole, dorsally, volar, fragment specific. I said, I'm just going to span it. Yeah. And because you give a plaster in a spanning plate, I left the styloid. You can put a screw, you can put wires if you want to. I said, okay, fine. It looks fairly undisplaced. So what am I checking in a spanning plate is the question, is the key. So one is my radio scaphoid joint. It looks parallel. Do we agree? It's out to length. I've maintained the space and I've not over distracted like in an X-fix. Because if you see my mid-carpal joint space and my radiocarpal space is fairly equal and maintained. Do we agree? And on a lateral also, I can see I've achieved my reduction and my carpus is back. Yes. And then these are your X-rays, 3 months. So plate will come out at 3 months, basically. So so there is a role of spanning plate. That's what I'm trying to say. And the role is when either with volar plate or dorsal plate or styloid plate, whichever plate, you cannot hold on to fragments. So if it's very distal and a lot of combination, yeah. So if you're shown something like that, you can bring your X-fixes or infixes into discussion, basically. Again, you can see there's a bit of a step here. There's a bit of a dorsal tilt and a bit of a step there. Get a CT scan, isn't it? And if you see CT, look at any slice, this slice, this slice, this slice, all of them. Scaphoid fossa fragment, lunate. So I've shown all the fragments, like covered the whole 360 radius. Again, very distal. Do we agree? I felt, again, it needs a spanning plate. So I put it there. Yeah. So spanning plate does have a role. You will do 2 or 3 or 2 a year maybe, but you still do them. This we have discussed before. So who's going to have a go at this, guys? So this patient fell. And this was 2021, so it's fairly recent. So who wants to? I'll take you through it. This will give you confidence in exams. Okay, Kazi, go for it. So what do you see on an X-ray first?
So X-ray lateral on the wrist showing that there is the volar ribs, the distal radius seems to be fractured and comminuted. The carpus are not aligned with the distal radius. It's a volar pattern.
Okay, good, very good. So something is not right here, right? In terms of nerves, which nerve are you worried about? And why is that?
Because median nerve occupies the carpal tunnel and it forms the floor of the carpal tunnel. So any volar displacement will reduce the space.
Correct, very good. So let's say median nerve is fine, fair enough, or not fine, doesn't matter. It can be dealt with in that manner. So now, what investigation will you do? Okay, so why have I put these slices? What am I trying to show here?
The level of combination extending all across, including the styloid.
Okay, so let's look at the coronal CT, sagittal CT, beg your pardon, which is this bone. Okay, so which is this bone?
That's the distal radius
of lunate fossa fragment, isn't it? So that's your volar ulnar corner. That's the key. This you need to get reduced, otherwise we're in trouble. And axial cut, is this dorsum or what am I pointing to with my arrow? Good. So we know this is dorsum, that's volar, that's ulnar, so this is radial styloid. Comminuted? Comminuted? Yeah. So how will you tackle it? Like in terms of approaches, in terms of plates. So for volar Barton, for Smith, you put a plate from the front.
Yeah.
So you're committed to a volar approach. If you feel styloid is comminuted, you can do a styloid approach as well. If you feel like, if you don't feel like it, don't do it. Put through some volar, see how it feels. Put some wires, do a hybrid fixation. There's no right or wrong. But this is how bit by bit you interpret your scans. Axial cut in a wrist is very important. I don't know if your consultants have discussed that with you or not. The reason for that is you see your drudge. You see your ulnar head articulating with your sigmoid notch. So for example, in this case, this is my sigmoid notch is at least in 3 pieces. Do we agree? And if my this dorsal piece was sitting far up, it had displaced. And this piece was sitting far here. Then I'm committed to doing even a dorsal approach. Simple as that. So it may become a triple plating. So this is how you decide for your plates. So your best friends in deciding approach is your axial cut actually. Yeah. Look at this volar. So this is volar. That's your ulnar side, lunate side. Look at the volar ulnar piece. There's a step and it's sort of not sitting proper. And anyways, we know from there and from there. So axial cut in a wrist, very important. This approach we have discussed, radial styloid approach we have discussed, tips we discussed, isn't it? You hold the carpus and then do your 2 approaches and put your 2 plates, yeah? So the very act of surgery is easy. The journey to theaters and decision making is hard. And once you break it into simple steps, it becomes easier. Eventually it falls in place, yeah? Another volar button, even worse, see the carpus where it is, yes? Who wants to have a go at this? Anyone? Kazi? X-ray?
AP.
X-ray? Radiograph. Okay. Or
There is AP and
AP?
lateral
AP?
PA and lateral views.
Good.
Showing combinated distal radius and ulnar styloid fracture.
Good.
Uh,
What investigation? Is it what? Smith? Volar button? Colles?
Looks like a volar button.
Very good. Looks, it is volar button, sir. In exam for me, sort of, because then it gives you more confidence. Yes. Good. So what am I showing on this coronal CT?
So it's a scaphoid fossa that's fractured.
Scaphoid fossa of radius. Okay, the radial styloid. Yeah. Does it look comminuted to you?
Yes.
Okay. What am I? We'll come to axial in a second. What am I showing on a sagittal? Which bone is this? See how far out it is, and it's trying to adjust. So see how it now extends. So this is carpal instability adaptive. Yes. So you know this is bad. And axial cut. Why am I seeing axial cut, Kazi?
Decide upon the number of plates in the approach.
Correct. So how's my dorsal fragment looking? And it looks, and is it articulating with ulnar head? So do I need to go dorsally? Good. So already I know it's the volar ulnar corner is displaced, carpus is all out. I need a volar approach. And then I see the styloid is comminuted. I can do a styloid approach. Or if you think from volar plate, you can get screws or somehow get wires, don't do it. So this is how you decide for double platings, triple platings. Does it make sense now? Because otherwise it's very difficult to understand why are we doing double platings, especially to convince my lower limb colleagues. Same technique I had to do. I stabilized it with wires. Then I went from the front. Then obviously I've buttressed the whole thing. And then finally I put my styloid plate. Yeah. And look at the articular surface. Does it look reasonable now? And does it look reasonable there? And I've taken my wires out, see, in this frame. So, and now, like remember the diabetic patient where I had to put a wire from radius to lunate. Even at this stage, if it was subluxing, then I know the whole carpus will come in the front and this may fail. Yes. So then I may leave the wires for 3-4 weeks. So there's no right or wrong. What is right or wrong is your thinking process.
Just a quick question. Would you think about fixing the ulnar styloid because it's so low in this?
It's so undisplaced. I know TFCC is attached. I know it'll heal up. I'm going to put this lady in a plaster because she started so I have not put this wire as a habit. This carpus, despite opening from the front, was not going back. So I had to really hold it with 2 stout wires. So I know I want these tissues to heal up. So this lady needed a plaster for 4 weeks. Normally with you don't give plasters. If it's a good stable fixation, 10 days plaster, pain, edema, swelling settles down, you get them moving, isn't it? So that's why you don't have to. But it's a good question. And important to see at 2 months, it is this thing I see when I see my X-ray. I see nothing more for first 2 minutes when I see a patient. And luckily, screw is there. It has healed up nicely. It's out to length. Look at the ulno-lunate distance. It's there. There's been no abutment. Makes me happy. Yeah. So volar ulnar fragment is the key. Yeah. Take home message. This was again, it's okay. I don't have CTs, but I had done a double plating, a dorsal NR. So again, if I had a CT, I would have shown you an axial cut. If it was dorsal combination, then you go dorsal. Nothing, no more, there's nothing big in it. Now you know why double plates. Yeah, nothing big in it. This is important. 57, who wants to have a go at this?
PAM lateral, which demonstrates a very distal intraarticular radius fracture with shortening.
Very good.
And, dorsal lesions with some dorsal combinations.
Very good. So see, that's dorsal combination. Exactly. That's dorsal combination.
Yes.
Look at where this fragment is pointing, capsule is pulling on it, right? So is it a bad injury or not a bad injury? Significant, isn't it? Quite combination, quite this, quite that. I don't know what approach to do. I'm very confused still. So what investigation should I do? Okay, I've got a CT. Let's go one by one. Look at the sagittal CT. That's the volar fragment. That's the dorsal fragment. Is it big or small? Very, very small, isn't it? So it doesn't make me happy. I'm thinking, oh my God. Yeah, I actually am when I'm seeing it. Look at this, the shaft is plowed there. Look at the size of this distal fragment, nothing, sliver or bone. Look at all the styloid is comminuted. So good or bad there? Still bad. So I'm still thinking, bloody hell, how will I manage it? Then I've done axial, not very good quality axial cut, but I've got it. Look at the space here, big translation, isn't it? This looks like some cortical piece there, high density. That's dorsal, that's volar, with lots of soft tissue, that's blisters. And looks like the dorsal piece is displacing, isn't it? So God knows what approach to use now and what plate. So we can all work together, can't we? It's very distal. There's a lot of combination. Part of me is thinking, why not put a spanning plate from behind? At least this carpus will be sitting on radius. At least I can stretch it a bit without overstretching. At least my dorsum, this is dorsum will heal up nicely. But then I'm thinking, what do I do with the volar fragment? Remember, capsule was pulling on it.
Sandwich it together.
Correct. Then I'm thinking, can I do a sandwich plate? As our colleague is saying, I put a spanning plate from behind, then I open from front. It's a styloid fragment. I may have to do a styloid screw. I may have to, if it's lunate also, I may have to do 2 plates. I may have to do 1 plate holding anything. It's the principle. So I'm thinking sandwich plate will be good, but with spanning plate, I have to take it out in 3 months. But I was within reason to do that. Somehow I decided, okay, fine, let's try a normal plating. Yeah. So fragment specific. So I went from the front. See, I'm holding styloid temporarily with wire. I went from the front. So I've got hold of my lunate fossa fragment. For styloids, I've got hold of styloid fragment. And I was hoping, sorry, that when I do all this with a clamp, it may come back. You know, I was hoping and see what happened. So once I've done first plate, because this is your key fragment. So first plate, styloid plate, and then look what happened here. What's happening here after 2 plates when I saw the lateral? Yes, look at the capitate, it's still falling off because this dorsal combination is still out. So the carpus is still falling off. So then I was committed to do a 3rd plate. Yeah, it looks like, oh my God, right? But I was committed. So this is how you sequentially progress to triple plating, or I could have done a sandwich plate and then taken spanning plate out. No right or wrong. It's how you are interpreting your CTs and going towards double plate, triple plate. Is that quite okay? But see the 3 months, look at the movements. So I knew this patient may not do well. I've got 360-degree approach and 360-degree plate, and vascularity will be an issue. So I watched her. So I warned her pre or post-op. I said, listen, you may be in not big trouble, but if you're stiff, I may have to do capsular releases. So I said, you need to just see me for next 3 months, 6 months and follow as I tell you. And she was a very good patient. I'm sure I still gave her a plaster for good 3 weeks, not longer, because I have 3 plates now. And if you get them going and patients are compliant, you can see a scar on the volar side and the dorsal side. So you can get good movements. Yeah. Mr. Kaplan's we have discussed, volar versus dorsal. I like to put a wire in Kaplan's, unlike PIPs. I'll just put a wire in 20 degrees MCP for 3 weeks and then I'll get them going. Yeah. What's this? Yes, parilunate. Do we agree? Look at all the carpus. Yes. And something is happening with scaphoid also. See? So who knows? Scaphoid may have, like you, again, doesn't matter. Whatever it should. All I know is it's a significant injury. All I know is I'll attempt to reduce it in A&E. Make sure it's not open, obviously. Make sure median nerve and everything is fine. But get a CT. But why I have put this slide here is to show you one thing. So who can interpret these wires for me first? One by one. It's easy. So see, if I go take you back so that you can't say I'm tricking you, lunate, whole carpus is out. So your which ligaments are gone? Scapholunate and lunotricutal, that's why whole carpus will be out. So what are these two wires doing? Scaphoid to lunate and scaphoid to capitate. And what are the other two wires doing? Which is the bone next to lunate in the tricutum. And what are the anchors doing? These anchors in the carpus. Anchors are wherever, scaphoid, lunate, tricutum, doesn't matter. They will be there. Why are they there? To slap the capsule down, which is known as washing line technique in capsulodesis. The reason I put these two anchors was the dorsal capsule had completely lifted off and I wanted it to slap back and heal up. So I put an anchor there also, doesn't matter. But what happened was CK wires, infection went and see now it's totally infected. Can you see the bones are all going? So they can show you this and then you have to talk about MRIs and debridements and micro and antibiotics, all that jazz, yeah? This was the one I discussed with Ms. Reichart. And yeah. So, okay, what is this injury, guys? Look at this, I magnified it. Pilon type, isn't it? So you can be asked that classification when you have that volar base middle failings. If it's one big chunk, you reduce and put a wire. You can put a screw from the front. If it's pilon type, then you have to do what? Okay, so we have done that. Ligamentotaxa. This Miss Reichart and I did together, I remember. So look at the joint space. So we did distract it nicely. Fine, it all healed up beautifully. And then pilon type, anywhere in the body, arthritis and pain. In PIP, what are the options? Now it's arthritic and it's painful. Okay, so what are the options? You can fuse it or replace it, isn't it? So Ms. Reichart replaced it and he's doing very well. Okay, so PIP replacement, and if you see carefully, it looks like a knee joint, isn't it? It's twice as expensive. Yeah, I mean it. It is. So we are posh hand surgeons, you see. So replaced it basically, yeah. So you've seen the whole journey now of PIP injuries. What's the worst? Arthritis will happen. You can fuse it, replace it. What can you do? Yeah. Both bones, 10-year-old. So how will you manage? There are no tricks. These are all my x-rays. This is what you get in DGH. This is what you will get. All done, sir. Final operation.
So I would consent, I would do a try close reduction and manipulation under anesthetic. If that works, I would put in flexible intermediate nails.
Okay, why can't you put plaster in this? Simple plaster. Yeah. So why can't you? You may be right, you may be wrong.
The fracture is at the same level, so that led me to think that it's unlikely to be stable.
Good, so that's one answer. Second, look at this bone. Is it displaced, not displaced? Correct. So even if you get perfect reduction by manipulation, chances are it'll displace. So that's why. So in exam thereafter, your thought process, you may still be, someone may have gotten away with plaster, who knows? My thought process in exam is same level, unstable. This is all displaced, almost 80-90%. I feel it's going to displace again. Periosteum has memory. I want to put something there and I'm going to put elastic nails. Yeah. So unless you say with a bit of surety, they will confuse you, or they'll say, oh, he's not that confident. Yeah. So we've done elastic nails. Yeah. How will you critique them if I was to ask you? So this has healed, obviously. It's a healed one now. You know the alignment is fine and the bones have healed and sort of there's a good interosseous space and all that. So that's all critiquing. Main is wire. It should be enough out here and enough out here for you to take it out. Yeah. And it should traverse the whole length. Shouldn't stop halfway once. Sort of it should go enough. Otherwise they become loose and start backing out. So you can critique anything in any way, isn't it? Has the healing happened? How's the angulation, interosseous space? Are the wires adequate length? Make sense? Ah, that's a good one. Who wants to have a go? I put the answers for you. I'm nice. Because you guys can give me some of your pizza. Good. So it does happen, isn't it? Fourth, fifth. We all see it. Okay, what's this? Which bone? Hook of hamate, yeah? So which is this metacarpal? Fifth or fourth? Fifth. Hook will be fifth. Yeah, that's how I know it's fifth. So this will become fourth. Yes? So you can see fourth and fifth, they're plowing into hamate and see how they've caused a fracture. What will you do for this?
Reduce and fix the CMC joint, and then ideally you need to fix the hamate.
Good, very good. So how will you deal with your, let's say it was a pure, so we'll break it into simple steps. There's a hamate fracture, there's a fourth, fifth dislocation. Let's say if it was a pure 4-5 CMCJ dislocation, which you see all the time. How do you manage those? So you reduce it, it's reduced now.
Stabilize with the 2K wires.
Okay.
Some use 3K wires, but I never use 2K wires.
Okay.
And one,
so which is the order of your wires now? Where will your first wire go? Where will your second wire go? And why?
First wire is the proximal one.
I don't know, you described it to me.
So first wire is the proximal, which goes from, so I will make sure that the spatial nerve goes somewhere like this, and to make sure that it's protected. I make a
Various other nerves are on the dorsal. So wires will go from the side. Right. You don't want an issue for the wires. You agree? Okay, good. Where is the first wire going? Where is the second?
So the first wire, what I will do is go from the base of the fifth until to the hamate.
Okay.
And second wire from the fifth metacarpal to the fourth metacarpal as well, and then some can drive into the carpus bone as well, depending on the instability.
Okay, drive into the carpus.
I mean the capitate.
Okay, so second wire goes there, and since you love your wires, take a third wire now. No, you're happy with 2 wires.
2 wires.
Okay, anybody wants to
And
have
I
a
need
go?
to take a proper lateral view before.
They're gone beautifully. Very good. They're gone. They are in hamate and capitate. Anybody wants to have a go? It's just wires.
Fifth metacarpal into the hamate.
Very good.
The second I'll place from the fifth metacarpal base into the fourth metacarpal base.
Not getting presented like the answer. No,
The second, so from the fourth base into the
out there. So exam is not difficult. If I was taking exam, I'll ask you to do stuff. So any other takers? It doesn't matter. Yes, okay.
It's a just pure dislocation of the fourth and fifth.
Pure dislocation.
Pure dislocation. Then it's the first wire from the base going into the metacarpal into the carpal bone.
Okay.
And the second wire would be the tough wire, is the fourth metacarpal base going on to the carpal bone. The angle is very difficult to reduce.
Okay.
Get it
Any other takers?
I think both the wire has to go through the fifth metacarpal. The first can incorporate only the hamate. Second has to
So
incorporate the
first wire from base of fifth
to the hamate.
to the hamate.
Second, fifth, incorporating the fourth going to decapitate.
Fifth, fourth capital, right? We will go. Any other takers?
And then we have to check lateral view.
It's gone beautifully answered. For that I always give. I never say it's gone anywhere. I'm that way very generous.
Wire across the bases of the fifth, fourth going to the third.
So your first wire is?
No, so the first one is from the fifth into the
hamate.
hamate. The second wire just across the bases to the third.
Fifth to the fourth to the third. And why is that, sir?
Just to fix it, because those are the ones that are dislocated. Should transfix fourth as well. To the third,
Okay.
because the third is not dislocated.
True. Agreed. Any other takers?
You mean fourth also dislocated?
Don't you X-ray? 1505.
We fix the mobile race to the fixed race.
Any other takers? Okay, so if I were to say you're partly right, otherwise it's not right. And I'll tell you the reason why. And let me show you. So see, I'll try and, okay, let's see this picture first. If I was to put the first wire from fifth to the hamate, yeah, how can that wire maintain this joint space? Yeah, so your first wire has to be a distraction wire. Same in Bennett's, first wire goes from first to second to distract the joint. Second can go into the trapezium. Remember that, yeah? So your first wire has to be a distraction wire. And if you're putting just wires from fifth to hamate, fourth to capitate, yeah, fourth to hamate, your joint can still do this. Remember with your nailings, one screw is not enough. You put two, isn't it? Even two, they say it allows some movement. So first wire has to be from fifth because fifth and fourth are gone. So I have to, as you said, well, your first wire is this, into the third, because third is your solid one. It will keep fourth and fifth out to length. Even with one wire, my fourth, fifth can do up and down. Do you agree? That's why I put two wires like this. Yeah. Once my two wires are there, distraction wires, this joint space will be maintained. And remember, once fourth and fifth reduces, it's a stable joint. It's not now going to sublux. If you are worried, you can put your third wire from fifth to hamate, and it will lock your fourth in if you want to. I was not worried. Make sense? And then you open dorsally, you protect your cutaneous nerve, as Milindu said. And what am I doing here, Milindu? Where is the screw going? What's the structure? Hook, and hook is under fifth. Yeah, that's why I was saying fifth. So I know I'm right in the middle of the hook. Then you do 5, 6 images. I've just put 3. You rotate slightly oblique, and then a proper PA or whatever. Why am I showing this view? End on view of screw. What is this? Anybody? What is this structure? So I know I'm right in the hook. Why am I so concerned about that? Yes, ulnar nerve is in the front. So when I was drilling for a screw, if I was not in the hook, I can wrap the nerve. I can damage the nerve, right? So that's why you do a lot of views. And this is how it looks, yeah? So remember that.
For isolated fifth, base of fifth, fourth, you still recommend this type of.
Because you need to maintain the joint space. That is more important. So this is your mobile column 4, 5. Yes. Why is that important? Why has nature given us a mobile column? Correct. It gives you grip. Grip comes from these 2 fingers, isn't it? What happens if I get properly? Then how do you deal with it? So this joint space is not good. Patient has arthritis. He's come to you a year later. Joint is reduced on a CT or waves or arthritis. He's in pain. What do you do now? So first, second, third were rigid problems. If there was problem between capitate and metacarpal, you say nothing, sir, I'll fuse it. Problem with trapezium metacarpal, nothing, sir, I'll fuse it. And fourth, fifth problem is a mobile column. There's a lot of movement in that joint. You can't fuse it. So what do? It becomes an issue. You have to put ECU there, or capsule there, or some tissue, soft tissue into position. So that's why you want to avoid arthritis in 4-5. That's why distraction wire is very important. Yeah. Same with your Bennetts and Rolandos. Yeah, maintain the joints with distraction wire. I've just put some. Shall we have Rishi?
Yeah.
Do you think we should have lunch? Because
Let's
it's
have
a bit
lunch.
cold. Then I'll finish these 3-4 slides and a bit of drawing on the paper. Shall we do that?
Yeah.
Brilliant. Let's do that. Is that okay, guys?
Yes.
Any questions? Sorry, first of all.
You get the lens right, but still the DRUJ is not relocated.
DRUJ will always be okay if your radius going is okay and you got it right. 100% okay. Unless it was a big dislocation and your ECU has flipped in or some soft tissue, which is very occasional, but you will know because you have seen so much displacement, then you are thinking of it and then you flip it out.
How do you approach the DRUJ?
So it depends. Rishi has one very good exercise to show you. If your if your ulnar head has come out dorsally, then when you supinate, it tends to fall back in. Yeah. If your ulnar head has come out volar, which is Rishi's case, pronate and it will come back in. If there's any interposition, you go through the bed of, so normal approach to fix TFCC is bed of EDM, fifth compartment. Go through EDM, cut the retinaculum, EDM goes to bed. Let's say ulnar side, make sure you don't cut the TFCC, and open the capsule, and then whichever, you just reduce it. Makes sense?
KYS or
If you got KYS, no. If at all you have to put a wire proximal to purge, and make sure the wire, if you're going from ulnar, comes out of break so that if it breaks. Normally, drudge doesn't leave wires. Once you've reduced it like PIP, it's very stable zone. Yeah. Drudge is a very hard problem with wrist, but they will don't put wires. Just say above elbow. Do sugar tongue also or above elbow. Any other?
When do you remove the K-wires in CMC dislocation? 6 weeks.
6 weeks. Wires are not easy. Infections happen. I'm most worried about wires. So with wires, you have to constantly tell patients, no sweating. Very young men, they go out, they sit in pub and they sweat. And this is what happens with wires. Because infection will go in right into carpus and then you're done. So you watch wires like a hawk yourself. Don't trust over. Sometimes you can bury the wires. They say after 4 weeks there is evidence that infection goes up quite a lot. So after 4 weeks, if they say you have to do wires, just bury them under skin. Better to take them to and take it out. Don't do it, but this is.
Two questions about TENS there. Asking the right question. You usually remove them in 6 to 9 months. It's
3 months patches here.
And then the question I have is, KYS we keep for 6 weeks and then we remove it. But then the TENS there is intramedullary, we keep for 3 to 6 months. And what is how does basic science wise how
Consolidation, let it consolidate as much as it can.
And then when you remove the intramedullary, still have time to heal, isn't it? Because intramedullary, because it's occupied by the metal.
What has to be there?
I mean, what's the
bone will consolidate
from there?
Consolidate.
Yeah. So when you remove the intramedullary foreign body, it will take time to heal as well, isn't it? To protect you.
Damage any endosteric blood supply.
Yeah.
Go back to the has enough periostic blood supply. That's why spanning plate comes up with 3% roughly time to 80% there. Sorry, how will you reduce flexion type? What will happen in flexion type? It's come forward, isn't it? You just extend on the front. What more?
So the pronation aspiration not be of value.
That's to do with the wheel combination. Wheel combination is pronation or the supination. Supracondylarus, Gartman 3. Anything which is 100% displaced, anything in body, there's a lot of soft tissue from accommodation. soft tissue injury. By and large, they should almost always reduce. You should almost never have to open a suprapuncture cartilage unless there's a pucker sign, unless they have really massively displaced muscles or something like that. More approach. I do a medial approach. Exam answer is lateral approach. Only because I have to see ulnar not anyways. So then I'm even more safe and happy to see my bone directly. And one incision job done. Exam answer lateral approach. If I do 3 KOS, then I can convince all of you that 2 hours are not good. For the exam, Deborah Eastwood, it is also very well. She has 3 wires.
I mean, the advantage is you can take my out.
Also, for many reasons, convince you guys that feel better. But for exam 2 hours, I should be exam answer 2. Try and show your knowledge and even prove it. They will think these adventurers need to 10 more things. Very simple, humble. You do what you want to do. But yes, 2 hours, for example.
Condyle fractures is not displaced. You manage them every week.
I have that condyle. Bring all your questions actually.
Yeah.
There are a few things. Set your things. Thanks, guys.
Like there's chicken and veg, which there's no pork or beef.
Someone's mask is here.
Saurabh?
We are having a lunch break. Sorry, Hitesh.
Okay, Saurabh. So what I'm going to do is I'll be running Rishi's couple of videos so that our online audience remain engaged.
Beautiful.
And I've transferred all of them to you, Hitesh. There should be about 7 now, yeah?
Sure.
Fantastic. Very nice. Thanks, Hitesh.
Yeah,
brilliant.
bye-bye.
Thank you. We'll catch up. Yeah, see you soon.
No, this is chicken. This is chicken.
So the key thing about the active question is giving or is it pathological? So the key about the active question is epiphysis and metaphysis. Adolescence is typically in obese kids, and 80% of those cases are unilateral. This time you want to measure the intercondylar distance, which is the distance between the knees when the ankles are together. You want to look for a leg length discrepancy, and you also want to measure the rotational profile, including any internal tibial torsion or the thigh foot angle as well. Your indications for radiology in Blount's disease are if they have a family history, an asymmetrical deformity, age outside the normal range, or any endocrine abnormalities. So you measure a number of different angles on the radiographs. You can do a tibiofemoral angle to tell you the degree of varus. You can next measure the Drennan's angle, which is the metaphyseal diaphyseal angle between two lines, one going through the proximal tibial epiphysis and the metaphysis. The normal angle is less than 11 degrees, abnormal is greater than 16 degrees. You can do the epiphyseal metaphyseal angle, which is normally less than 20 degrees. And finally, you can do Langenskiol's classification, 1 to 6. Now, I wouldn't learn this for the exam. All I would learn is that the deformity becomes progressively worse as you progress, and you get formation of this physeal bar, which if it's less than 50%, can be excised and replaced with some sort of graft, such as fat interposition graft. Typically, Langenskiol 1 to 2 is treated with an orthotic, and 3 to 6 or failed conservative treatment is treated with surgery. At the end of your clinical and radiological assessment, you should be able to determine the diagnosis and the severity. So let's go on to management. Your principles of management are to, number one, treat the underlying cause, and number two, treat the deformity. And remember, if you're going to do a proximal tibial osteotomy, you need to do it distal to the apophysis to prevent cessation of growth there. If you've got a bar which is less than 50%, you can excise it or do a hemi-epiphysiodesis. But for the sake of the exam, there's three buzzwords that I want you to remember: hemi-epiphysiodesis, guided growth, and Hoyter-Volkmann. So what do I mean by that? Well, guided growth works on the principle of Hoyter-Volkmann, which means that compression slows growth, whereas tension speeds up growth. So you want to place your device or fixation always on the tension part of the bone, which would be medial in genu valgum, and it would be lateral in genu varum. So what are your options for this? Well, they can be divided up into temporary or permanent. And temporary can be a static device such as staples or a dynamic device such as 8 plates. Remember, you have to remove these down the line. Whereas a permanent one is an ablation type procedure such as drilling or curettaging the physis. So the type of operation you use depends upon two factors: the age of the child, in particular, is the physis open or closed, and the severity of the deformity. Hemi-epiphysiodesis corrects at 1 degree a month. But remember, if you have a large deformity with a closed medial physis and not much potential for growth, you cannot rely upon medial growth to correct your problem. So here, the only option would be to use a proximal tibial osteotomy plus either an internal or external fixator to correct your deformity. Nerve injury. Now, this is a really common topic in the exam, and I'm going to show you how to score very highly on it. So there's a number of different ways of classifying nerve injury. You can classify it nerve injury. Now, this is a really common topic in the exam, and I'm going to show you how to score very highly on it. So there's a number of different ways of classifying nerve injury. You can classify it anatomically according to the Seddon or Sunderland classifications. So Seddon described nerve injury as being either a neuropraxia, which is where you get distortion of the nerve, but all of the elements remain intact. He also said you have an axonotmesis, which is where the axon gets cut, but some of the neural coverings remain intact. Whereas a neurotmesis is where all of the neural coverings and the axon essentially get cut. Sunderland. Nerve injury. Now, this is a really common topic in the exam, and I'm going to show you how to score very highly on it. So there's a number of different ways of classifying nerve injury. You can classify it anatomically according to the Seddon or Sunderland classifications. So Seddon described nerve injury as being either a neuropraxia, which is where you get distortion of the nerve, but all of the elements remain intact. He also said you have an axonotmesis, which is where the axon gets cut, but some of the neural coverings remain intact. Whereas a neurotmesis is where all of the neural coverings and the axon essentially get cut. Sunderland expanded upon Seddon's classification by dividing it into 1 to 5. 1 is the same as a neuropraxia, whereas 5 is the same as a neurotmesis. 2, 3, 4 just describe sequential loss of neural coverings. So 2 means the basement membrane is gone, but the endoneurium is intact. 3 means that the endoneurium is gone, but the perineurium is intact, whereas 4 means that the perineurium is gone, but the epineurium is intact. 5 means everything is gone. The problem with Seddon and Sunderland is anatomically they're very interesting classifications, but you can't tell the difference clinically between the two. We do not know whether a patient has an axonotmesis or a neurotmesis unless we looked under the microscope. So it's not really that useful clinically. Whereas Birch and Bonney used a more clinical classification, subdividing patients up into either a conduction block, which is the same as a neuropraxia, or a degenerative lesion. So a conduction block means that all of the neural coverings are intact, but the myelin sheath may have been stretched or distorted for some reason. And the analogy I like to use is that of a lit bomb which is placed in a puddle of water. The bomb represents the nerve trying to conduct, but if you don't take away the puddle of water, it will not go off, i.e. the nerve will not conduct. And the puddle of water represents maybe a hematoma or a stretching of the nerve. And so as surgeons, we go in there and we try and release that obstruction. We may do a neurolysis and suddenly the nerve will tend to get better, or it may happen on its own. The key point is that a conduction block over time can eventually progress to a degenerative lesion. The other form of injury is a degenerative injury, which occurs when the axon is cut. And this was described by Waller and is known as Wallerian degeneration. And the way that I remember it is I divide it up into 3 distinct parts: the distal segment, the cell body, and the proximal segment. So when you cut an axon, the distal segment, because it's disconnected from the cell body and receives no nutrients, the neural tube will collapse and becomes ingested by macrophages. But the Schwann cells are left behind, and so they start thinking, well, what am I going to do now? The nerve's gone. So they start to form these bands of bunga, which produce neurotropic factors, which can guide the direction of growth, but they can't cause growth themselves. So they're telling the nerve where to grow to. We then move up to the cell body, which starts to detect that the nerve has been cut, and it changes its phenotype from a neuroconductive to a neuroregenerative phenotype. The nucleus moves off to one side, the mitochondria and activity increase. You then move to the proximal segment, and this time the axonal growth sprouts start to grow out and produce neurotrophic factors which can produce growth. And so how does the proximal segment meet the distal segment? You've got one side which can produce growth and is trying to grow. You've got the other side, which is the tunnel, which it needs to grow into. So the way that it does it is via these things called filipodia, which are like little fingers which move along and try and find their relevant growth cone to go down into. And that's a process called contact guidance. And the analogy I like to think of is the blind man and his cane, feeling for where to go, which is just like the nerve trying to grow down the correct growth cone. And this can be monitored clinically by an advancing Tinel sign, which basically resembles an advancing growth cone, which grows at 1 millimeter a day. So it's really important to note that Tinel signs, real Tinels, only occur in degenerative lesions. The type of Tinels we get in a median nerve compression at the wrist in carpal tunnel syndrome is a pseudotinels, and that occurs because due to prolonged compression the myelin sheath has melted away and you're basically tapping on exposed growth cones, but it is not a true tinels. The other analogy that I use for Wallerian degeneration is that of an earthworm which has been cut in two. The distal half, which is not connected to the brain or cell body, will die by Wallerian degeneration. The proximal half will survive. So how do we assess a patient with nerve injury? You do a triple assessment comprising history, examination, which is both clinical, and neurophysiological assessment. And the net effect you want to know is, number one, is there an injury? Number two, what's the location of the injury? And number three, is there any evidence of recovery? So clinically, you take a history looking for both patient and injury factors. Patient factors. Do they have any history of immunocompromise or poor vascularity such as diabetes or peripheral vascular disease, infection, anything which might influence recovery? And then injury factors. What is the time from injury to presentation? Which nerve is affected, since proximal nerves often have a worse prognosis than distal nerves? Nerves which supply both motor and sensory again have a worse prognosis. What is the type of blade or injury that was used to cause the nerve injury? So if it's a sharp blade, you often need to get in there very quickly, whereas if it's a blunt or serrated blade, you may wait for the nerve injury to declare itself and therefore explore after a period of time. Also, nerves which supply a number of different muscles often have a worse prognosis than those which supply just one. Next, examination. You want to try and localize the injury and also see if there's any evidence of recovery in the form of an advancing Tinel sign. This will involve a detailed examination of both sensory and motor modalities. A neurophysiological assessment. This is something you often have to discuss in the exam, how to set up a nerve conduction study. And the way that I remember it is a nerve conduction study consists of two things. Firstly, a nerve conduction study itself, which is activity in a sensory or motor nerve, and then an EMG or electromyography, which looks at the activity in a muscle. So a nerve conduction study requires a number of different electrodes. A stimulating electrode, which provides the stimulus, a recording electrode, which records it, a ground electrode, which stops the patient being electrocuted, and a reference electrode, which gets rid of any background activity. So the setup is slightly different for a sensory and a motor nerve. In a sensory nerve, the stimulating electrode will be distal, whereas the recording electrode will be proximal. So the direction of impulse transmission is from distal to proximal, or it's called antidromic. Whereas in a motor nerve, the stimulating electrode is proximal and the recording electrode is distal. Therefore, the direction of stimulation is from center to periphery, or orthodromic. Now, it's slightly different in an EMG, because in an EMG, the patient provides their own stimulus, so you don't need a stimulating electrode. You just have a recording, a ground, and a reference electrode. So once you've got your electrodes in place, what are the parameters that you need to know about? Well, there's three to remember: latency, amplitude, and conduction velocity. And the first two are measured, whereas the third one is derived. So latency looks at the time to travel between 2 points, whereas amplitude looks at the size of the stimulus. So some people refer to it as the quality and quantity of the impulse, whereas the conduction velocity looks at the speed of transmission. And that's worked out by taking a tape measure, looking at the distance between 2 points, and then measuring the latency to pass between those 2 points. It's measured in units of meters per second, and the only value you really need to know for the exam is an average conduction velocity of 50 meters per second. The upper limb is slightly greater, it's 60, and the lower limb is lower at 40, but 50 is the average value. The other thing you always must do is you must ask for a conduction velocity or figures for the contralateral side, since you cannot interpret a nerve conduction study in isolation. You have to compare it with the other side. What are we actually looking for when we look at a nerve conduction study or an EMG? Number one, we're looking for localizing the lesion. So is conduction velocity slowed across a particular point? Secondly, we're looking for, is there any evidence of recovery or regeneration? And I'm just going to take you through an EMG. So when I record an EMG at rest, because I'm providing no stimulus, I would expect to see nothing. However, when I ask the patient to contract their muscle or do a particular movement, I will expect to see what's known as a motor unit action potential. So essentially, what happens when the nerve has been cut or denervated? Well, at rest, you start to see lots of electrical activity because the nerve is trying to stimulate the muscle. So what does that look like? Well, initially you get these things called positive sharp waves, and then later on you get fibrillations, okay? A common misnomer is that you get fasciculations, but remember, fasciculations are clinical, not on a nerve conduction study. So then what happens when the nerve starts to regenerate? When the nerve regenerates, you start getting these things called polyphasic units, where you get one nerve trying to supply lots of motor units. You may also get an increased amplitude to the nerve. And the analogy that I try and think of is the Indian chief and his villages. So if you think of a village where each chief supplies or has a number of children, and those resemble all of the motor units which that nerve supplies, when that chief dies, the chief in village 2 will take over his kids or his motor units. So you'll see what's called polyphasic units on the EMG. So those are my buzzwords to remember: polyphasia, positive sharp waves, and fibrillations. So what's the relevance of this triple assessment? Well, ultimately, the two reasons to explore a nerve as a peripheral nerve surgeon are, number one, if there is evidence of ongoing compression. So the patient may have pain, either spontaneous or evoked pain, or they may have imaging or a scan showing that there's a hematoma compressing the nerve and potentially knocking it off. Or number two, that there is no evidence of recovery after a reasonable period of time, either clinical in the form of an advancing Tinel sign, or neurophysiological in the form of, for example, polyphasic units. If, as a peripheral nerve surgeon, I see a Tinel's which is advancing or polyphasic unit, I'm going to wait and hold on.
No, I think this
so then
sense.
finally, once we decide to explore the nerve, what are the different treatments we can offer? Well, I use a stepwise mode of remembering this called the ladder of reconstruction. And this can start off with a very basic exploration of the nerve and release of any hematoma or any scar tissue called a neurolysis. If you then find that a nerve has been cut, you can try and do a direct end-to-end repair, which must be low tension with a non-absorbable suture and depends upon the size of the nerve in question. And the key point is it must be done under microscopic guidance, either loops or microscope with fascicle matching. The next level up will be if you find that you cannot repair the nerve and you try and use something else to bridge the gap, known as a nerve graft. This can be either an autologous graft, such as a sural nerve or a cutaneous nerve, which is sacrificable, or it could be a synthetic nerve graft. Or the level up from that is if actually, you know what, the gap is too big to bridge, I'm going to use another nerve to try and replace the function of the one that I've lost, known as a nerve transfer. And again, you'd be using some type of nerve which is sacrificable. So we use common nerve transfers in peripheral nerve injuries. For example, a spinal accessory nerve may be used in a patient who's had loss of their suprascapular nerve. You might use an Oberlins transfer in patients who've lost their musculocutaneous nerve, or you may use a Somsax transfer in patients who've lost their axillary nerve. Now, an important point to note is that all of these things, such as nerve repair, nerve grafting, or nerve transfer, have to happen within a period of time, ideally 6 months, but no more than 12, because by that point, you start to get death of the motor unit. So even if you then restore innervation, it won't end up increasing or improving function. So the next level up would be to do a tendon transfer, which we'll discuss shortly. And then finally, if you don't have an adequate tendon transfer, would be to do what's called a free muscle transfer.
Hitesh, can you hear us?
Not muted, are you?
Hitesh? No. Hitesh? Hitesh?
Muted, is it muted?
So he's muted us.
Can you hear me? Can
Yeah,
you-
we can hear you. Can you hear us, Hitesh?
Yes, yes, please.
We had pizza. Did you have some food?
No, not yet, actually. I was running Rishi's video, so that went on well. So I think, yeah, you can start off with the presentation.
I had your share, Hitesh. Don't worry.
No worries. Enjoy.
Okay, guys. So are we going to switch off the lights, Arjun? So, guys, if I may do terrible triad first, it's again elbow, but it is asked. So Rishi and I was sitting yesterday and we were thinking what to show you. So I thought we should do this, yeah. Terrible triad. So again, like radius, if you break it into simple steps, it's not difficult. Yeah. So for example, if I was to show you this elbow X-ray, what you immediately know is elbow is dislocated. What you know is there are few pieces floating around, 2, 3, 4 there with my arrows, most likely a radial head, most likely, I don't know. And then if you start looking at the AP, you will say, yeah, hang on the radial side, yes, this is radial head piece. This may be a radial head piece, yeah, because it can go any which way, right? So what will you ask for? A CT scan, isn't it? Sorry, I don't have more slices, but at least on this slice, you know, radial head is very comminuted. Yes. So now you already know radial head is, elbow is dislocated, radial head is fractured. There may be a small, tiny coronoid, may not be, but it's a terrible triad. Yes. So this is how I would in my mind work out elbow fractures. So once I've worked out that much, obviously you reduce the elbow in any, all that you guys know. And then obviously it needs an operation, correct? So we'll try and answer these questions, approach and what are we fixing, the sequence of repair, all those things. Yeah, I'm going to spend 10 or 15 minutes because this is a bit, sort of takes time to. Mechanism, you all know, Sean O'Driscoll gave us this, yeah? This is just cram up, axial valgus supination, correct? Circle of Horry's, start from the lateral, goes front back, then goes to MCL, yes? So in a terrible triad, LCL always goes and MCL may not go, correct? This slide is important, principles of fixation. So this you need to somehow sort of get it in your sort of system. Imaging, obviously lateral positions, you need a good imaging. Fine, positioning is lateral, supine with side table. Universal posterior approach versus dual approach. Do you understand what is this? Yes. Dual is dual. You can do a medial and a lateral approach. Otherwise, you do a big incision and inside you can do medial and a lateral. Yes, simple to understand. Sequence of fixation is you fix the coronoid fracture, or if it's a flake, then anterior capsule. Yeah. Do not reduce, do not worry about this. I'll explain to you with the case. Then you go to radial head. Either you fix, but fix well so that you move elbow early, or you replace. Then you reduce the joint because obviously radius, as you all know, to fix it is better for it to be dislocated, you know, create that TLRI because radius looks at you. Then you do your lateral ligaments, LUCL. Then posterior sac. Do we know posterior sac test, all of us? I'll show you some slides. And then if sac test is positive, then MCL. Then again, you do SAC test. If it's positive, then X fix or in fix. Now we have a internal joint stabilizer. Do you guys know about it? Oh, very good. You people are well informed, more than I am. Okay, so let's go back to this. Yeah, so please remember the sequence of fixation. Is that okay? So this was the case, I think, Mufi, we did last week, isn't it?
Yes.
When was it? Wednesday, Thursday. I did someday we did, isn't Thursday, I think. So see, this is important now. Supine, lateral, tunicae, who and everything you know, consenting you know. What am I showing here, guys? Any of you? Beautiful. Why should I do it as a surgeon, Milindu? Why should I show you an isosceles triangle as a surgeon? I've written there, it's upside down. Have a read. So that's anconeus muscle. So every time I do a lateral approach, I would do this every time, whatever I do. Why? Because see, so anconeus originates from humerus at the back and then sits on the ulna there, isn't it? We all know this, yes? So olecranon, epicondyle, 6-7 centimeters on subcutaneous border of ulna. So if I draw this triangle, this is exactly my anconeus muscle. So if this is this line with my arrow, this muscle will be ECU. So this line is my Cocker's approach. Do we agree? Yes. So that's why I was trying to highlight this to you. And before I come to this picture, can you see this line, my line? But my cut is not on the line, bit in the front. Have you noticed? So I've not done a Cocker's, I've gone a bit in the front, like a EDC split. You can say Kaplan, whatever you want to say. I like that approach. You can do Cocker's also. Yeah. So let's go back to this picture. So again, good flaps. You can see the fascia means good flaps. And what am I holding in my forceps? Why am I trying to show this to you? Very good. The reason being, medial side fascia is not good. You can see next time. Lateral side is very good. It's a thick, robust structure. So when you come back stitching things up, do the muscle first, fascia in a separate layer. Otherwise, muscles will herniate. Small detail, but important, okay? And then see, I'm going through the EDC. I've made a little sort of incision there. And then radial head starts looking at you. Yes? And when I took it out, at least in my hands, I thought I can't fix it. So one decision done, replace radial head. Yes? So let's see what I did next. Good. So remember, we were talking of sequence of repair. So we said, what structure first? Or? Yes, capsulocoronoid, CC, yeah, whichever. So this was a flake of bone, let's say. So we have to fix the capsule or attached coronoid to it, yeah. So what am I doing here? So what's this? Anybody? Beautiful. So how do you do it? Explain this picture to your colleagues. Correct. Posterior ulna you drill, and you pass the suture, you take a bite in capsule, you come back out, and when I pull on it, this flake of bone will come back. And this is a flake, does it matter? If idea is this capsule should heal here, right? Capsule has proprioception. Does this make sense? So what am I showing here? Drilling. So I'm trying to show, see, this is where you go from posterior, drill, 2 drills like this. Agreed so far? Easy so far? It is easy so far.
Can I ask you one quick question?
Yes, Rishi.
Sorry. So you said about fixing the coronoid first, and this technique would be used if it's like a small coronoid fracture.
Yes.
Like an avulsion technique.
I deliberately didn't want to.
If it's a bigger coronoid
Correct.
injury, such as requires screws or plate, would you still go on the medial side and fix that?
Yes, no.
So you still do the lateral and then you go.
That's why I deliberately didn't bring it
that's fine. That's
so that they will get a bit.
Yeah,
but
yeah,
you're
yeah.
100%. It's a very good point.
Yeah. So this is only applying to a terrible triangle in a small coronoid. If you need to place the medial side, then you're going to do that. Yeah.
Fracture dislocations elbow. If you go into detail, the terminology itself nobody agrees on consultant-wise. There's a lot to think about actually. But in the exam, you'll not be asked beyond this. Coronoid, as Rishi rightly brought up, if it's a big fragment, it may need plate, it may need screws. If it's transolecranon fracture, Montegia, transulnar, lots of factors. Then you think about your needle approach. We have lectures. Rishi has a lecture. I have a lecture on terrible troid on YouTube on orthopedic principles. Then you have to think about it and get it in your mind. Basically, we are keeping it small flake, as Rishi very correctly pointed out. Okay, so drill from the back. We agree. So now, like your lasso, I put 2 sutures. Do we agree? And if I may say, so that's your lateral side. That's capitulum. That's trochlea. You can see there's a bit of chondral loss. Can you see that? Now watch this thing. What is this structure? Where the hand is? This one. This is right in front of the bones. Has to be capsule, isn't it? Capsule will be there on the joint. So now watch carefully as I play the video. As I pull on the stitch here, this capsule will fall back here. That's the flake of bone. Yeah. I hope it comes. See, can you see it? There. Can you see that capsule falling back? Okay, so this is suture lasso for you. Make sense? 100%? So see, oh, it's playing again. Why not? Can you see that capsule coming back? Yeah, okay, good. So capsule is taken care of with the suture lasso. But you don't tie the knot because it will reduce the ulnohumeral joint. I still want it to be dislocated for this reason. So now I'm addressing my radius, my radial head, correct? What am I showing here? I'm reaming for radial head, isn't it? So idea is, if you watch this, see, as I move this, my radius is moving. Do we agree? Yeah. So you know this is the right fit, basically. Sometimes people ask me, how do you decide? And this gauze piece is my retractor. It was very benign because pin is sitting there. Pin is sitting right below the neck. So this is very benign. It can pull the radius out and see how comfortably I'm able to put my rasp and check and rasp it. So that's a little tip to do your radial head replacements. Yes? Easy so far? So now what I'm showing is I've replaced the head. Yes? Agreed, guys? Radial head replacement done. My suture lasso is still there. I've not put a knot. Have you seen? Now is the time to reduce the joint. Hold it in flexion because it will stay reduced, ulnohumeral joint, and then start repairing your lateral ligaments. Or you can even do a knot now and do lateral, whichever way now, because my radius is done. Yes? So this suture anchor will go into the isometric point of capitulum. Correct? And what is this structure now? Okay, what is this structure? How many structures are there on the lateral side? Skin, fat, muscle, and ligament. What does it look like? Muscle or ligament? Muscle. So this is a EDC muscle, isn't it? We did a EDC. So if this is muscle, what is this structure? Ligament, LUCL. So I've separated the two. Yes. And now I have stitched it to the isometric point. Make sense? Easy. It's just a stitch there, anchor there, nothing more. And now LUCL is not a separate structure. You know that. LUCL, RCL, annular ligament, they're all one. So this part of LCL, LUCL, whatever you want to call it, will be annular ligament. This part will be annular ligament, isn't it? You have cut it to see the radius. So now you further reinforce your repair by tying this thing to this thing, which is what I've done here. Can you see this? And I'm pulling with my forceps just to show you the radial head that I have tied this annular ligament. Make sense? So annular ligament and LUCL or LCL, whatever you want, and I've stitched it here. Yeah? Make sense? So we have addressed what we wanted to address. The capsule we have addressed, radial head we have addressed, lateral ligament we have addressed. Now, only thing left is which ligament? MCL. It may have gone, it may not have gone, right? Agreed? One thing before I move on, sometimes I'm asked overstuffing. How do I avoid overstuffing? So if you're really overstuffed, what's happening here? Yeah, see, lot of space, less space. Because obviously if radial head is too much, this will open up. So this should be parallel. Delta sign should not be there. See, it's opening up. So this is one way of knowing. Second way is your radial head should be, because sigmoid notch was there, you can actually see it sitting next to it. Yeah. So this is how you avoid overstuffing. Yeah. Make sense? So this joint should be parallel and it should be sitting at the level of sigmoid notch, which you see with your eyes actually, because it's there looking at you when you're doing head replacement, radial head replacement. This is your posterior sag from a different patient, obviously, just to show you what is sag. Can anyone describe here what's happening?
Posterior. This is
Is the joint congruous here?
as we're going through
It is
flexion to
congruous. There's a bit more
extension,
space, but it's congruous. Sorry.
as we're going through flexion to extension, the joint is becoming more and more incongruent.
Correct.
Dislocating,
Correct.
extension.
That's your sag, sagging posteriorly. So this is how elbow dislocates in real life also, isn't it? So this joint is congruous. You're just seeing a bit more space because patient is sleeping. And the biceps and brachialis is not firing, but it is congruous, yeah? But see, as I extend, it's starting to drop a bit more. Now it's perched, see, and now it's dislocated. This is how elbow dislocates in real life as well, yeah? So once you've done the three structures, this is the sag test you do. So you get a lateral view, and last 30 degrees are not important. But if I have a sag at 40, 50, 60, 70, if you get this kind of picture, then you know MCL has to be done. Then you do your medial approach, you repair your MCL, then again you do a sag test. And if it is still sagging, then you put a X-fix, infix, whatever you want to put. Make sense, guys? So this is the sequence of repair. This case was done 2 days back. So this is just to show you an example, because I didn't have the X-rays. I was just sitting in the morning doing, but this is how you can be shown an X-ray. Yeah. So is this a overstuffing? No, sir, because this joint space is parallel and you can see a good space here. You can just about see the retrograde drills. Can you there? So you know I've done a lasso and then there's an anchor for LUCL. And you can see I did a sag test for this case. And even at 10-20 degrees, the space joint was congruous. Make sense? I think this was the last. Yes, but I'll take you back to capitulum. So this is terrible troid, guys. Yeah, I wanted to discuss this only because it is asked. So I've taken you through the sequence. What is suture lasso? What is overstuffing? How does a LUCL look? So hopefully you can make some sense. Oh, thank you, Ines. You taught me how to do them when I was your fellow. Brilliant. So shall we go to the capitulum? Any questions in terrible triad? If you have a big coronoid, anteromedial facet or huge coronoid, then you have to do one of your medial approach. You can bring up ring approach because it's through the ulnar nerve bed of FCU, easy to remember. And if it's a big coronoid, put a plate, put some screws, fine. If it's an anterior band of MCL, it tends to come off from sublime tubercle, put an anchor and stitch it there. Simple as that, okay? So capitulum. Is this a capitulum fracture, we agree? What approach will you do? Lateral approach, capitulum. Pick up any approach, Cockers, EDC split. See you, Ines. Thanks for coming. See you tomorrow, Ines. Sorry, excuse me. So I do EDC split for most. You can say any approach that you want to, but you will have to do an extended approach, isn't it? You'll have to go on the supracondylar ridge here, bring it down. I put some AP screws. You can do PA screws, AP screws, whatever you want to do. Yeah. What is this? So you can see the physis. It's, I think 13, 14-year-old, it says somewhere. But yeah, it's a pediatric bone. Is it a dislocated elbow? Yes. What is this piece of bone? So hard to know, but you can see here. Can you see this broken piece? Yeah, it's a whole condyle, isn't it? So lateral condyle, yeah, fracture, dislocation. And then, yeah, same. Who can critique these wires? So look at the fracture. Fracture was somewhere here, wasn't it? Like lateral condyle. So we've got decent separation, isn't it? This fracture line would have been like this. Yeah. So it's so easy to critique now once you know what you're doing. And this is a shoot through view, articular surface is restored, correct? And here you can see the anterior humeral line as Rishi told us, correct? So if you're asked to critique, it's just application of what you already know, basically. What's this? Radial neck fracture, isn't it? This is what I would do. There are many techniques described. You can't reduce it with one wire. You have to use 2 wires. I use 2 wires as chopsticks. You can do with people say you come from styloid and go up and swing the wire. I find it hard. So what I do is 1 wire supports the head. See, head was here and now so 1 wire supports it, otherwise pushes it. 1 wire supports it, otherwise pushes it. So by and by, it comes and sits right up. At this stage, I felt I can go between the shaft and the head, so the head won't slip down further. Then I came with the wire from the top there, and I used it. Can you see it's bent? I used it as Kepenji, head reduced. I just put the wire like a Kepenji, job done. Yeah. So no right.
You have to open it or you're doing close?
So far, I haven't opened it, but if you can't do this technique, I will end up opening it, but you don't want to, if you can avoid it. Yeah, so I didn't open it, no, for this case. What? Oh yeah, this is just showing me a healed fracture. So, okay, what's this, guys? Is this elbow dislocated or not? Answer is yes. Very good. So see, this is medial epicondyle, medial. Oh, yeah, do we agree? Why does it incarcerate like this? Do we know? So let's see this video. It will tell us why it incarcerates. So is this medial epicondyle? What is this structure which we can't see from there to there? Which ligament?
Which band is it?
Anterior band of MCL, isn't it? So this is not a free floating structure. Do we agree? So see, if I show you this video, which I did, see how as I dislocate the elbow in the name of science, see how it is going to incarcerate. Did you see that? So anterior band is pulling. Oh, you got the gist, isn't it? So this is how in real life as elbow is dislocating. I didn't fully dislocate because it's not medial. This is how it will incarcerate. Do you get it? And as I reduce it, it goes back. So it's so easy. You just do a medial approach, see the ulnar nerve, flick it out because anterior band is attached, and then put a screw, put some wires, whatever you want to do. Yes? What's this, Melindu? You were asking me about this. Lateral condyle, isn't it? So see, now these are poorly done wires. Can you see that? This was me when I kind of used to think I was perfect. Look at the separation, not so good, yeah? But yeah, fine, I got away. But what is this? Beautiful. So why have I done it?
And the size of the
Correct. So see, bone is stopping there. Can you see where my arrow is? So from there to there is what? Cartilage, which you can't see on an X-ray, obviously. So by doing arthrogram, I can see there's no articular step. So I know I've done a very good reduction. Do we agree? So for medical legal purposes, because lateral condyle gives you so much grief, AVN and growth deformities and everything. Yes. So I have told them, see, on both planes, I had done a, well, still not a good job, but I've done as good a job as possible. So if it slips, at least we can defend a bit. Make sense? This we have discussed. So any questions, guys? Oh, any questions?
For the exams, how much detail do you need to know about lateral epicondyle? Would it go to a lateral condyle humeral fracture in a child? Would they go to cubitus valgus? And
Well, if they go, doesn't matter. If it's 2 valgus, you stretch out MCL, you need to reconstruct it. You can have tardial pulsing, stretching it. Main thing is classification. Main thing is it's a Salter Harris 4 or a Salter Harris
issue. Main thing is how you check your reduction with arthrogram, your divergent wires. This is a fracture of necessity. You need to preserve the blood supply coming from the back of lateral condyles, respect your soft tissue. Once you know all this, they are happy. Even if it goes into valgus, only two things can happen: ulnar nerve and MCL. MCL, you send it to an elbow surgeon, they reconstruct it using whatever large ligament, some tendons. Ulnar nerve palsy, you ideally interpose it. Simple. Yes.
There is controversy about the non-union view and then subsequently deformity. Are you going to osteotomize that? Are you going to open reduction and bone graft? Regarding if talking that possible transpose it or correct the deformity for overcoming the
You
symptoms.
should correct the deformity, obviously, because that's the problem. And it will also stretch out MCL, and even whatever ligament, whatever large ligament or tendon you will put it, that will also stretch out. You should correct the deformity, and you should take pressure of the nerve. You can easily do anterior transposition.
With or without the deformity.
With correction of the deformity.
The terrible triads, they now, and just, in trauma meetings, they talk about writing classification now, and they talk about how we don't need to obsess about the colon fragments anymore.
Professor Adam Watts, there are two schools of thoughts. Adam Watts from Brightington, and he's a great elbow guy. I learned a lot from him. He's the one who's given this column concept. He doesn't believe in repairing the capsule.
The capsule or the colon, unless there's an antromedial
flake, you don't. But if you have antromedial facet, you do. So flake you.
Classically anterolateral facet, it's not
It's not that simple. Terrible triad can be a flake. Flake means it's a PLRI type injury. It's a valgus terrible triad. It can be an antromedial facet, which is a PMRI injury, posteromedial, completely different kettle of fish, which is a varus injury, and your radial head is intact in that. So these are very different injuries, and they're hard to get your. That's why I was not even bringing those up. You should say, sir, I will repair. So Lee and Rensburg from Cambridge always repairs the capsule. So there's no right or wrong. So you just go by what is the traditional teaching. Says a capsule has proprioception. I'm going to repair it. I can sleep peacefully at night. And your capsules and it's pulling elbow, but it's not something. Make sense, guys? Any more questions?
Guys, for the sake of time, we might have to just
let's
go.
Hand elective, right?
Yeah. I'm the annoying timekeeper in the back of the room.
No,
that's Mr. Agarwal. Sorry. So
elective hand.
Yeah.
That way.
Good. Great. Okay, guys. So Hitesh, can you hear me still?
Yeah, Rishi, you need to share your screen. Actually, it's not.
Oh, share the screen. Okay, I'll do that. Sorry. So share screen. Is that better?
Yeah, and full screen.
Okay, good.
Perfect.
So similar to how we did before, guys, I'm going to give you sort of the decision making behind some of the common elective cases that you meet. And then Mr. Agarwal is going to go a bit more detailed with some of the tips and tricks to take you that bit further. Now, just for the sake of catching up a little bit of time, I'm just going to take you through a few of these, if that's okay. But any questions, please feel free to interrupt me at any moment. Okay, so I'll present case one. This is a 50-year-old manual laborer who presents with pain in his wrist, and you send him for some radiographs. So it's a PA radiograph of the left wrist. Now, what I noticed straight away is this thing here, sclerosis of the lunae. So shout it out. What are we thinking? Okay, so the level, what I call the 5-6 candidate, will just comment on sclerosis of the lunae. But the person who's going to go and get a distinction, a 7 and 8, will show evidence of higher order thinking. And if we're thinking of Keenbox, what other things might we be concerned about in our decision making? So I might comment on the ulnar variance, whether it's negative or whether it's neutral, because negative ulnar variance is a risk for Keenbox. I might comment on if the scaphoid is fixed rotation and the lunate is collapsed, because if that happens, I'm going from a reconstruction to a salvage option. And I might also comment on mid-carpal changes. Is there any lunocapitate arthritis? So from today on, I want you guys to focus on that. This is a PA radiograph of the left wrist, which shows sclerosis of the lunate. There appears to be no evidence of, or there appears to be evidence of carpal collapse, fixed scaphoid rotation, whatever it is. And there is also some lunocapitate arthritis. The ulnar variance appears to be neutral, or whatever it is, like that, yeah? So what are you going to do next? I'm going to take a history. Typically, these are manual laborers, and they may complain of pain and restriction of movement, especially dart throwers motion if they've got mid-carpal changes, okay? I might get further imaging. This is a different patient, but classically, you'll see basically a hypointense signal on these T1 images on the MRI, okay? You can also see here that there is actually a negative ulnar variance, isn't there? Okay, so it's like an abutment of the lunate. That's what happens. Okay, and there are various risk factors, and I would divide these into patient risk factors and anatomical risk factors. So patient risk factors might be if they're a smoker, if they're on steroids, anything like that. So I would ask that in the history. Okay. Anatomical risk factors might be if they've got basically evidence of a negative ulnar variance, or if they've got some problem with their blood supply. So the I type of blood supply is the one that's particularly at risk. So these are the things that I want you to bring out in the exam. So how are you going to manage this? Well, for me, I type. So you can have 3 types of blood supply, and it all depends upon the way that the vessels cross. So there's a Y type, an X type, where you get good sort of collateral circulation. So even if there is, because what is Keenbox? It's basically avascular necrosis of the lunate, isn't it? Okay, so if you've got a Y or an X type, there's good collateral blood flow, so you're unlikely to get avascular necrosis. With the I type, essentially, there's a single blood vessel, so it's much more likely to get avascular necrosis. Does that make sense, guys? Yeah. Okay, good. So how am I going to manage this? Well, I would break it up into if the patient has ulnar neutral variance, or if the patient has ulnar negative variance, okay? And let's assume we've tried conservative treatments. Conservative treatment might be giving wrist splints, might be trying to treat appropriate risk factors, stop steroids, hand therapy, those side of things, maybe injections as well, okay? And maybe some sort of what I would call small operations, an AIN, PIN neurectomy, just treating the pain in the wrist. Let's say all of that fails. What do we do next? Well, medical treatment. Is there a role for medical treatment in Keenbox? Things like anticoagulants, anti-lipid drugs, etc. Lots and lots of trials, studies. There's no real evidence for any of that. Okay. So the next thing is, let's say that fails. We go into surgery. It depends if they're ulnar negative or if they're ulnar neutral. If they're ulnar negative, I can do something to offload that lunate. So that may be either an ulnar lengthening or a radial shortening osteotomy. Shortening is always easier than lengthening. It's probably radial shortening osteotomy. Or if there's abutment of the capitate, I could do a capitate shortening osteotomy. Okay? And those things would offload my lunate. Let's say that it's not a problem of abutment, it's an ulnar neutral one. What do you do now? Well, it depends really on something called the Lichtman classification. Okay? Now, with the Lichtman classification, it's divided sort of 1 to 4. 1 basically means that you've got pre-clinical changes. So you look on an MRI, pre-radiological changes. You look on an MRI and you see hypointense signal, but you can't see the X-ray changes. 2 means you're seeing X-ray changes. You see the sclerosis, but the lunate has not yet collapsed. 3 is where the lunate collapses. 3A, there's collapse, but the scaphoid is not fixed. 3B, it's collapsed and the scaphoid is fixed and rotated. And 4 is kind of your STT joint arthritis. Which is important with Lichtman? The important one is what? 3B. Because once you get to 3B, you're going from a reconstruction to a salvage route. So just as a quick tip, guys, and this is not just for Lichtman, but it's for any classification. Now, people always panic in the exam, and I always think of the exam as like a poker game. You lay your cards on, the examiner, it's all about keeping a poker face, confidence. Now, people always say to me, and I've watched the exam myself, I've been there, and they'll say, how would you classify this? And this is how it will go. The trainer will go, okay, we do Lippmann classification, 1 to 4. Type 1 is pre-radiological. Type 2 is radiological. I think there's a 2A. I think there's a 2B. And you're just watching it, and it's just going downhill, downhill, downhill. This is a consultant entry exam. Is it a good test of your ability to be a consultant if you can just memorize a classification? Is that a good test? No. It's can you apply that classification and make sense of it? So the way that I present the classification, poker face, keep a complete poker face, is I would say, okay, I would classify it according to Lippmann. The most important being a 3B, where you get lunate collapse and fixed scaphoid rotation, because that's when you're going from a reconstructive to a salvage procedure. How would you classify adult flat foot? I would classify it according to Johnson and Strom, modified by Meyerson, the most important being a 3, because that's when you're going from flexible to rigid and reconstruction to salvage. How would you classify hyperplasia of the thumb? I would classify it according to Blount, the most important being a 3B, because that's when you've got CMCJ instability and you're going from reconstruction to a salvage route. Do you see what I'm doing there? I'm not giving the whole classification. The examiners don't want to spend a minute listening to you ream off a classification. It's not a good test. Although, is that a fair point, Saurav, as well?
100%. They will not even know. Like,
Yeah, they wouldn't have a clue.
I would know practical application.
Yeah.
And what am I going to gain out of theory? You pass part 1.
Yeah.
What I want to know is when you see this, can you make a decision?
Yeah.
I'm thinking circle.
Yeah. So for me, the decision making is based on, is there lunate collapse and fixed scaphoid rotation? Is there an ulnar negative wrist? And is there mid-carpal changes? That's what my decision making is based on. Okay. So as I said, if it's ulnar neutral, and the lunate has not yet collapsed, I might try and revascularize it. Okay. So you can do various types of revascularization type procedures, trapdoors, drilling, etc. But if basically it has, so if it has and they're ulnar neutral, then I'm going towards more salvage type procedures. So those might be things like STT fusions, or there may be some sort of mid-carpal type procedures. Okay, we've already mentioned some of them before. Okay, yeah.
STT fusion is to offload the lunate.
Correct. Correct. And you've already got pan STT changes anyway at that point. Okay, good. And then obviously wrist fusion is the last one. Yeah, you can go on to. So the next one is a 40-year-old male noticed a thickening in his palm, and you notice that the finger is bent slightly. Okay, thickening of the palm, bent finger. What are we all thinking? Dupuytren's disease. Okay, just make sure you're not missing anything like a trigger finger, but it's going to be Dupuytren's in the exam. All right, and that's a bit more obvious there. So first thing to say is Dupuytren's disease. What I was going to say is, what is the underlying pathology? Well, we all have what are called bands. Bands are physiological, and these bands get converted to cords, which are pathological. And we believe that the underlying pathological process is sort of mediated by the myofibroblasts. So that's a common question they ask you in part 1. And it leads to a predominance in type 3 collagen, which normally occurs naturally with age, okay? So you get reduction in type 1, increase in type 3. Interestingly, a similar process occurs in the shoulder, in frozen shoulder, but the frozen shoulder tends to get better, whereas Dupuytren's tends not to get better. Okay, so you may be asked to name the different chords in the exam. Okay, so my advice for you for that is subdivide your answer. Either talk about palmar chords, palmodigital, and digital chords, depending on where they are. Okay, or talk about chords which cause MCP joint flexion, PIP joint flexion, and DIP joint flexion. Okay, so for example, your central cord is like your pretendinous cord that causes MCP joint flexion. Okay, your PIP joint cord or your palmodigital one is your spiral cord. Okay, and that's relevant because the spiral cord tends to displace the neurovascular bundle centrally and superficially. So if you get that cord, you've got to be careful intraoperatively. Okay, that's why we don't normally do injections or MUAs, sorry, injections or needle fasciotomies, anything for PIPJ deformities that are quite significant because there's a risk of injuring the neurovascular structures. DIP joint contractures are things like the retrovascular cords. You can also have an adduction contracture, abductor digiti minimi contracture. Okay, so how do I assess the Dupuytren's patient? Well, in the history, I want to know about how the disease is affecting them themselves, and I want to know about possible risk factors. Okay, alcoholic, do they use vibrating machinery? Are they of Nordic background or Scandinavian background? Anti-epileptic medications, there's newer research has shown that's probably not a risk factor anymore, but traditionally that's something you take in the history. When I examine a Dupuytren's patient, I've got one on my list tomorrow. Even now, I use the same system. I look at 4 things, okay? Step 1, I put the hand flat on the table to confirm the diagnosis, Houston's tabletop test. Step 2, I think of the location and the severity of the disease. Is it MCP joint? Is it PIP joint? So to test the location, my philosophy is I hyperflex the joint that I am not testing. Does that make sense? So can I borrow you as a volunteer? Is that okay? Yeah. Okay. Is it fair? Can those guys see that? Probably. Okay. So let's say you come in with a bent finger like that, and I just hold it in that position, and I want to work out, is that MCP joint? Is it PIP joint? Okay. And is it correctable as well? Okay. So what I would do is, if I want to see if it's at the level of the PIP joint, what will I do? I will hyperflex the MCP joint like that, and I will see if the residual deformity corrects. Okay. If I want to see if it's MCP joint, I will hyperflex the PIP joint, and I will see if the deformity corrects. So you hyperflex the joint that you are not testing, and the reason you do that is to relax the cord. So I've seen the examiners ask that in a short case before. All right. So third thing I'm going to do is test the digital nerve and also test for vascularity with a digital Allen's test. Okay. You must do that preoperatively, because if I roger one of the arteries, okay, I want to know that there's another one collaterally. Okay. And that's the first thing. Saurabh will probably tell you the same. When you've done a complicated Dupuytren's, the first thing you're doing is, as soon as the tourniquet is down, you're just panicking and thinking, is it going to pink up? Is it going to pink up? Yeah. And then you get, your heart just relaxes as soon as it pinks up. Yeah. That's the stress with the Dupuytren's. And I always counsel my patients, if it's a really severe deformity, I'll always counsel them making an amputation in the future. And I will always counsel them saying, if I think the vascularity is at risk, I'm not going to completely correct your finger. So incomplete correction is a risk. Okay. So that's that. I will never try and get a finger that's in the palm completely straight if I think it's going to put the vascularity at risk. Okay, so these are little things to be aware of. Okay, so how are you going to treat it? What's your decision making? Well, always conservative you start with, but if it's affecting them significantly, then your options are to either do what I would call more minor type approaches, needle fasciotomy or collagenase injection. Collagenase is not part of NICE guidelines anymore, but you may need to know about it for the exam. So it's an enzyme produced by Clostridium histolyticum, essentially, which dissolves the type 3 collagen. And you need to counsel the patient that they would need to come back the next day for an MUA. Okay. Needle fasciotomy. I know some people will push the indications a bit. I'd probably just do it for MCP joints. I'm not as confident with doing them for PIP joints, but I know some people will do them for PIP joints as well, which is fine. I would probably say if they've got a deformity of the PIP joint of more than about 20 degrees, I'd be thinking of surgery, and I'd be thinking of there's various different options. You can do a subtotal palmar fasciectomy, normally a Brunner's incision, okay? Or maybe if I want a bit more length, I might do a straight incision with multiple Z-plasties, and I'll let Saurabh come on to those in a second. And then also the option is to leave the wounds open, let it heal by secondary intention, which is called an open palm Makash technique. Or obviously amputation is also something that you can do, particularly with a finger and palm deformity, to give them function back. Okay, so those are all your kind of options for Dupuytren's. Okay, so next case. This presents to you in your short case. What's the diagnosis, guys? Right, so rheumatoid hand. So if you see this in the exam, there's a spiel you're going to come out with, all right, before you even start. Okay, this is a symmetrical deforming polyarthropathy with features suggestive of rheumatoid arthritis, such as, and then work proximal to distal. I'm not even looking at the patient, okay? Such as caput ulnae, radial deviation of the metacarpals, ulnar deviation of the fingers, swan neck deformities, Z thumb deformities, dropped fingers if there are any, okay? Just have the spiel done. The next thing I would do is I would clinically feel the fingers for pain and temperature to see if there's any evidence of active disease, and then I would do a functional assessment, all right? So functional assessment is made up of 3 precision grips and 2 power grips, okay? So everybody in their back pocket should have a pen, a key, and a coin for the exam, okay? The pen, you get the patient to hold it and to write a sentence. That's the tripod grip, okay? The key, you get them to hold the key and turn it in the, pretend they're turning it in lock, key pinch. And then the tip-to-tip grip is the other precision grip. Pick up a coin from your hand, okay? Excuse me, the power grips, I get them to grasp my forearm or make a hook like this and hook onto my fingers. We call it a simian grip because monkeys do that, simians, okay? So 3 precision, 2 power grips, okay? That's very important, guys. So, and then how do you treat rheumatoid arthritis? You would say to the examiner 3 buzz phrases. Number 1, multidisciplinary management, orthopedic surgeons, rheumatologists, orthotists or hand therapy, etc. Number 2 is going to be optimized medical management of rheumatoid arthritis. And 3, treat according to function. So rheumatoid case should be done within 2 minutes, maximum, the whole short case, okay? Now, sometimes they might present the case with these deformities here, okay? What's this deformity here, guys, on the left? Okay, and what's this? Boutonnières. Okay, so I'm going to give you a really good system to remember for the exam. Rishi system, right? Okay. When I tried to learn swan neck and boutonnière for the exam, I read the books. It was so complicated. There's about 1 million operations, and it never made any sense to me. So I devised a system which I think is a really easy way to remember it. And I always think everything I learn in orthopedics as a bit of a side, I try and understand it, because my philosophy is if you understand it, when you get nervous in the exam, your knowledge will remain. Okay. Even if you're operating, if you understand the operation and you understand why you're doing things, then you'll be fine, even when you're stressed, okay? So I break it up into 3 parts, and I signpost this to the examiner. So I will say, this is a swan neck deformity, which is made up of hyperextension at the PIP joint and flexion at the DIP joint. You can divide it into 3 parts. The initial pathology, what happens to the retinacular ligaments, which we spoke about at the start of the course, and change in balance of forces, okay? So in the case of a swan neck, the initial pathology can occur at one of 3 joints. At the DIP joint, you can get an untreated mallet. At the PIP joint, you can get a volar plate injury or an FDS rupture. And at the MCP joint, you can get an MCP joint subluxation. Okay, you've got that so far? All right. Whereas in boutonnières, which is where you have flexion at the PIP joint and extension at the DIP joint, the initial pathology only occurs at 1 joint, the PIP joint, which is a central slip injury. Okay, you got me so far. Initial pathology, 3 joints for swan neck, 1 joint for boutonnière. The next thing is what happens to the retinacular ligaments. And what was one of the first things I said this morning, if you weren't all asleep or decaffeinated, the first thing I said was in swan neck, which retinacular ligament goes? No, opposite. Transverse goes in swan neck. Triangular goes in boutonnières, okay? And then the third thing I say is change in balance of forces. So what is the function of the transverse retinacular ligament? So it prevents it going dorsal, okay? So if I imagine my finger like that, and the center of rotation is there, in the center of the finger, if the lateral bands slip dorsally, are they going to become extensors or flexors? Extensors. Okay, so let's say that again. Swan neck deformity, untreated mallet, the DIP joint, FDS rupture or volar plate injury at the PIP joint, MCP joint subluxation at the MCP joint. Second thing that happens is the transverse ligaments goes. It slips dorsally, so it's going to become an extensor of the PIP joint and a flexor of the DIP joint. Does that make sense? Good. Boutonnières is the opposite. Initial pathology is at the PIP joint, central slip. Retinacular ligaments, triangular. This time it's going to go volar. So if it's volar at this joint, is it going to be a flexor or an extensor? Easy. That's just swan neck and boutonnières done. So the next thing you say is, how do I treat swan neck and boutonnières? Okay. Assuming they fail conservative treatment and they're symptomatic, easy. Divide it into flexible or fixed. If it's flexible, you can do some sort of soft tissue procedure. If it's fixed, it's probably going to need a fusion or possibly arthroplasty. Okay, so flexible, what do we do? Well, I again go in by 3 subheadings. treat the initial pathology, okay? Reconstruct the lateral bands by reconstruct the retinacular ligaments and relocate the lateral bands and rebalance the forces. Those are my subheadings, okay? So for example, in a swan neck, initial pathology, I could try and treat the mallets if possible. What will I do about the FDS rupture? I could do a tendon transfer. What will I do about the volar plate injury? I could do a volar plate advancement. What will I do about the MCP joint subluxation? Reduce it, okay? Next thing, how do I treat the fact that the transverse ligament has gone? I can relocate the lateral bands by doing some sort of reconstruction of the transverse ligament, a so-called Littler or Matev procedure. You don't just know the names, but just call it a relocation of lateral bands procedure. And the third thing is just rebalance the forces. So if I've got too much extensor force at the PIP joint, what am I going to do? I'm going to cut the central slip, what we call a Fowler's tenotomy. Does that make sense? Okay. Opposite with Boutonniers, treat the initial pathology, so treat the central slip problem. Okay. Reconstruct relocate the lateral bands, Littler or Matev procedure to reconstruct the triangular ligament, and then finally rebalance the forces. There's too much extensor force at the DIP joint, so where are we going to cut the tendon? We're going to cut the terminal extensor tendon. It's what we call a dolphin's tenotomy or a modified Fowler's. Does that make sense, guys? And going back to my biomechanics lecture at the start, you might say, well, Rishi, why would you cut the tendon? You're going to have a floppy finger, aren't you? No, because what did I say communicates between the PIP joint and the DIP joint? The ligament of Lanzmann, the oblique retinacular ligament. So you still have the extensor force. Yeah, isn't that much? Yeah, you don't cut the oblique retinacular ligament. You're cutting the tendon. Yeah, does that make sense, guys? Isn't that a much easier way to remember swan neck and Boutonniers? Much easier way, and no examiner will be prepared for that. Yeah, so that's a much easier way to remember it. You can understand it. Makes sense. Okay, good. Very common case. All right, Arvind, what do you think?
It's a bigger photograph of actually it's actually from the issue of the issue of
yeah, so shouldering in the base of the thumb, MCP joint hyperextension because you've lost your span, or so you've got an adduction contracture, and thenar wasting. 30% of these are associated with carpal tunnel. Okay, so again, what would I want to know in the history? CMCJ arthritis. Are they having difficulty opening jars, opening doors, things like that? I want to know about their level of activity. Are they a labourer? Are they high or low demand? I want to know about their dominance. On exam, I would look at the CMC joint itself. Is it tender? And I would do a grind test, axial load and circumduction to elicit the symptoms. I would also look for pain at the MCP joint and also STT pain by testing dart throwers motion. Why is that relevant? Because if they've got MCP joint arthritis, it means I don't want to do a fusion of the CMC joint. Okay, I'm probably going to have to do a trapeziectomy if I do anything, because you need movement at one of the joints. If they've got STT arthritis, I may need to do a trapezoidectomy or take out part of the trapezoid. Okay, so that's why those things are important. And then finally, I would test for carpal tunnel. All right. Radiographs, I'm going to request two views you're going to ask for. An AP Roberts to show the arthritis, okay? And a lateral, which will look for a disc deformity. And that's important because if you have a disc deformity, you can't do a trapeziectomy because you can destabilize the carpus. Okay, so again, classification of this. I don't think this classification is that relevant or that important, but what is it, guys? Yeah, Eaton and Littler. Yeah, okay, so 1 to 4 basically. 4 is pantrapezial, 1 is widening of the joint space, 2 is a little bit of arthritis, small osteophytes, 3 is a bit more arthritis, more osteophytes, and then 4 is pantrapezial. Yeah. Okay.
One opening increase in the joint space
because they get swelling, they get synovitis. Okay, but it's not that relevant a classification for management. I don't think it's that important. So the next thing is, how are you going to manage it? Well, conservative activity modification, injections into the joint, but ultimately a surgical exam. We're going down the level of surgery. Okay, and your options are trapeziectomy and fusion, and then you can do CMCJ arthroplasty as well. Okay. Probably for the exam, your gold standard, I would go for trapeziectomy or fusion. CMCJ arthroplasty is coming more and more into vogue. but those are the two that I would probably go through. And I'll let Saurabh go through that in a bit more. You got that, haven't you? Yeah. So I won't go that in more detail. Okay. Yeah.
Can you explain about the hyperextension? Is there any hyperextension?
Yeah. So the reason you get hyperextension is, if you think about it, you get abduction contracture, so you lose your span. Okay. So you need your span to pick things up. So what you do this time is, because there's no movement at the CMC joint, this starts to move, the MCP joint. So almost kind of subluxes, or not quite, but that's what you're doing. You hyperextend, and that's so you get your span from somewhere else. So it's a compensatory hyperextension of the MCP joint. Okay. Last things I want to very quickly mention, just for the sake of time, is you guys asked me about nerve injuries. Okay. So you might get a humeral shaft fracture with a wrist drop, radial nerve injury. Okay. So all I want to do in this type is just very quickly focus on, with any nerve injury, what you want to know for the exam is, how do I differentiate between a high or a low palsy? And what are the tendon transfers or options that I might do? Okay, that's what I'm going to keep it on today. So that's the key stuff. So with a radial nerve palsy, how do I differentiate between a high and a low radial nerve palsy? Okay, and I'm going to basically, can I borrow you as my patient? Or maybe someone with that, yeah, I don't. They say you've got your jacket on, so
Okay.
just to be quick and easy. So basically, with a radial nerve palsy, always start off with any examination, look, feel, move. Okay, so first of all, look, I'm going to look for wasting and scars. With a radial nerve, I would look for wasting in the triceps. Okay, I might also look for a posterior scar indicating that they've had a humeral shaft fracture of some sort. Okay, I would look for wasting in the mobile wad. Okay, ECRB as well. Okay, those are the main places, and I would look for a wrist drop as well. Okay, feel, I would check sensation, superficial branch of the radial nerve. Okay, first web space, and then motor. I'm a very stingy examiner, so I'm only going to allow you to test 4 muscles to work out what the level of the radial nerve injury is. Arvind, what are the 4 muscles I would test?
Triceps.
Triceps first of all, and what I would do is I'd test triceps against with gravity eliminated. Yeah, number 1. Next one, brachioradialis. Number 2, ECB, so wrist extension, and then what's the last one? So I would, so you're talking about PIA, yeah? So EDC, you're quite right, so you could test EDC, but I think when you're under pressure in an exam, and remember, sometimes you might get EDC mixed up with the lumbricals and whatever, the easiest one to do is test retropulsion of the thumb. Nothing can be confused for it. So I would do triceps, brachioradialis, wrist extension, and then I would do EPL. Done. Your entire examination should be done within 40 seconds max. Maximum 40 seconds examination. Okay. And then in terms of treatment, remember my ladder of reconstruction, neurolysis, nerve repair, nerve grafting, nerve transfer, tendon transfer. So what tendon transfer do you use? My thing, what I say is with tendon transfers, I say, what is the deficit? What is the surgical priority? And what are the options? So the surgical priority in this case is I want to restore wrist, finger, and thumb extension. So wrist extension, remember my rhyme, PT to ECRB. Okay. We don't transfer to ECRL because remember, ECRL inserts into the second metacarpal, so you'll get radial deviation. ECRB's got a more central pull. Okay. PL to EPL. And then finally, EDC, this doesn't fit in the rhyme, I'm afraid. It can be either FCR, FCU, or FDS. So those are the tendon transfers you need to remember for radial nerve. Okay, brilliant. Thank you very much. Okay, so I'm going to borrow you now for my next one. Yeah, please, if that's all right. I'm getting everybody to strip, sorry. Apologies. Okay, so again, bilateral wasting and thin remnants is worse on the right compared to the left. We're probably thinking carpal tunnel, but remember, guys, because it's bilateral, don't miss the neck. Always remember the neck, okay? Now, I'm quite happy that you guys can diagnose carpal tunnel, but what I want to teach you is how do you distinguish between a high and a low median nerve palsy, and also what tendon transfers would you use, okay? So again, what I want you to put your hands out there for me. So where am I going to look, guys, for wasting and scars? So the highest place I would look is where? Forearm, whereabouts, be specific.
Flexor.
So I'm going to look at the common flexors on you, okay? Because that's your common flexor mass. Okay, so I'm going to look there. Okay, next place I look for wasting. Three remnants. Okay, and I might look for a scar at the elbow, or I might look for a scar at the wrist as well. Okay, good. Right, next thing we do is sensation. So I'm going to test 2 points. What are they?
Over the thinner remnants.
Palmar-cutaneous for a high median nerve palsy, and which we call the autonomous zone of the median nerve. Be precise in the exam. Okay, the nerve examining is a purely an anatomical station. You need to know your anatomy inside out. Okay, and being a bit more stingy this time, and I'm going to allow you to test 3 muscles to work out the level of injury. What are the 3 muscles going to be? What's the highest place a median nerve can be injured? Yeah, but our pronate is that easy. So you're right. You've got 4 branches, haven't you? You've got FCR, FDS, pronator teres, and palmaris longus. Which of those is the easiest to test when you're under pressure in an exam? FDS, isn't it? Because pronator teres can be, you can make up for by abduction of the shoulder. FCR, you might get mixed up with FCU. Palmaris longus, 20% of the population don't have it. The easiest one to do is to test FDS, right? Can I get you to bend your finger for me, sir? Okay, it's the easiest thing to do. So I always think in my examinations, what can I do under pressure in the exam when my hand is shaking like this to stop me? So make your life as easy as possible. So step 1, check FDS. Next thing you're going to do? FPL. Can you make an OK sign for me, sir? FPL and FDP to index. Okay, and then the last thing you're going to do? Touch your thumb to my index finger and don't let me push you down while I'm feeling the thin remnants. Okay, good. All right, so what I'm testing there? ABP, yeah? Okay, good. And that's it done. And then, sorry, I should have said you do a provocative test as well. And I forgot to say, sorry, with the radial nerve as well, the provocative test there would be just tapping over the superficial radial nerve, all the way up there. Okay, so look, feel, move, provocative test. Okay, thank you very much.
Do you look at any scar in that as well?
You've got to think median nerve, where is it going to be injured? You could have a look, I suppose, at the neck, see if there's a plexus injury, but it was more like very obvious. That's the sort of more quick attack thing. Okay, and then tendon transfer that you'd use. So if it's a high median nerve palsy, think about what are your surgical priorities. You need to restore what? Finger flexion and thumb flexion, don't you? And opposition. Whereas if it's a low median nerve palsy, you just want to restore opposition. Does that make sense? Okay, so with a high median nerve palsy, you've lost FDS and you've lost FDP to these 2 fingers. So you've got no flexion of this. So what you can do is you can buddy the FDPs from here to there, so that basically you have a mass movement. Okay, that will restore finger flexion. All right, thumb flexion, you can basically do brachioradialis to FPL, because if you remember from your distal radius approaches, they're very close together. Okay, and then opposition, with a low median nerve palsy, you've got 4 options for opposition. Okay, you've got palmaris longus, you've got EIP, you've got FDS to ring, and you've got abductor digiti minimi, or a Huber transfer. Now, abductor digiti minimi tends to be a pediatric transfer because you lose about 25% of the strength. So we don't really use it in adults. So with a low median nerve palsy, you've got those 3 options. But with a high median nerve palsy, you've lost palmaris longus, you've lost FDS to ring, so your only option there would be EIP. Is it? Okay, good. All right, here. So as Saurabh said earlier, classical clawing, hyperextension of the MCP joint, flexion of the IP joints. Okay, so this time, Arjun, can I borrow you, please? I see you're running off somewhere else, sorry. Okay, so again, I've got to basically examine Arjun's hand. So again, look, guys, where am I going to see wasting on the nerve? Hypothenuse remnants, but the most common place you see is first dorsal interosseous. That's the first place to go. So that's where I would look. Okay, scars wise, cubital tunnel, Guillem's canal. Those are the places to look. Feel, high ulnar nerve palsy, dorsal cutaneous branch of ulnar nerve, low ulnar nerve palsy, autonomous zone of ulnar nerve. Okay, and then in terms of movements, all right, I'm feeling a bit more generous this time. I'm going to let you test 4 movements. What are the 4 movements?
Abduction.
What's the highest one? Okay, so you could test FCU. So I could flex it and And say put it in normal direction, say try and straighten your fingers for me. Sorry, try and straighten your wrist for me. Okay, yes, hang on, do that properly. Do it again. I'm going to stop you. Yeah, that's good. FCU. FDP, the little ring, that's number 2. Stop me from straightening it. Stop me from straightening it. That's it, good. Okay, that's number 2. Number 3, what are we going to do next?
Introshift.
Okay, spread your fingers like spiders, don't let me squeeze together. Feel the first dorsal process at the same time. And then what's the last thing I'm going to do? A piece of paper. I haven't got one, but has anyone got? Just give it one. I won't take that. So imagine we've got a piece of paper. And what I do is I do the same. Can you put both of them between your thumbs? And I compare the two like with like. Now, is a positive test me winning the tug of war? Is that a positive test? No. What's the positive test? That's it. It's compensatory flexion of the FPL. Yeah.
That's it. So what is the transfers we need to do here? Well, think of what your priorities are. I've got to prevent cloring or treat cloring, and I've got to restore the key pinch or side pinch, which is first dorsal process and what's the other? Adductor pollicis. Okay. So with the cloring, you can do something called Zancoli's capsulodesis. Okay. With the first dorsal process, adductor pollicis. Any suggestions? Yes. Yeah, you can do that. What else? Really anything you like, that which is non-on that you can use. Okay, so just think, what are the priorities and then what are my options? Good, done. Hitesh, any questions?
No, you can carry on. It's fine.
Fine. So, do you want to do your electives before?
Sure. Brilliant.
Guys, any questions here in the audience while we're switching over? No? And do any of you guys have any questions?
Okay. In the how do I differentiate this, like a contracture of the PIPJ due to this Jupiter itself or something else?
Sorry, boss, just say that again, sorry.
The cause of the PIPJ contractures in Jupiter, not only because of this disease itself, can it happen to different, because some of the fibrosis, they think that the PIPJ contract is not so directly related to Jupiter, maybe something else.
So you're talking about Jupiter, you're saying if the contracture is caused by something else? Yes, so you
always do the
no, it's not. So I've seen PIPJ contractures because of a roller plate injury. I've seen PIPJ contractures because of arthritis. So always examine them. So if I can't feel an obvious cause, other things it could be a locked trigger finger. It could be somebody who's got a volar plate injury. It could be somebody who's got an arthritic finger. So you can get an X-ray as well, and that would show you. Yeah. So I saw one actually interesting. I saw one on Friday in my clinic, and that patient's got a volar plate injury. So the patient had a dorsal PIPJ dislocation, treated conservatively, reduced, sent to hand therapy. When she was referred to me after a few weeks, she was starting to wasn't able to extend it fully. So I put her in a cage and split, sent her quite aggressive hand therapy. It hasn't really worked very well. And so I saw her on Friday, and I've listed her for a volar plate release. I've counseled her, look, it may not completely straighten it and sort things out, but everything feels quite tight there. So that's all volar plate related. That's not because she's had damage to the volar plate scarring problems. So I'm going to go in and just explore that and then do a volar plate release. And if there are any adhesions around the flexor tendon, I'll release those at the same time.
Release the
I'll try not to. I'll just try and release the volar plate. Yeah. So, yeah.
So in your previous nerve lecture,
yes,
I was trying to Google as well. How you mentioned about this neurotopic versus neurotrophic. I could not get my head around it.
Yeah. Okay. Sorry, I've sent you a lecture, by the way. What I will do is I've got you a video for it. Okay. Neurotrophic factors are things which produce growth. Neurotropic factors guide growth, the direction. Okay. Whenever I think of a nerve being cut, layering degeneration, I break it up into what happens at the cell body, what happens at the proximal segment, what happens at the distal segment. The distal segment is when the Schwann cells are left behind, the neural tube collapses, and the Schwann cells form these bands of bunga, which basically produce neurotropic pick factors, PIC. So they guide where the growth should go to. Whereas the proximal segment, you send up this philopodia and you produce neurotrophic factors. So they are producing growth. The proximal segment is sending out growth factors. The distal one is telling it where to go to. That's the difference in neurotrophic.
Thank you.
What's great if you could send a video of the sketch. You said you could send a video.
Yeah, I sent the video.
Right. Perfect, guys. So hand and wrist, elective, same theme. So we'll cover a few other topics if you like. We've discussed this before, isn't it? 24 young man fell down, hyperextension injury. Who would like to have a go at this? What do we see here on an X-ray, on a radiograph?
Scaphoid base action.
Okay.
And then subchondral sclerosis in the distal end of radius.
No, that's not. There's no sclerosis there. So once you got your diagnosis, why do you want to sort of, unnecessarily say something where sort of they will ask you, yeah? So it's a scaphoid fracture, isn't it? What is, looks like there are cysts there and looks like there's a fracture gap there. Normally you don't see such a big gap. So you would ask for a scan, isn't it? Who's going to describe me the scan, guys?
Here, CT scan, cyst of the scaphoid with the humpback deformity as well.
Correct. So there's some humpback going on. There's lots of cysts going on. So it is a non-union, correct? So we'll do a volar approach, waist. And this we have discussed, isn't it? So incision like this, a curved incision centered on scaphoid tubercle. You cure it out all the cysts. Whatever space is there, you take the graft, you put corticocancellous chips, right? Why should cortical piece be thin? So if I were to ask you if you put any bone graft anywhere, how will the sort of bone form there?
Cancellous bone, it happens via creeping substitution. Without the vascular new vessels come down and then the existing trabeculae dies and creates a scaffold and then new bone formation without a cartilage in between. Whereas the cortical is a structural graft, but it heals with the cutting cones. But if you have a big
which takes longer than your cancellous chips,
so
isn't it?
Take time,
Correct. So you want cancellous chips, not so much cortical chips, isn't it? Okay, good. This also we have discussed, proximal pole. What approach? Dorsal. Good. We have seen the dorsal approach, right? Can someone describe to me what I've shown here? So I've gone through the skin, through the retinaculum, which is this tendon, which is the first tendon you will see in a dorsal approach. It has to be EPL. So now tendon is retracted, so I've gone through the capsule now, which is this bone. So scaphoid. Why have I palmar flex the hand? The proximal pole, as I'm showing here, correct? And then your entry point and your screw. Yeah. What screw would you use in a scaphoid fracture? Pitch. Which it works on what principle? How? So lead pitch is more than the trial pitch. So the pitch of the screw which is going into the bone first is bigger. So it has to travel for one 360-degree sort of turn. It has to travel more. So the only way that happens is by compressing. So lead pitch more than trial pitch. Yeah. So the spot diagnosis, Dupetrons, isn't it? So it's affecting, see, I think 5th, 4th, 3rd, and the thumb. Yeah, do we agree on that? Okay, good. So what I've done is small cut to the 2nd and the 5th, runners to the ring finger, and then thumb. What am I holding in my forceps? That's Dupuytren scar tissue, okay? So once I've excised all the scar tissue, you'll get your thumb span back, basically. And what am I trying to show here in my McDonald's? The digital nerves, yeah? So you have to be aware of the nerves, excise all the scar tissue, you're looking at healthy muscles, and you'll get your thumb span back, which is what I'm showing here, correct? So that's why you need to excise the Dupuytren's cord for the thumb, to give the span back, yeah? Make sense? Okay, this was just me showing how common digital nerve divides into proper digital nerves. Can you see this, guys? So this common digital nerve there divides into proper digital nerve, another nerve, and they'll go on 2 different fingers. Yes, same happening here. Common digital, proper. This will go this side. This will go to the other finger. Make sense? Just for you to be aware of digital nerve anatomy. That's all. And this is another patient, and just for me to show you Z-plasties. So they can ask you to draw. So if it's a redo Dupuytren's or a very severe Dupuytren's, patient may need a full thickness graft or Z-plasties, which is part of your consenting process. So that can, then they can ask you about Z-plasty, how it works, how much lengthening you get. Now, if you were to do Z-plasty in this size wound, so I've almost done 9 or 10 Z-plasties, yeah? They have to be very small Z-plasties, and then you don't need a graft here. So just for you to be aware. Guen's canal, again, can be brought up in the exam. So you need to know all the zones, the causes for compression. And then this is the sort of scar, the cut, yeah? So it goes quite distal into the palm, be aware. Yeah, and it's a curve, it's almost going towards where carpal tunnel incision will end. Yeah, because you need to follow the deep branch of motor nerve, if you like. And here, I don't know how much it is visible, but can you see the red structure? That's ulnar artery. And then this yellow structure is the nerve, this and this, which you will see better here. Can you see the main nerve as it goes? So ulnar nerve will go past the pisohamate ligament. That's ulnar nerve, that's hamate there under my arrow, and is divided into a superficial branch and a deep branch. Yeah, superficial will supply your skin of 1.5 ulnar fingers. Deep branch is going to go deep to the adductor pollicis, follow the deep palmar arch. Make sense? Yeah. So just for you to be aware in case they ask you about Guen's canal. So you can see here very clearly, this is the nerve going and dividing into 2, yeah, past the hamate. Okay, so 24, we know this is kind box. We just spoke about it, correct? It looks quite fragmented, isn't it? So you always get a CT scan and see how capitate plows into lunate, and lunate will go volar and dorsal. Yeah, that's important to appreciate. So obviously this is beyond the stage of saving it. Yes, it needs some sort of a fusion work. So what will you offer to this patient? You can, let's work out. So 4 corner is you excise scaphoid, and you're going to fuse capitate, lunate, triquetrum, and hamate. But lunate is a dead, fragmented bone. Do you think it's going to fuse to your 4 corner? So what will you offer? You can do a STT fusion, yes. Yes, you can, or a scaphocapitate fusion, whichever you choose. STT fusion problem is you're trying to fuse scaphoid to trapezium and trapezoid, lots of surfaces. Difficult fusion to achieve. Scaphocapitate is 2 big surfaces, just put 2 screws and broad 1 surface. I feel it's easier to fuse, yes? And I've done a lunatectomy. These little fragments are remnants attached to the capsule. They're not big pieces of bone. So you don't want to disturb the capsule too much, yeah? So, come again?
Joint leveling procedure.
Joint leveling, because once I fuse the bone now, there's no lunate left, there's no pathology left. So there's no sort of reason for it now. Joint leveling you could have done in earlier sort of stages of kind box. Make sense, guys? Yeah. Which approach will you use? Dorsal. What are the steps for dorsal approach? Good. It's as easy as that, yeah? Capsule, what flap? Burger flap, cradle base flap. Retinaculum, between 3 and 4. Yeah. So let's look at, so next few slides are on fusion now. So we've seen scapho capitate. Let's look at the RSL fusion. So see, this is a common injury we see. Smashed, young man fell off motorbike, smashed up radius, scaphoid is fractured. You do a volar plate and a screw fixation, correct? Once in a while, they'll come at 1 year, 2 years with arthritis, which is what happened here. So we got a CT scan and look at the articular surface. It's quite wavy, isn't it? Quite wavy. So he was painful. That's why he was painful. He's got radiocarpal arthritis now. So what will you offer him? What can you do for him? So there's arthritis between radius, scaphoid, and lunate.
Injections, that fusion.
Correct. So you will try non-operative. If it doesn't work, then you're looking at RSL fusion, isn't it? So, which is what we offered him. So because everything was volar, so I took out everything and put this plate from the volar surface. Yes. And if you see the subsequent scans, it has all fused. Radius has fused to scaphoid and lunate. Here radius, I'm showing fusion between scaphoid and radius, between lunate and radius. It is all fused, but he was not happy. And why? Because we've discussed in our distal radius plating lecture, this plate is crossing watershed line, isn't it? And you cannot put a PQ here, like how much ever you put, it's a big broad plate. So FPL was getting irritable. Obviously, we didn't go dorsal that time because we had already gone volar. So we thought we may escape. Who knows? It's not going to happen in 100 out of 100 cases. So looks like FPL was getting irritated. So I just took the plate off. It still confirms the fusion. So he was happy. Yeah. So, no, not at all.
Is it possible to mention that one plate, the spiral plate, for the self-releases?
If we can do which plate?
Span from the radius to the vertical.
To fuse it. So see, few things. So if you are doing that, you have to go from the dorsum. If you're doing that, then you are also fusing the mid-carpal joint and the MCP joints. Whereas just by doing RSL, I'm preserving those movements. So if they're not arthritic, we should preserve the movements, isn't it? So you can do it, but why? Like sort of.
That's all. So for fusion in young active patients. Right?
For fusion what? Sorry.
For young active patients, just like a labor.
Yeah. So even if you do a total wrist fusion, actually it is designed for young manual laborers. Because once your wrist is fused, they have a good solid platform on which they can move their fingers. So they do very well actually. I've done lots of wrist fusions for young manual laborers. They're fine. They go back to normal livelihood. So now again, slack wrist, we know that no marks for guessing, we agree. We know how lunate will extend, scaphoid will flex. Always do a wrist scope to see whether it's a slack 3, slack 4, what it is. For example, here, you know, it is a slack 2 at least. You can see arthritis throughout scaphoid. Capital lunate doesn't look so bad, does it? When I put a scope in, the capitate surface was gone. So if it's a slack 3, what can we offer him?
Can't offer a proximal
No, can't, agreed. Yeah, so scaphoidectomy and four corner fusion, and maybe take off a bit of radial styloid so that this doesn't hit here. Yeah. So this is what we did. Yeah. So see, I've taken a bit of styloid also, and can you see I'm fully radially deviating, and with full radial deviation, there's a gap. It's not hitting. So do take off a bit of styloid if you have to. Make sense? So it's easy once you understand the stages. Now see what's happened here. No, that's another one. So done. Okay, good. What can be the complication for these plates if they ask you? See what's going on here. This plate is a bit broad. Can you see this? And it is on extension. It will hit dorsal rim of radius. Can you see this lipping osteophyte forming? So obviously this will be very painful. So the only answer is to take the plate out. So when you're doing a spider plate, look at this, it's all buried, it cannot impinge, yeah? This has to bury, it can't hit your radius, that's the key. So when you are reaming from the top, you ream enough so that plate sinks down. Metal shouldn't be proud of the bone. That's the key here. So if they ask you, that's a potential complication of a spider plate, yeah? Then another lady, scapholunate injury, acute injury. I think this we have done before. Put a scope in, see what it is, and put some wires and anchors. Make sense? What approach will you do? Good. Male manual laborer. What's the diagnosis here? So scaphoid non-union. If there's a non-union, I'm looking for snack. Is there any arthritis here in this area? Answer is yes. Scaphocapitate, yes. Capitolunate, maybe. Then you put a scope in, and if you see radiolunate arthritis, which I saw, then it is a snack 4. You don't do MRIs. It was done by a colleague of mine who referred it to me, and you can see how lunate has got high signals and corresponding signals in radius also. So you know there is radiolunate arthritis even on MRI, yes, which is confirmed by scope also. So if it's a snack 4, what can you offer to this patient? A total wrist. You can replace it or fuse it. Manual laborer, would you replace it or fuse it? Correct. So the fusion, yeah. And again, if they want you to critique it, you can see this is your key thing. That's where force transmission happens. Intermediate column. You can see trabeculus or radiolunate has fused. We agree. This screw is prominent. If they ask you if it irritates the extensor tendon, you just give a little local, little nick, take the screw out. Nothing more to be done. If it irritates, yeah. So you don't say I'm going to give GA and start taking the whole plate out. It can be done under a simple local, yeah. Okay, diagnosis. Anybody who wants to read this X-ray? It's easy. I can take you through it. Anybody? Guys?
Equilateral plane radiographs of the right wrist, which demonstrates really confident and as well as mid-carpal osteoarthritis, basically.
Very good. Yeah, she may have had lenotricutal before. She's 73. Who knows? It may be carpal instability, adaptive. Who knows? But yes, it's a good thing to pick up. I agree. So it is osteoarthritis. Why not? Why is it not rheumatoid arthritis? So what features will you have in a rheumatoid wrist? Rishi told us. Wrist will deviate radially, other words. Correct. We don't see a radial deviation here, do we? And then you'll have osteopenia, blah, blah, blah. You can always say, I want to see MCP joints. They should go all words. Just show you theory knowledge. And by, examiner will lead you. Yes? Okay, good. So what are your treatment options here? 73. Okay, always start with what treatment? Unless he's come to you 2-3 years after non-operating, gone to physio, gone to GP, has had 100 steroid injections and 200 resistant therapy. That's a different matter. Otherwise, you start with non-operative. You try splints, you try some activity modification, whatever you can. Steroids, and if none of those work, then what are your options? Neurectomy. When will you do a neurectomy? So it's an option. In which patients? In the patients who are not fit for a big operation, lots of medical issues. Then you can try that. She's fairly active and fit and healthy. Correct. So see, wrist, you have 2 options, fuse or replace. MCP, you don't fuse, so replace. PIP, you fuse or replace. DIP, you fuse. So if you think like that, you will know.
MCP, you fuse, you don't replace. Yes. IPs here, you fuse like your DIPs. Okay. Trapezium, you do hundreds of things. Replace, trapezium, LRTIs, some tendons, lots of things. Once you think like that, you can very confidently take the options. Fuse or replace, I discussed both of them as you told me. She wanted a replacement, so I did it. Okay. The reason I'm showing II images is just to tell patient that how much extension I got, because grip comes with extension and how much flexion and radial ulnar deviation, just to motivate her to move her wrist after surgery. Yeah. To show it was stable, it was not distal. And this was 3 months post-op. Yes, you have to put this thing in. Yeah. You need space there. So you do PRC and then you do that. It's a tight space. Drudge arthritis, in case they bring it up. Again, you do your steroids and all that. And then you can do these ulnar head hemis. Yes, that's always an option. Oh, yes, good thought. Darex is only reserved for elderly rheumatoid, where you want to do minimum. The Darex means the ulnar will hit radius on loading, so you get impingement pain. But if you do solving FMG, it's like doing a proximal Darex. It's even worse. It will still keep hitting. In rheumatoid for Vaughan Jackson, and I've got a case I'll show you, which I again did on Friday. So I put all those for you guys. There you can put the capsule inside like bowels, like a soft tissue interposition. Ulnar head has come up, caput ulnar is eroded because of enzymes. So you nibble all this, smoothen it. Put a better prosthesis. Just to show you, in case they bring up this discussion drudge somewhere. Finger arthritis. So do you guys agree? Second, third, fourth PIP is arthritic. Yeah, see, second, third, fourth arthritic. Do we agree? What are the options? Non-operative. If it doesn't work, then options. PIP, you can do what? Fuse or? Yeah, she wanted replacement. Fine. And you assess the patient. You're not going to start replacing 3 joints and spend 6,000 pounds, expensive implants. So I fused it. Yeah. Once it heals solid, she will work very well. What am I showing here? Some finger, ring finger, PIP arthritis. Do we agree there? And middle finger, DIP, OA. Do we agree there? There may be lots of arthritis and lots of fingers, but these two are hurting her. DIP, easy. What's the option? Only one option. PIP, what's the option or options? So you talk to the patient, nothing is right or wrong. Assess the patient. A patient is 40, wants to lift 200 kgs in gym. Why will I replace it? I'll fuse it. If it's a sedentary lifestyle patient, 60, 65, retired, wants to just do some kitchen work, I can replace it also. But she loves knitting and all that, wants some movements, fine work, I'll replace it. It's as easy as that. So I replaced it and then fused this joint. Yeah. And this we have shown before. It looks like a knee, upside down knee, if you like. MCP. So this patient, as Rishi was telling you guys, central slip injury, boutonniere, lateral band has gone, volar to the center of rotation, causing extension at the IPJ. He was not so worried about IPJ. He didn't want any reconstructions. His main worry was MCP. So I've done an MCPJ fusion. Yeah, simple as that. And he's happy. He's a retired Sri Lankan GP actually. So whatever patient wants, every chronic boutonniere doesn't mean you start reconstructing lateral bands. Sometimes patients want something different. This is just to show you that. So see, I've shown you MCPJ fusion, correct? If you see, it is hard to know, but this device will tell you this angle is around 20 degrees, correct? So thumb should not be fused straight, slightly flexed. So if I was to show you, this was a case with Miss Reichert and I did together. Someone did, it looks like ancient kind of surgery, but MCP is completely straight. If MCP is straight, you struggle with daily functions. So we have revised it now to see 20 degrees of flexion.
Yeah. So even though it fused beautifully, but so what I'm trying to say is with PIP fusions, MCP fusions, you have to be careful in the position you fuse. These days with this beautiful intramedullary implant, your angle is pre-decided, which makes our life easy. But if you were to use these wires or tension bend wire or free screws, build in those angulation. Otherwise, patients don't like it.
This wire still in practice?
I hope not, but who knows, Mufi?
Was it in the UK then?
Must have been, 15, 20 years ago.
Long time.
Yeah, a long time. IP arthritis, obviously you'll fuse it, correct? Again, build in a bit of flexion. Yeah. So it's easy. Wrist can be replaced or fused. MCPs, replacement. PIPs, fuse. DIP. So it's just alternating, isn't it? CMC, we're coming to that. CMC, there are lots of options. You can do anything there also, replace or fuse. MCP again, this can commonly be asked. MCP somehow, they love to ask this. And we replace them here. But you can also discuss about volar plate interposition, soft tissue interpositions. So even though index and thumb have pinch, but with these replacements, the lateral forces are not high for them to become loose. So you can replace those. So we've done all sorts of, I've shown you replacements and arthrodesis from wrist to fingers. Any questions so far? Especially in rheumatoid, they'll bring it up. So you have to talk about, okay, I'm going to replace, I want to preserve movements. MCP, you can use Swansons. PIPs, you can say I can fuse or replace, fine, but don't fuse every joint in rheumatoid. You want to preserve some movement. So if you're fusing one, replace the other at least. Yeah. This is quite straightforward actually. So 61, there's a bit of angulation there. And in A&E, this was reduced. It's acceptable at 70-ish. But again, followed up late and it slipped back to where we started. So message here is in distal radius, follow them for first 3 weeks, not 2, 3. They slip actually after 2 also. So now she's not happy, obviously marked angulation. Look at the lunate. So what type of carpal instability is this? Adaptive, is adapting to the new home. Look at the capitate completely falling off. So what do we do now? She's not happy, year has gone by. Corrective, beautiful, okay. Where will you go from dorsum, volar?
So incision would be in the direction of the previous fracture line. But I would actually, sorry, I would also do a dorsal approach to pack the defects with bone graft as well.
You'll do double approach. Why not go from dorsum, pack it with graft and put a plate there?
So in my practice, my experience, I've always done roller and then a small incision to pack it with the graft.
Oh, this is how you do. Yeah, that's fine, acceptable. Fine, you can do that also. Yeah, fine. If you're doing a small incision, then I'll accept it. Agreed. So radius has 3 deformities, isn't it? Which 3 deformities?
Inclination.
So okay, good. So on a lateral view, is there a deformity? Dorsally tilted. We need to correct that. On this view, is the radius short? And inclination may be okay, who knows? Maybe a little less, maybe okay. So these are the 3 deformities you look for. These are the 3 deformities you correct. And I've shown you if you put your plate and put distal screws first, whether you go volar or dorsal, you can correct all the 3 using a plate, isn't it? Agreed? Do you agree on that? So I went dorsally because I felt I have to do a lot of correction, and then I packed it with graft and I put a plate. Yeah. If they ask you with dorsal plates these days, because they're low profile, high grade titanium, 1 in 5 needs to come out, not more. Okay. This is a bit complex case, but I'll make it a bit easy. Distal radius, very common fracture, very commonly mistreated, maltreated, missed, whichever is the right term. So this is what happened to this lady. these are her healed X-rays basically. So radius is short, it's dorsally tilted. And then when I got a CT scan, look at the surface. Do we agree it's very wavy? And then I gave her a steroid in radiocarpal joint. A lot of her pain settled actually. So like that young man in motorbike, I thought, okay, she does have radiocarpal symptomatic OA, which I need to address. And she also has a malunion. So two problems, two operations maybe. So for radiocarpal OA, I can do a RSL fusion. For a malunion, I can do a corrective osteotomy, correct? Both can be done from dorsal. So see, these are the options. Can you wait and see? Yes, you've tried, you've given steroids, it's helping her. So you know, operation will help her. Corrective osteotomy, yes. RSL fusion, yes. Combined, yes. Salvage, what salvage? Like neurectomies at her, she's active, no. Ulnar shortening won't work because problem is in the radius. So answer would be 4, isn't it? Osteotomy and RSL. And these are the unacceptable healing variables. You know those, so I don't need to sort of go again. And so this is important. So see, when I went from the back, just bit of tips and tricks, just for you to reinforce corrective osteotomy. So you always, so I always put a wire in this through the capsule. So I know this much dorsal tilt is there. Yes, this wire tells me. So then what I do is I put 1 or 2 wires proximal to drudge. You don't want your saw to go into drudge, into sigmoid notch. Makes sense? Then I take a saw and cut here from the back. And now with my laminar spreader, see this spreader is opening more, this is less. So I'll get my radial inclination, you agree? Radius is out to length, you agree? And once I'm happy, I'll temporary wires to hold it. And I'll check my lateral to see my tilt. All of it makes sense? Once I'm happy, you take a lot of graft. This needs a graft because it's a big hole. You pack it up with graft, you do a dorsal approach, and because this plate is not long enough, Medartis plate, so I put another extra plate. That's the reason you're seeing 2 plates, yeah? Make sense, guys? So see, you can see this plate is from radius into lunate into scaphoid. Yes? And because I've done a corrective osteotomy, this plate finishes there and that's my osteotomy. So I've just put another plate, that's all, a hand plate, improvised it. So again, same.
So how to do a corrective osteotomy there? Would a fusion not work?
I could have done a RSL, it's a good question. I could have, so if I take you back, I could have done a RSL fusion there, yes. So her radiocarpal pain will go away. And I knew from my steroid injection that half the pain goes, half is still there. And the reason being her drudge is not okay. She will still have rotation pains. So that's why I gave her a steroid. So I knew I have to do both. And this is the approach, guys. You know that skin, retinaculum, burger flap, and see my wire in the joint, 2 wires parallel to it, proximal to drudge. Then I've osteotomized it. I've packed it up with graft there. Plate. So this is what I was saying. You know, this is where my osteotomy is. I only have 2 screws there. So I was not happy. I just put a plate from the hand. Put any plate just for reinforcement. So then this is the capsule. I put the capsule back and the retinaculum back. EPL always stays out. So it's just principles. You've seen all these X-rays. It's just what is this going on there? So 63 distal radius malunion, isn't it? Smith malunion, do we agree? Ulna is long, do we agree? So Smith fracture missed, malunited. Obviously, he will be in pain. These are his movements and they are painful. You look for all the 3 deformities that we have spoken about. Is gone in the front. So your osteotomy will be from the front. Because it's easy to go from the front now and bring it up. Because your V will open up from the front. Makes sense, isn't it? I don't think I have X-rays for this. This is again malunion, so we'll ignore it. Can you be asked about ulnar shortening osteotomy in a distal radius malunion, or is it too much? Okay, just for completeness sake. Malunion, But see what's happened. Is radius short? Yes. Inclination is good, looks reasonable. Tilt looks reasonable. So that means my only problem is shortening of a radius. So if I can shorten the ulna here, the head as it comes down will still sit in the sigmoid notch. So these are the only cases in distal radius malunion where you can do a ulna shortening osteotomy. Otherwise, problem is in radius, you address radius. Yeah. So just for completeness sake on this chapter, I put it here. Yeah. Important. So about so radius has deformities in 3 planes: inclination, shortening, and a dorsal tilt. So if these 3 are happening, the sigmoid notch will change the orientation. So if I shorten the ulna, it's not pointing in the right direction. They'll have rotation pains. But if inclination and dorsal tilt is okay, radius is just short. The sigmoid notch has just become short. Ulna head is there. If I bring the ulna head down, it will articulate. And it's an easier osteotomy than a radius, basically. You could have done a radius osteotomy in this case also. Doesn't matter. Doesn't matter. So important questions here. I think, okay, well, when to do distal radius corrective osteotomy or ulnar shortening, we know that. When to use graft for exam purposes in every case. When to do dorsal volar approach, if it's a Smith malunion volar, if it's a dorsal malunion dorsal. Although you can mix and match, but I don't want to confuse you guys. That's why I've skipped that dorsal malunion slide, the last one. Axial shortening is ulnar shortening, I've told you. This you can ignore. Importance of correcting radial is to do with the orientation of FDS and FDP going through carpal tunnel, but that's too much. Ignore that. These are not my slides now. Few wrist arthroscopy pictures, because we've not touched on scope today. We're not doing any lectures. Are you guys asked about wrist scope these days? Oh no, nothing at all. Part 2? Okay, anyways, it'll take a minute. I'll briefly touch, not too much. So wrist scope is very valuable in slack and snack. Well, I can't stage it any other way. Sometimes MRI will show me something, sometimes it won't. Like it showed edema in that case. We cannot comment on cartilage MRI. I can't rely on that. So to differentiate between your capitate and lunate articular surface, isn't it? Because it becomes a slack 3, snack 3, slack 4, snack 4. And it changes my management. So that's when you put a scope and you can see grade 4, like from your knee scopes. Yeah. Then scapholunate. So this is, again, think of your knee scope. If you have a scapholunate dissociation, these are the pictures you get. Those for those of you who've not done a wrist scope. That's my scaphoid. That's my radial. Can you see the rim there? That's my radial styloid. So you can see styloid, how it wears off, like your knee scope. And then you can see the head of capitate here. Can you see the wear? So I know this is at least a slack 3. Yes, correct. This is how you are staging it. Scapholunate injuries. Are you guys asked about Geisler? No, too much, isn't it? Like with they're not, no? Like with anything. Portals are 3, 4, and 4, 5 basically. Yeah, like that's what you'll be asked. Geisler, like with anything, 1 is some tear, bit more tear. 3 and 4 is bando. You can go through it. You'll not be asked. Lunotricutal. Again, this is the sort of gap you see, in all those lunotricutal ligament injuries. But you won't be asked. So I've just put a few slides. That's how a normal TFCC looks when you read upon it. Like a drum, like a trampoline effect. When you probe it, and this is a lax TFCC. Can you compare these two? So when a TFCC detaches, it will just become lax. TFCC, I think, can be asked. So just keep this picture in mind. And this is how you debride it, like your knee meniscus, and you debride it to healthy margin. You may see ulnar head, doesn't matter. Till the time periphery is okay for TFCC, it's fine, it's stable. Yeah. Okay, who can describe this lesion to me? So this patient has come in with pain to the distal phalanx of whichever finger. What's this? I know the diagnosis is there, but who can describe the lesion?
Finger, AP view. AP, I'm going to describe the first image.
Sure.
AP view showing the most obvious abnormal in a currently mature patient, showing that the most obvious lesion is a lytic lesion in the distal phalanx with a narrow zone of transition. I can see some breach of the cortex and maybe some soft tissue swelling. There is some evidence of speckle calcification as well.
Okay. What's the most common tumor in a finger? Is it benign or malignant?
Most of the time.
Most of the time, enchondromas are benign, right? When you use the word lytic, what is it conveying to the examiner? Malignant lesions are lytic or not? Correct. So be very careful. Lytic is a very strong word. Unless you are 100% sure it's a malignant lesion, don't use this word. Say radiolucent. With lucent, you can turn it into malignant. If by the time you're describing, you see other features of malignancy. Once you say lytic, you can't come back to benign. Lytic means cancer straight away. It's a strong term. So don't say that, yeah? Similarly, breach of cortex. I know it looks like here, but it may be underexposed. You know it is enchondroma, and you can kind of see here, see how well circumscribed it is. Yes, it's ballooning, scalloping. So you have to cater your answer to a benign enchondroma lesion, correct? So have another go. So I see a lesion in distal phalanx of whichever finger. You can't see the finger, second, third, fourth. I see a well circumscribed lesion. I can see sclerotic margins. Yes, there's a bit of ballooning, fine, of the phalanx, but narrow zone of transition. I do not see soft tissue reactions. I do not see periosteal reactions. I feel it's a benign lesion compatible with enchondroma. Yeah. All this bit of swelling there, soft tissue is no, so that means you are saying it has gone into soft tissues. This is just because the whole phalanx has ballooned a bit, basically, nothing more. So what will you do if it's painful? You can go midline, mid-axial approach. You can go through the top depending on the phalanx. For the proximal phalanx, I went midline. This one you see on MRI. Let's say you go midline, even though you know you can't because your thumb is there, your nail is there. So you'll have to go through the side in this. You go through the side, you curate it, curettage it, take a bit of graft, put the graft there from volar radius or wherever you want to take it. You can easily take it volar because you're doing a mid-axial approach. And then in 4-5 months, this is how it looks. It heals up. Yeah. So lesions wise, just be a bit. So now next few slides are on carpometacarpal joint, yeah, CMC, because trapeziectomy is asked, isn't it? What's the latest evidence now? Simple trapeziectomy? What's the exam answer these days? Simple? Same Tim Davis Nottingham or any other paper has come since 22 decades ago? No paper? Okay, very good. So just quote that. I learned that 10 years ago, I think. Yeah, it's the same. So Tim Davis, Nottingham, simple trapeziectomy, okay? But in case you're doing very well and they want to probe you further, so this was done, so metacarpal can sag, isn't it? So if it sags, it starts hitting the trapezoid and scaphoid. So you can do a mini tightrope, simple answer, like your mini tightrope for ankles. Yeah, make sense? Then again, see how as metacarpal sags, how much it has scalloped on scaphoid. So this lady is in a lot of pain. And then APL sling. So APL, your approach for your trapezium, APL sling was taken. And they may have even put an internal brace. Oh, so they put an APL sling with some whatever internal arthritic brace or something. Bottom line is it's again failed. You can see the metacarpal has come down to where we started. So then this patient but still is in pain. So this time what I've done is I've gone from the front, I've taken FCR, wrapped it around LRTI, as you know, and further reinforced it with a tightrope there. Yeah, let's see how it works. Well, all I'm saying is in a metacarpal sag, you can use your FCRs, you can use your APLs, you can even use ECRLs, you can use mini tightropes, You can use internal braces. Principle is the same, is holding the two bones together. Yeah, depending on the approach previously, if someone has already taken APL, then I have to take ECRL or FCR. Yeah. Now this lady, if you see, can you see slack there? Slack 2 is already there, 3 is already there, and I must have done a scope to radial unit look pristine. She's symptomatic, so I know I have to offer her a four-corner fusion, which then means I have to excise the scaphoid. Now, if you see she already had trapeziectomy, look at where the metacarpal is sitting on scaphoid. Once scaphoid comes up, it may further come down. So I have to do something with it. So because I've gone from the dorsum and ECRL looks at me, I've wrapped ECRL this time. Yeah. So whichever approach, you just improvise. So what I'm trying to say is for trapezium, you were asking, there are lots of options, lots of tendons available, arthrodesis in manual labor, MCP should be working, and you can even do a thumb replacement these days, not for exams, but for you to, for completeness sake. So this patient is 72, very healthy, and you know, this area is white Caucasian. So influential rich people, healthy, they want to get on with life. They want to have the best available sort of surgery, if you like. So again, arthritis, not happy with steroids. So I've done a thumb CMC replacement. Yeah. And these all have value. They're not for show. It keeps thumb out to length. It stops sagging. They get on with their lives. They're in 70s. They're not lifting 50 kgs in a gym. So they all have valid sort of indications. So you will not be doing those unless you are a hand surgeon, but at least at the back of your mind, you know how trapezium should be handled for completeness sake. It'll give you more authority. Last few slides, Vaughn Jackson. Who wants to have a go at this? So I can show you the video. 2 dropped fingers. Okay, my lovely voice. You can see 2 dropped fingers. Do we all agree on that? Now differential for it. Okay, good.
Yeah, in injury, although it will involve all other fingers, so it's
good.
Extensive tendon structure in this case.
Good. You have dupetrons from the front, from lock trigger fingers. Yes. Okay, good. If it's a sagittal band, so you've told me how to differentiate pin. Extensor tendon, fixed length of tendon, stenodesis effect, you can see. You will know whether it's a tendon rupture or not. Dupetrons, you can see from the front, trigger finger, you will see patient.
You will passively extend the finger, it should stay there.
Exactly. If it stays there, sagittal band. If it doesn't, that is not. Yes, we agree on this. So, and you also had this big swelling there, all right, which is what? That has to be synovitis, some inflammatory process going on, isn't it? So this is the kind of incision, we agree? Once I've incised, this swelling is all ulnar head swelling. So now we know why he had a capital ulna and eroded ulna and why tendons were rupturing. Look at this swelling. And especially what I want to show you is, see the stitch? What am I holding there? That's a ruptured tendon. Hold that thought and see the next slide. This we just did actually on Friday, 2 days back. So now that's the ruptured tendon, stitches out now. And once I opened like your ganglion, the swelling, fluid came out. What's this? The other end, yeah? So what I'm trying to just show here is how tendon ruptures encased in a synovial fluid. The fluid will eat it up, all the proteinases and enzymes and yeah. And see attritional rupture, see a gap. And as this tendon shrinks, the cavity follows it. It's not out, it's still encased. Yeah. So it's just to show you the etiopathogenesis. And then these are the ruptured tendons to the little and ring finger. Now, middle finger, my arrow, follow the middle finger tendon. What am I showing here? Healthy there, healthy there, healthy or not healthy? So stages of rupture, how fibrillation happens. And if I was late by another 4 to 6 weeks, let's say, bit by bit, this will start rupturing and he'll have a middle finger gone. So just to show you the etiopathogenesis, yeah? Make sense, guys?
Yes.
And then, so what I had planned was initially at this stage, when I saw him a month or 6 weeks ago, I need to do some tendon transfers to these fingers, right? So what tendon transfers would you have done? You would have taken EI. EI is spare. Yes. You would have taken EI to, let's say, little finger. Ring finger is left. I could have taken FDS to ring finger. So that's what I was planning for him. But on table, I saw middle finger. This is middle finger. Look at the index finger tendons. Yeah. Again, not good. Yeah. So I thought both are unhealthy. Index finger tendons are unhealthy. If I take one from there, the other tendon will be weak. And I thought for thumb movements, I don't want one weak tendon. So I decided to leave the EI tendons also. Took a picture for medical legal purposes. So now the conundrum is I've got 2 dropped fingers and I have no tendon from the back. So what should I do? FDS, correct. So ring, either I put the ring to both the fingers or I can take 2 FDS from middle and ring, isn't it, guys? Agreed? Easy so far? So see, this is the kind of incision you do, proximal to wrist crease, A1 pulley to ring and then A1 pulley to middle. And what am I trying to show here? Yes, like before. So I felt this you can passively extend. So it's not FDP, promise. It'll always flex a bit. You can't help it. If it was FDP, you can't passively extend. So I pulled on the FDS to ring finger. What happened, guys? FDS to ring finger. Once I've confirmed, only then you cut from A1 pulley. Because if you cut it before, it's very hard to find amongst 8, 9 tendons, which is the right one. Yeah, so you identify to ring finger, middle finger like this, same maneuver, cut off the 2 tendons, and then you feed them from here, come out dorsum at the back, which is what I'm showing here. Okay. So I've got 2 tendons to spare. These are all EDC, 4, 5 tendons. That's the retinaculum, which is all eroded by synovial fluid also. So now what did I do? Let's see. So what I've now done is, because now I have a middle finger, ring finger. So for those, because middle finger tendon was intact but tatty, so middle and ring, I made it into one and then a pulvar weave here with 1 FDS. And the other FDS, I've gone to the little finger. There were 3 EDMs. EDMs can be up to 4. Yeah. So there was 1 EDC, sorry, and 2 EDMs. So there were 3 in total, but EDMs on its own can be 4. There can be 5 tendons to little finger sometimes. Be aware of that. So there were 3 tendons and I've just, but they are too tiny for pulvar. So I've just wrapped them around. You can see I've wrapped it, yeah. And we got very good tension on table, like I showed you with FPL. And then obviously drudge had to be taken care of. So what I've done is, this is ulnar head. I've trimmed it to half the size. And that's my capsule, which I'm holding in my forceps. And see what I'm showing here. So if I see, I'm wrapping the whole head with the tissue now. Can you see this? Yeah. So this will go right there inside. So what will happen is, this stitch is in the volar, on the volar tissues. So when I interpose now, head is encased in that capsule. And I have to take half of retinaculum also, because there was hardly any capsule. So that head will now keep moving under the capsule and retinaculum. Because sigmoid notch is also great for arthritic. If you see here, that's the sigmoid notch, like a cup. So drudge pain will go away. Ulnar head will not irritate the tendons. Make sense? So this is what you have to bring up in your discussion in a rheumatoid case. Oh. And then finally, because retinaculum was not so good, I took pomaris longus. And can you see this tendon? This pomaris longus. I'm making some sort of a sling so that these tendons do not bowstring. And you can see as I'm moving, they are gliding smoothly. EDCs and EDMs. Yeah. So, and then finally I stitched this back on there. You can see now. Yeah. So your EDCs, EDMs are all under this pomaris longus and retinaculum, sort of a retinaculum. Like I made a retinaculum, and this is that Barber's procedure there. Does that make sense, guys? So for Vaughan Jackson's, because rheumatoid is an important topic because they can discuss so much with you. Intended transfers because they can. So that's why I put this slide here. And this is my website along with orthopedic principles. There are 10-11 lectures, all catered to FRCS and sort of firstly with consultants. Yes.
With expenses ended, are you able to justify the remaining?
Saurabh.
Hi, Hitesh.
Hi, Saurabh. Can I ask a question to the delegates?
Yes, please do, Hitesh.
Yeah, I just ran a poll on our website, YouTube chat, and I just asked about what is the variance that you see in Kienbock's disease? Is it ulnar positive variance or ulnar negative variance? So let me see what the delegates got to say over here.
They are all masters now, Hitesh.
Negative.
Yeah, I know.
Negative or neutral?
Neutral or negative, they are saying.
Okay, so it has a strong correlation with ulnar negative variance, right?
Yes.
Okay, so the reason I asked is on the YouTube chat, we have almost 60% saying it's ulnar positive. So that's why I just wanted to
that's wrong.
message.
That's wrong. It's correlated with ulnar negative variance.
Exactly. So it is ulnar negative variance, but unfortunately on the YouTube chat, we ran a poll and the guys got it wrong.
Send them all to prove to us.
Yeah. Send them all my courses then.
Send them to Rishi's course. So,
and the other question was with Rishi has already emphasized that what is a cell implicated in Dupuytren's contracture?
Myofibroblast.
Not the faculty, the delegates.
The delegates.
Not that I know. Guys, what is the cell implicated? Myofibroblast.
Okay, so that's pretty easy.
So what type of collagen is implicated?
And what is the osteotomy that you do for Kienbock's disease? What shortening or lengthening osteotomy?
Radial shortening.
Radial shortening. Okay, great. So I just ran a poll, so I just wanted to know the opinion of the delegates. Okay, great. So Rishi, back with your classic lecture.
Fantastic. So guys, I'm gonna give you the slightly sort of very exam focused, very compressed version of this lecture because I've delivered it previously, the full lecture on the Orthopedic Principles channel. So please, I refer you to that on Professor Gopalan's Orthopedic Principles channel. But this is an area that people often struggle with, and so I'm going to simplify it for you as much as you need to know for the exam to get an 8. Okay. So congenital deformities of the upper limb, that's what's going to come up basically. So I'll teach you how to generically approach a congenital deformity case and then specific management of some of the key cases that come up in the exam. As I say, I'm going to shorten it for brevity. The full lecture is on the Orthopedic Principles website. So the first thing you want to do is you want to introduce yourself to the patient. If it's a younger child, then you may introduce yourself to the patient and also the parents. If it's an older child, just treat them like an adult. Simple as that. Okay. Take a history, find out how the condition itself affects them and what they presented with, not just the deformity, but what's their actual presenting complaint and any risk factors. And that's the key thing for the exam. So as a day one consultant, they're testing your safety. It's not the deformity that will kill the patient. It's the associated conditions. So you being a safe day one consultant is, are you going to pick up associated problems with the heart, the spine, the kidneys, etc.? Okay. So the key question I want to know is it syndromic? That's what I want to know. All right. And then you examine them and you want to do sort of a head to toe exam, but basically try and use broader terms. Don't say things like abnormal or missing because it can be insulting to the patient, and do a functional assessment as well. So that's kind of my generic approach. And then investigations, I think of sort of hemodynamic investigations. They may need chromosomal or genetic testing, and they might need scans of their kidneys and their heart, as well as the limb itself. And that's just to say if it's simple, does it involve the soft tissues or does it involve a bony deformity as well, simple or complex? So that's kind of my generic approach to any congenital deformity. So if you ever get something in the exam, you don't know what to do with it, go by that approach. Okay. And then management, think about these different headings. First of all, what is the correct setting? Should this be done in my DGH? Probably not. It probably needs to be done in a tertiary center with an MDT-based approach, pediatricians, geneticists, etc. So MDT approach. What are your goals of treatment? Okay, think about what the goals are. All right, what are some of the challenges you face? When do you want to intervene? And what are the principles? And it's basically to improve function, but also for cosmesis as well. And then further management will be specific to score a 7 and 8. So the way I think about it is generic management and the approach will get you a 6. The 7 and 8 will be about specific management, okay, in the exam. I always say to people in the exam, try and take it to the basic science. Don't just use basic science in the basic science station. See if you can bring it into other stations. And I always think of it as, imagine you're in Star Wars, Revenge of the Sith, where Obi-Wan and Anakin, one of you's got the higher ground, okay? The examiners are always uncomfortable with basic science, trust me. Very few of them are good at it, okay? So if you know your basic science and you can bring it in, you've automatically got the upper hand. So whenever I see a congenital deformity, I'll always throw little breadcrumbs about embryology. This is a congenital deformity of the upper limb. It's caused by a failure of formation due to a deficiency in the sonic hedgehog gene governing radial to ulnar growth. And I'll throw it out there like that, some little breadcrumbs. Okay, so embryology, the limb buds, remember Rishi's rule of 3. And I'll send a video to the group, or you can look at my videos for this to subscribe to those. But essentially, 3 zones, 3 genes, and 3 directions, okay? So the 3 directions of growth are proximal to distal, governed by the homeobox gene, radial to ulnar, governed by the sonic hedgehog gene, and dorsal to ventral, governed by the wingless type gene. And the 3 zones of growth are the apical ectodermal ridge at the tip of the limb bud, the progress zone just behind, and then the zone of polarizing activity, which is normally where the sonic hedgehog gene works. So remember that 3 zones, 3 genes, 3 directions, my rule of 3s for embryology. Okay, classifications wise, the one you're probably all familiar with is Swanson, okay? Failure of formation, differentiation, undergrowth, overgrowth, duplication, constriction band, and skeletal dysplasia. There's 7 of them, okay? OMT is a relatively new classification. Don't worry about it for the exam, okay? That's just what it looks like. Right, so now I'm going to go on specific cases which I think will come up in the exam. This has come up many times in the short cases, okay? So, clinical photograph, what does it show? Everybody shout out the diagnosis. Radial club hand, okay? Now, if I was going to describe this, I'm all about economy of phrase. My philosophy is every word that comes out of your mouth should score a mark. So don't waste time, okay? So I would say this is a clinical photograph of a child's upper limb, which shows 3 things: shortened forearm, radial deviation, absent or hypoplastic thumb. I'm not even looking at the patient, all right? I've got that spiel in my head. I also note that there is a scar indicating that this is a recurrent radial club hand, okay? So it's a failure of formation due to a deficiency of the sonic hedgehog gene governing radial to ulnar growth, okay? It occurs in about 1 in 100,000 patients, okay? And it has a spectrum of disease where it can be very minor, to just a shortened forearm, to full-on arm at right angles. So remember what I said, basic science, Rishi's rule of 3s, sonic hedgehog gene. Now, if I'm assessing this patient, they come up in the exam, why do I start? So the first thing is I talk about the 3 points of what I see. The next thing I'm going to do is I'm going to check the patient's function. And what's the key function you want to test with radial club hand? Does the elbow work or not? All right. Why is that important, Sahel? So it's not so much for centralization. The problem is if the patient's got a deformity and the elbow doesn't work, they may be relying upon their deformity to feed themselves. And if you then go and correct that deformity, you will defunction that upper limb. So that's the key point. All right. So the next thing I'm going to say to get me my 6, to pass the station, is I'm going to exclude any associations. All right. And there's 5 associations for radial club hand: Vactyl, Holtorum, Tar, Fancones, and Vata. Gosh, you guys are very good. All right. So 5 associations, okay? Vactyl, Vata, Holtorum, Fanconi's anemia, and Tar. All right. So this is what I call poker, guys. If they give me a congenital deformity in an exam, and I've never seen it before, I'm going to describe what I see. I'm going to talk about a functional assessment. And I'm just going to throw out associations. Vactyl, Vata, Holtorum, Tar, Fanconi's anemia. I'm going to say it with real confidence, poker face, and the examiner will not challenge me because they won't have a clue. All right. I promise you that is it. And you've got your 6 within the first 30, 40 seconds. All right. You're just chilling after that. Do you know what I mean? So the next thing to do is, how do I get that up to a 7 or an 8? What do I look at? Well, you don't really need to know classification for radial club hand. I'll just mention it very briefly. There's Bain and Klug, 1 to 4. 1 just means the radius is a bit short. 2 means the distal physis is absent. 3 means the proximal physis and distal physis are absent. And 4 means it's completely absent. So that's an arm sitting at right angles, okay? But don't worry too much about that. You get x-rays, you get a renal ultrasound, you get an echo, multidisciplinary assessment. The 7 will be talking about what is your management plan. And the management plan, guys, is going to be, first of all, go back to what I said before, the setting. It should be an MDT, congenital hand specialist. You want to intervene early. Ideally, you want to centralize within the first year. You want to polysize by 2 years, okay? And your goal is to get a central position of the hand over the ulna. And the challenges are that it's got a high level of recurrence. So what we say is, first thing you want to do is get it straight, serial casting and physio. Once it's straight, centralize within a year, polysize within 2 years. Okay, and that is the algorithm to get a 7. So the 6 is describe the deformity, exclude any associated anomalies. The 7 is management, and that's your algorithm. And then the 8 is how you do the centralization. I've given you 4 points here, all right? So incision, it's what we call a bilobed incision, 2 lobes, okay? Releases, release on the radial side, tendon transfers, radial to ulnar extensors, and then a single transcarpal wire. Okay. Every student who came on my Blitz course, we did this. I gave them that answer. It came up in the recent exam. They all scored an 8 on it. All right. There is no other way this question is going to go. So if this comes up now in your exam, the first thing you're going to do is you're going to give the examiner some sweet and salt popcorn. You're going to mark an 8 on their sheet, and you're just going to tell them, sit back, record on your iPhone for 5 minutes and just enjoy yourself. It's the most easiest station you're going to get. Okay, because you know exactly what the mark scheme is. All right, it's a real chilling station. So don't ever fear radial club hand ever again. Okay, good. The next thing is 2 fingers which are joined together. What's this called, guys? Syndactyly. Okay, and if you were going to classify it according to Swanson's, what would you say? Theory of differentiation. Very good, Owen. Good. Okay, right. So what happens here? This is actually probably one of the most common congenital upper limb abnormalities. Okay, it's a lot more common than radial club hand. Okay, it's more common in males, and it's because of a failure of apoptosis to separate the digits. Many of them have a positive family history, guys, and it's usually autosomal dominant. All right. The main thing I want to know on examination is this syndromic? Is it a complete syndactyly or incomplete? So they're joined all the way up, and also is it simple? Does it just involve the skin, or is it complex as well? Does it involve the bones too? That's what I kind of want to know. I want to exclude associated syndromes. And here I've actually contradicted myself because these are 3 specific ones for syndactyly. But there's Apert, there's Poland, and there's acrosyndactyly. This won't come up in part 2, guys. This will come up in part 1. Okay. So Apert is just basically where you've got an FGFR2 mutation. You get a bilateral complex syndactyly, so it involves the bones, and also a flattened skull and quite broad forehead. So you get this thing called acrocephaly, and that's because the sutures of the skull close prematurely. Okay. Poland is where you get unilateral chest wall hypoplasia. Okay. So it's basically because the sternocostal head of pec major is absent. And then acrosyndactyly is a 3rd one. And that's basically where the digits fuse distally, okay? And the proximal digit has got fenestrations. Okay, so those are the 3 abnormalities to exclude. As we said, classification, it can be simple, just involving the soft tissues. It can be complex, involving the bones, or it can be complicated, where you've got accessory phalanges or abnormal bones involved in fusion. Simple, complex, complicated. How do you manage it? Quite easy. You separate the joint digits, okay? And your goal is to try and increase their width span. When do you do it? Neonates, you basically do acrosyndactyly, 1 year if it's syndactyly, okay? And your challenge is you get this thing called web creep. That's the most common complication. It can be about 60%. So they might ask that in part 1. They won't ask it in part 2, okay? So web creep is where you get early creep, where you get necrosis of the dorsal quadrilateral flap. And basically, you can treat that by a full thickness skin graft, basically. Or late creep is basically where you get discrepancy in growth between the scar or skin graft and surrounding tissue during the growth spurts. Early creep, late creep, okay? What are the principles of surgery? Is basically you want to avoid separating the digit on 2 sides. So if there's multiple digits involved, they say do it in 2 risks. In 2 stages, because you want to avoid vascular compromise. So basically, border digits first, you do less than 6 months, middle digits you do a bit later, and try and use zigzag flapping. Okay? Good. What's this called, guys? What's this thing? Polydactyly, isn't it? Yeah? Polydactyly, okay? So there's different types. Preaxial involves the thumb, postaxial involves the little finger, central is the set digits between, okay? Thumb duplication is the one that most commonly comes up in the exam, and you want to check which of the thumbs is the most dominant one, because you want to retain that. Compare it with the other side, okay? Wassel is the classification, which they occasionally ask, all right? But again, it's more a part 1 than a part 2 question. So what it has, bifid or duplicated, bifid or duplicated, bifid or duplicated. So 1 and 2 is the distal phalanx, 3 and 4 is the proximal phalanx, 5 and 6 is the metacarpal, and 7 is triphalangism, so 3 phalanges, okay? Your goal is that you want one stable thumb, which is stable, mobile, strong. And it should be about 80% of the size of the contralateral side, and it's also cosmetic. And that can be quite challenging to achieve a normal looking thumb, basically, and there may be deviation. Okay, so the principle of surgery is that you usually preserve the bigger of the duplications, and it's usually the ulnar side. You want to try and keep or reconstruct their medial collaterals because you want to make some sort of pinch, okay? And then you want to free any adjoining ligaments or tendons, okay? And I won't go through the different types. That's far too complex for FRCS, okay? Postaxial is just little finger duplication, okay? Type A is complex, more common in Africans. Type B is simple, common everywhere, okay? The A type, you usually do a type 2 reconstruction, which I mentioned in the previous page. Type B, you amputate, okay? But I think the duplication of the thumb is the one that I've seen asked with Wassel. That's the more common one, okay? The final one, patient's got a little thumb. What's that called? Hypoplastic thumb. So this is the most common other one after a radial club hand that comes in the exam. And here, there's 3 things you want to comment on. So you want to say the patient's got a small or hypoplastic thumb. You want to say that there's an adduction contracture, tight web space. And you want to say that there's hypoplasia of the thenar eminence. 3 points, economy of phrase, okay? So what happens here is it's very similar to radial club hand. It's a failure of formation, sonic hedgehog gene, okay? Triple assessment, again, assess the child clinically, okay? Assess them radiologically, okay? And assess them by, well, I can't think of the word, radiologically and also biochemically, okay? So I'd want to check for bloods, full blood count, UNEs, renal ultrasound, cardiac ultrasound, and x-rays, okay? And their syndromes are pretty much the same except Barter. So just treat it like a radial club hand, okay? So the classification here is Blount, all right? The one I want you guys to remember is CMCJ stability is the key for your management. So 3B is where you lose your CMCJ, and that's where you're going from a reconstruction to a salvage route. That is all you need to know for this, guys. Don't learn any of the other things in detail. 3B is where you have a deficient CMCJ. So what happens first? Well, think of what your problems are. So a type 1 is just a slightly smaller thumb. A type 2 is basically where the MCP joint might be deficient, or they may have a bit of collateral instability, okay? Type 3 is where the CMC joint becomes absent. 3B, sorry. Yeah. And then 4 basically means you've just got a rudimentary skin card. 5, it's gone. So 3B, 4, and 5 is salvage. You can't reconstruct it anymore. You have to do a polycization. 1, you don't do anything because it's just a bit smaller. 2 to 3A is where you've basically got instability of the MCP joint because of the ulnar collateral ligament, and you've got an adduction contracture, and you've got wasting of the hypothene remnants. Also wasting of the thin remnants, sorry. So what do? You just treat the problems. Reconstruction, easy. So my first problem is I've got ulnar collateral ligament instability. So I'm going to plicate the ulnar collateral ligament. My next problem is I've got a tight first web space. So I'm going to do a first web space release to give me a handspine. And my third problem is I've basically got wasting of my thenar eminence, not hypothenar, sorry, I should have said thenar eminence wasting. So I'm just going to do an opponent's plasty. Does that make sense? So you're just treating the problems. Whereas a 3B to a 5 is salvage. You're going to amputate whatever's left and polysize it. Use the index finger. So just to give you the scoring system here, a 6 is to describe the deformity. Hypoplasia of the thin remnants, loss of first web space, small thumb. I want to exclude a associated syndromes. That gets you the 6. The 7 is to talk about your management plan. 1, you do nothing. 2 to 3A, reconstruct. 3A to 5, polysize. And then at 8 is to talk about the steps of a polycization. All right, which are these steps? Number 1, make an incision. Okay. Number 2, mobilize the index finger because you're going to transfer that. 3, shorten, rotate, and place the index finger. And then 4, rebalance the tendons and muscles. If you notice the language I'm using, guys, it's very generic. I'm not going into any specifics because I don't want my Viva to turn into a tell me in detail about polycization. You don't need to. That's not what they're testing you as a day one consultant. You just need to know the generic steps. And I promise you, nobody will give an answer like that in the exam who's not been through my course. Nobody. Because that is the marking scheme to get an 8 on hypoplasia of the thumb. Okay, so if you get those questions, you should smash that out of the park now. Easy, yeah? Good. Done. Right. Any quick questions? Because I want to get onto the Vivas as well, guys. So any things that you guys want to ask at all? No? Hitesh, anything that you guys want to ask over there?
Yeah, Rishi, that's fine. No.
It's okay, yeah. And as I said, guys, I've got the full recording. I've done a proper 1-hour lecture on this, which is on Hitesh's website as well, on orthopedic principles. So please just go back through that as well. But those are some of the key points that I wanted you guys to remember. Start generic and then go specific.
I think, guys, let's have a working sort of coffee break where we can start off with the Viva as few of you guys grab your coffee. So,
okay, good. Yeah, so what I think would be nice to do is...
Do we have a break for 5 minutes or something?
Yeah, let's have a break for 5 minutes.
Okay, I'll run a few of Rishi's videos then.
Yeah. Oncology. In this video, I'm going to give you a generic approach for tackling any oncological question in the orthopedic Viva. I'm not going to focus on specifics of tumours, which will come in the adult path section. So if you get given a radiograph with a suspected lesion in the FRCS examination, this is how you tackle it. There's 5 main points. Firstly, location. Look at which bone is involved, femur, tibia, etc. Which part of the bone? Is it physis, epiphysis, diaphysis, metaphysis, or more than one part? And how much is involved, such as Is it concentric or eccentric? So that's location. Secondly, describe the nature of the lesion itself. Is it well demarcated, like a geographical island which you can draw around? That's called a narrow zone of transition, and it means that the lesion is less aggressive because bone has had time to form a reaction around it. Or is it one where you can hardly see the outline? It's very blurry, it's poorly defined, with a wide zone of transition, suggesting a more aggressive lesion. Note, use the word aggressive in the exam, not benign or malignant, since you require a tissue diagnosis for that. Next, look at the matrix that the tumor is producing. Is it osteoid, so it looks like bone formation? Is it chondroid? Does it look like cartilage, which is often described as popcorn calcification? Does it look like somebody's thumbprint in the screen, fibrous or ground glass? Or does it just look see-through and lytic? Next, I want you to describe what the tumor is doing to the bone and what the bone is doing to the tumor. Then I want you to describe any periosteal reactions. When you have a very aggressive tumor and it tries to burrow through the cortex, the body tries to stop the tumor from getting out, and that's known as a Codman's triangle. The periosteum gets fixed but elevates off. You can also get sunray spiculation, which is new bone formation. Finally, you might get a soft tissue reaction. So those are the 5 areas: location, outline, type of matrix, and what the bone is doing to the tumor and what the tumor is doing to the bone, periosteal reaction, and soft tissue reaction. Now, once I was given that, I would then say I would discuss this with my regional bone tumor center, and the examiner will say, let's say you are the bone tumor center. So your principles are to gain a diagnosis via triple assessment, and that includes clinical assessment, history and examination, radiological assessment, and finally a tissue diagnosis. And all 3 of those will help you to gain the diagnosis. Clinical assessment. This includes taking a detailed and pertinent history, asking about risk factors for tumor, asking about constitutional symptoms such as weight loss, asking about a family history of malignancy, asking about the presence of any primary tumors which may metastasize to bone, such as breast, prostate, thyroid, renal, or lung, and also any symptoms which may be associated with those conditions. You also want to find out about red flag symptoms such as night pain. On examination, you'd look for any swelling, or you may examine their chest and abdomen as well. You then do appropriate imaging. So this would include a radiograph of the entire limb and also an MRI scan looking for any skip lesions. That's local staging. You then want to look at distant staging by doing a CT chest, abdo, and pelvis. Finally, you want to gain a tissue diagnosis, and this is done via a biopsy, which could be done by a Jamshidi needle or a true cut biopsy. And it's important to know about the principles of biopsy. The principles of biopsy state that the biopsy should be done at the same center and the same surgeon who's going to do the definitive treatment. They should also be single compartment biopsies. Ideally, there should be meticulous hemostasis and care of the neurovascular structures. Any drains should be excised through the same tract that you're going to do the definitive surgery, and you should always try and biopsy the periphery of the lesion because you get necrosis in the center of the tumor, so you might miss cells. It's important to understand about the behavior of a tumor as well when considering excision of the tumor. A tumor has a necrotic center, and then around the tumor you have a reactive zone, which is the body's reaction to the tumor. So you have 4 different ways in which the tumor can be taken out. Intralesional would not be used for a malignant tumor, as you're only taking out part of the lesion. Marginal takes out the tumor plus a small amount of the reactive zone, but essentially leaves the reactive zone intact. So for malignancy, you're likely to have recurrence. A wide local excision takes out the tumor plus the reactive zone, whereas radical means taking out an entire compartment, which can lead to a lot of morbidity. A triple assessment consists of 3 components in summary: a clinical assessment, history and examination, radiological assessment, and a tissue diagnosis. And that will not only give you the diagnosis, but also help to stage and give the prognosis of the disease as well. And the staging system we commonly use is the Enneking staging system, which looks at 3 parameters. The grade of the lesion, which is G1, low grade, or G2, high grade. The local extent of the lesion and site, which can be divided up into intracompartmental, T1, or extracompartmental, T2. And if there are metastases, distant spread, which is either M0, no mets, or M1, which are metastases. And in terms of the staging system, we divide patients up into 1 and 2. 1 is if they have low-grade lesions, 2 is if they're high-grade. These are then further subdivided into A or B, depending if they're intracompartmental, in which case they'd be 1A or 2A, or if they are extracompartmental, in which case they'd be 1B or 2B. Finally, if they have any metastases, they go straight to stage 3. So you've now got your diagnosis, you've got your prognosis, you've involved the oncologists, the bone tumor center, the radiologists, and multidisciplinary management. What are you going to do? Well, your priorities or goals of treatment are as follows. You want to save life, save limb, and preserve function. And this can be subclassified into one of 2 main areas, either reconstruction or salvage. Reconstruction might be that you use some sort of endoprosthetic replacement, whereas salvage is something like an amputation. And you have to decide, look, if I've taken the disease away, have I got a functioning limb in terms of skeletal stability, muscles, or neurovascular status? If you haven't, then you're probably going down the limb salvage route. And then obviously you have other modes of treatment such as chemotherapy or radiotherapy depending upon the type of tumor. So for osteosarcomas, you use neoadjuvant chemotherapy before surgery. You then take out the tumor and you measure the necrosis rate, which you want to be at least 90%. And then you do adjuvant chemotherapy. Whereas for something like chondrosarcoma, it doesn't respond well to chemotherapy or radiotherapy. So you want to do surgery for that. X-rays. What is it? X-rays are high-frequency energy from the electromagnetic spectrum. How is it produced? Well, there's 3 key phrases that you need to remember for the exam. Thermionic emission, breaking radiation, and attenuation. So what do I mean by that? Thermionic emission, you take a piece of metal which is made up of tungsten, known as a cathode, and you heat it in a vacuum to 2,200 degrees. This generates electrons. So what happens to these electrons? They fire their way down a tunnel and strike another piece of metal made out of tungsten, known as the anode. They're slowed down and they generate energy, hence the phrase breaking radiation. Now this is a very energy inefficient process with 99% converted to heat and only 1% converted to X-rays, and that's why the anode is rotating, because if it was struck full on, it would melt. Finally, what happens to those X-rays that are generated? Well, they pass through body tissues and they can be either absorbed, reflected, or transmitted, a process known as attenuation. And sitting behind the patient, there's a plate made of phosphor crystals, which if exposed to X-rays, stain black. So the more energy that gets through, the darker it will appear on X-ray. So that's why tissues such as water or air, which let through lots of X-rays, are known as low beam attenuation, whereas tissues with a very high calcium content, such as bone, let through very little X-rays. Therefore, they appear white on radiographs, and that's known as high beam attenuation. So what are X-rays used for? X-rays are very good for looking at simple bone anatomy. So they're good for diagnosing osteoarthritis, fractures, or deformity. The advantages of them are they're cheap and easily available. But the disadvantage is that they're a form of ionizing radiation and so do require necessary precautions. So what are the precautions? The mnemonic to remember for the exam is TDS, which stands for time, distance, shielding. And this means that you reduce the amount of time that you expose both yourself and the patient to X-rays, you increase the distance between yourself and the source of the X-rays, and you also wear some type of lead shield to cover both your reproductive organs and also your thyroid organs as well.
Rishi, are we starting? Your mic needs to be on actually. Saurabh, what's
Sorry.
the plan?
Oh, can you hear now, Hitesh?
Yes.
Oh, fantastic. So the plan now, we're just taking a quick course photo because a couple of the delegates have to leave, and then we're going to do like a hot seat type thing.
Great.
Fantastic.
I'll run another video of yours in the meantime.
Fantastic.
You can stay in the photo because that's going to be the background as well. You can see the.
I can be part of the photo, is it?
Yeah.
Yes, you can.
You're the mastermind.
The camera's in the chair.
Remotely.
Yeah, man, of course.
Okay, guys. Come.
We got yeah. Do we need to do like a football team thing or bend down, or is that?
We can bend eye.
Like a football team. We're old as too. Come back. Does actually work? Are you trolling us?
You're out anyway.
Cover.
Yeah, except Kiran. Should we get one? Sorry,
Kiran, come on. Kiran, you come next to me here. Come.
Okay.
Come close, like.
Hey, boss is going to come in as well.
Of course. Yeah, you're on the border.
Thank you. Beautiful. Right, so Aarti, you are number one, the most important person.
Thank you.
So, seriously though, well done. So,
Starting actually, who's grilling? Hitesh is grilling. No.
I think we are both grilling.
No, we are both
Hitesh will grill as well.
So where are the slides to grill now?
Okay.
बहुत सारे presentation I think I've got lots of.
Have we got any slides to grill at all, or?
We can use amongst these, but we'll have to email it to us, isn't it? This laptop.
Okay, don't worry, it's fine.
Or I can do it from my. No, but they have to see us.
Have you got the list of lectures here?
Do we have the lectures?
FRCS 100 risk. Good. Okay,
good.
That's fine. I'll just pick up a couple of. Let's pick up a couple of cases from here. Good.
Correct.
All right.
Rishi, can you share the screen?
Oh yeah, sorry, boss. Yeah. Let me just do that for you. Sorry, Hitesh, I'm just working out how to.
No problem.
There it is. Share the screen here. Good. Excellent. Right. So, guys, you've seen these cases, all of them today. There's no surprises. So just keep relaxed and.
And Rishi, full screen, please. Yeah.
Yeah, you can see that. Okay,
Yes.
so let me find some cases. All right. So this is a 55-year-old laborer who comes to see you complaining of pain in his hand. Tell me what you see.
So this is a clinical picture of the left hand, and I see the thumb in an adducted position. There is hyperextension in the MCP joints. The thumb span is reduced. There is thenar atrophy or wasting of thenar muscles, and all this I would suspect CMC joint arthritis.
Okay, so very good. How would you? You said that the MCP joint is hyperextended. Why is it in that position?
Because there is adduction of the thumb and the thumb span is reduced. To increase the grip, they try to hyperextend it so that they have more thumb space.
Okay.
So it's a compensatory mechanism.
Very good. Okay, so how would you assess this patient?
I would assess the functions of the hand, which involves 3 precision and 2 core grips, like the power grip and the hook grip. And for precisions, I would ask him to take a pen, then pick up a coin, and third was for tripod.
Okay, so we didn't ask specifically how you do a functional assessment, but is there anything else that you look for in examination?
I would do a detailed examination of the hand, which would involve a neurovascular examination. Then I would look for the functions of the tendons, if everything is.
Okay, why is it relevant to do functions of the tendons?
If I was planning for further treatment, for example, if I want to do a fusion, I would want to know the function of the other joints, IP joints.
Okay.
So I can plan my treatment.
So you're not really looking for tendon function, you're looking for movement or pain at the other joints, aren't you? Okay, anything else that you're looking for in examination? Okay. How would you know that this is CMC joint pain? It's not coming from anywhere else. How could you tell that?
So I'll do a grind test.
Okay, talk to me how you do a grind test.
So I would fix the patient's, I would give an axial pressure and do a circumduction. And if he has pain, that would indicate that it is only at the CMC joint.
Okay, anything else?
I would also examine the wrist and I would examine the MCP joint and see if there is any pain.
What are you examining at the wrist?
Wrist movements, see if there's any pain.
Okay. How is that relevant to your management?
So I would know if the pain is only at the if it is an isolated pain at the CMC joint, or if the other joints are also involved. For example, if it's a rheumatoid hand, or I would know about the other joints involved.
Okay, all right. Okay, how are you going to treat this patient?
I would do a radiograph of the hand.
What would you request?
I would ask for a Roland's view.
So it's called an AP Roberts view.
Roberts view.
Okay. Do you know how you do a Roberts view?
Ask the patient to in mid-prone position. Ask him to abduct the thumb and take it to AP.
So you take the film and you put the thumb pointing downwards like that. So that's how you do a Roberts view. Okay. Okay, good. So that's what the X-rays show. Tell me what you're going to do.
So there is decreased joint space in the CMC. There is subluxation of the metacarpal, MCP. So, and there are osteophytes. So, the PIP joint looks fairly okay. So, in this patient, he's a manual laborer. So, I would want to fuse this joint.
Okay.
Sorry, I would plan for a trapeziectomy.
Okay. All right. I'm going to stop you there. That time. So it's hard, isn't it? It's not easy at all. So even when you've watched a lecture on it recently. So actually, I thought you started very well. You said about words like shouldering of the base of the thumb. You talked about MCP joint hyperextension. And you mentioned about thenar wasting. And you said it's probably CMCG arthritis. And then you dug yourself a hole. So when I said about how you'd assess the patient, you can say, look, I would take a history about dominance, occupation, level of activity, and I would try and elicit where the pain is. Is it at the base of the thumb, or is it on something like dart throwers motion? If you throw words out there, just generic words like I would check neurovascular status, I would check the tendons, I would check the wrist, you're going to be asked about them. Okay, so the key thing with the short cases, guys, is about being specific. All right, so with a CMCG arthritis, I want to know what's the MCP joint doing. I want to know what's the STT joint doing. I want to know what carpal tunnel is, if there's carpal tunnel present, and I want to know about grind test. And that's pretty much it on examination. Okay. As you said, AP Roberts and lateral view, and then you come on to management plan. And you said he's a manual laborer. So first you said, I'll do fusion. And then you lost confidence in yourself. You said he's a manual laborer, I'll do a trapeziectomy. Okay, so you're quite right. Start off with injection, start off with conservative, but if it fails, probably a fusion is going to be the best treatment for him. And then for a 7, I would have asked you to talk me through the steps of a fusion. And then for an 8, I probably would have asked you about complications. Okay, so that's kind of where we were going with that. All right, but well done. That was a really good start. Okay, excellent.
Next person want to come in? Come. Sorry, do you want to ask the next question?
Sure.
So I will give you a picture and you can just sit.
Can I do my picture?
Yeah. Do you want to do your picture? Go on.
Because
Go on.
you know what I mean. Hand. So what did I do? Hand trauma, isn't it? Oh, let's pick the toughest case. Nothing is tough, promise. Okay. Do I have to say ensure here? Yes. Right. Okay. So as you can see, 26, you know the diagnosis, fine, doesn't matter. So he fell, he had a valgus hyperextension injury, axial load injury. So these are the radiographs and the CT scan. Can you describe them to me?
So these are the EP and lateral radiograph of a skeletally mature patient showing comminuted fracture of the radial head. I can also see some fragments on the medial side. I am not able to assess whether it's true AP or true lateral view, so I would need further investigation in the form of CT scan.
Okay. I've got only one image to give it to you. What do you see there?
So in this view of the CT scan, I can see there is a fracture of the radial head, which is comminuted in nature. I can't see the outline of coronoid, so my concern in this case would be it's a fracture of radial head, which is comminuted with associated probably coronoid fracture. I think this terrible triad injury.
Okay. What is a terrible triad injury?
So terrible triad is a triad with a combination of radial head fracture, coronoid fracture, and dislocation of the elbow.
Okay, good, very good. So coronoid, you can have some reasonable idea. You're totally right. Unless I show you the proper views, you can't comment. Yes, so there may be a flake off, who knows, but fair enough. I'll give it to you. The coronoid is intact, maybe a teeny tiny flake. Okay, so what are the principles of managing this injury?
So I would divide my principles of management in emergency management in A&E and then definitive management. So my principle in management in A&E would take detailed history with mechanism of injury. I believe this is a high velocity injury. I would ask the profession and which is it the prominent site which is injured, any medical comorbidity, and then I will examine the patient, in particularly in this case, rule out any open wound, open injury, distal neurovascular, and compartment.
Okay, so I give it to you. It's a closed injury. Nerves and vessels, everything is fine. It's fit and healthy. Dominant arm, non-dominant doesn't matter because it needs to be fixed, and we'll do a good job for him. What are the principles of fixation for this fracture?
So principles of fixation is if we can fix the radial head fracture. So basically, we have to see what structures are injured in this particular scenario, and we have to repair. I believe there is a fracture of radial head which is comminuted. So we can try to fix it if possible. Otherwise, we have to be ready with the radial head implant. If there is coronoid fracture, I have to fix this anatomically. If there is capsular tear, we have to repair through drill holes and capsular repair.
The capsule, good. What other structures can be potentially injured?
And
what is injured? What can be potentially injured?
Then the next, after fixing this, I will assess the lateral ulnar collateral ligament. So
you think it's injured or not?
It will be injured.
Okay, good. What last structure is left?
Then I will assess at the end of procedure MCL.
Do you think it is injured in this case or not? Hard to say. I do not know, sir.
I will check at the end of principle.
Exactly. You can check, but you do not know looking at these X-rays. Yeah? Terrible tried, you've told me. Fourth, you do not know. Okay, good. So, what approach will you use?
So for terrible triad, I would use a midline approach, which is extensive, and then I can divide my incision depending on what structures are injured.
Okay.
So in this particular scenario, I think the coronoid fractures were small, so I can go with the lateral approach. I will use a Caucus approach, which is the interval between ECU and Anconius. Fine. Structure at risk, and this will be posterior interosseous nerve. I will go scan in an considered appropriate marked patient under tourniquet, supine position, arm on the sideboard. I will go for the lateral approach. My interval between ECU and Conius. And then I will go through skin, fat, fascia, and then interval between ECU and Conius. And then I would protect my radial head, in particular PIN in this case, posterior interosseous nerve. I can use a gauze or some kind of to prevent it.
Okay.
And then I will try to fix it if possible. If not, then I would replace it.
Okay. So what is the order of your fixation now? So if you replace it, so do you want to do your radial head first?
No,
you can if you want to. It's up to you.
If it's a small fragment,
so I give it to you. It can't be fixed. You have to replace it. Okay. So what are you doing now?
So I would fix the coronoid fracture first.
How will you fix it?
If it's a small, then I will use the capsular
flake. It's a flake. I've given it to you.
I will use capsular repair.
How will you do that?
I will drill through the ulna, small incision, and then I will use I forgot the name, suture.
Just describe it.
The lasso technique, which I will use, and then I will pull through suture.
Okay, fine. So you've done your capsule. What will you do next?
Then I would not tie it at that time. I would.
Why are you not tying it?
Because I would need extension of the elbow.
You can extend. Can I not extend in my intact ulnohumeral joint?
So if I tie it, I would not be able to replace the radial head.
Why
it
will
come in our way?
Replace it?
It might come in our way.
How will it come in your way? Moment you tie it, your ulnohumeral joint is reduced. You have a stable elbow is better.
I would not be able to see the radial capitular joint properly.
So what's the term? You will not be able to
access,
sublux your radius properly, isn't it? Okay, good, fine. So now you replace. You've done your radial head replacement. Then
there are two things important to check. I would check whether I have not overstuffing or understuffing the joint, and also
you've got it right. You've not overstuffed it. Next.
Then I will repair the LUCL with Mitek suture.
Okay, good. So you've done that. Next.
Then I will check the medial collateral ligament stability.
How do you check it?
So I will check in around 20-degree of flexion of the elbow whether it's opening.
What is opening?
Opening on the medial side. So if I give a valgus impact, it should not open.
If you give valgus, then what?
If it's opening, then I think either it's not repaired.
So if MCL was gone, you give a valgus stress, it'll open. Then will you repair it?
I will also check with the palm sun on the X-ray, and I will check the range of movement from flexion to full extension.
For exam purposes, posterior sag you will do. Because if you have a simple elbow dislocation, do you fix those? Barring 2 to 5%, you don't. So if you do varus valgus in those elbows, they will open. Both ligaments are gone. We know that, but they all heal up because as you reduce ligaments, slap back. So don't do varus valgus. You still can, but that's a bit higher, like technical, you can't defend it. Say you do posterior sag. If it drops, last 30 degrees doesn't count. If it drops beyond 30, I'll repair MCL. Yeah, they will not ask you about X. Did well.
I think initial assessment was fine. In management, I could have been a bit more slick.
I didn't do very good, but maybe because you've heard the lecture even now. Plus, you have the knowledge. I'm not taking the credit away from you. But it's just the sequence. You put it all very well. You're not showing them how to do surgery. Radial head, sir, is comminuted. I'll try. If I can't fix, I'll replace. That's it. What can they say? They can't give you a knife to say, show me. You know, start with capsule first. Suture lasso. You know how to do it. Then radial head. Then lateral ulnar collateral ligament. Then sag. Job done. Okay, well done. Rishi? Carry on, okay. So how do I don't mind carrying. How do I end the show, guys? Anybody knows?
How do you want to do that?
Just to pick up okay, I can pick this slide, doesn't matter. Let me grill them. It's fine.
All right.
Is it okay, Rishi?
Yeah.
Okay. Who wants to come now?
Saurabh, which is the case that you're putting up?
The incarcerated medial epicondyle.
Okay, no, because it's showing the shaft of humerus on this one.
Oh, so my thing is not projecting to you, I suppose.
No.
Arjun. Oh, something. I'm sorry, Hitesh.
Is there a delay, Hitesh?
No. Screen sharing is paused.
Oh, we're not.
Oh, okay. You pause the sharing. Okay, so just. Resume share. Resume share. Yeah, that's it now. Now do it.
Okay, it should come up now.
Hand trauma. Hand trauma.
Yeah. So let me go back. Okay, fine. Yeah. Now, can you see us now, Hitesh?
Yeah,
Okay, sorry about
19-year-old male, right? Diagnosis.
Yes, yes, yes. Sorry, Hitesh. Yes, perfect, perfect. So, yes, go for it. What do you see on these X-rays?
Tibial lateral radiograph of an adult skeleton of the left elbow. And most obvious picture that I can see is elbow dislocation with incarcerated fragment in the upper femoral articulation. Most likely it's coming from the medial condyle. I will manage this patient as TLS. I will exclude any other.
If you were to miss it, what will happen?
Why?
If someone was to miss it, it commonly gets missed. What will happen? What's the worry here?
You're missing the dislocation.
You're missing the dislocation and the income. So what happens is quite barn door. I put an X-ray like that. Sometimes you're not careful, you will not pick up the dislocation, even with the epicondyle sitting in the elbow joint.
Yeah. So this is the MCL. So there will be a valgus instability. So this is the
That can be dealt. And what is another big worry? Yes, they will lose the chondral cartilage because you can fish out the epicondyle and you can still repair it, but it's the chondral loss. Because chondral loss will happen within a matter of days if the child is moving the elbow, isn't it? Okay, good. So what approach will you use for this?
So I will bear in mind, I'll start with reducing that in the A&E, bearing in mind that this fragment may be incarcerated. So I'll supinate and dorsiflex the wrist to try to close the.
You can't reduce it close. Then what will you do?
So I will go through medial approach in order to take off the fragment. And
good. How will you base your incision? Normally, when you put your incision for your ulnar nerve decompression for cubital tunnels,
yes.
What is your landmark?
So my landmark is the olecranon and the medial epicondyle.
Okay, so where is the epicondyle here in this case?
So the epicondyle here.
There's no landmark.
So
how will you put your incision?
I will go through. I use probably the.
So you have to make a guess. It's not easy.
You have to follow the bruises actually.
You follow what?
The bruises that's from the fracture of the.
Means you have to estimate it. It's not there for you to put an incision. Remember that. So incisions can horribly go wrong. Unless you are aware of that fact. What you can do is your lateral side is there, epicondyle, your olecranon is there. You can make an isosceles triangle that way.
Yeah.
And assume medial epicondyle should have been here and then base your incision. It's not easy. They can go wrong. Okay, good. Fine. Follow bruises or whichever way. Yeah. Then what will you do? What next?
So I will do an open reduction. I will go through the capsule. So I will probably follow surgical plan. If there is any disruption of the soft tissue there, I will follow the site of the damaged tissue. Otherwise,
before you go into the capsule and into the epicondyle, you have to see the nerve.
So there will be, I will look for the ulnar nerve.
Yes. Will it be easy for you to find it?
No, because it's usually behind the medial epicondyle and has been already disrupted. So I will bear into consideration.
Where will you start looking for the nerve then?
I will follow it from probably the medial intermuscular septum and then go down. So proximally to distal.
Okay. Where is ulnar nerve easiest to find? Let's say you're doing a nerve decompression on knee. Where? You're right. Good. Medial triceps. Yeah. Where? 2 to 3 centimeters proximal to epicondyle. So that's your best friend. That's where you will find it. And you'll very slowly dissect it. Once nerve is under control, then it's not that difficult. Yeah.
And then I will produce it, check the stability. Most likely to be, there will be insufficiency of the ligaments on the medial side. I will fix the medial epicondyle with a compression screw. And then I will look for the stability via screening under X-ray control.
Once you put wires or screws, it will be fine. You'll be fine. The question is ulnar nerve incisions and how you get into the elbow joint. Where are the flexors? Once you've done the ulnar nerve, where are the flexors? Because you need to get into the joint to fish it out.
Yes.
So you may have to go through your flexors and capsule. Where are the flexors? Very good. So flexors are sitting in the with the epicondyle in the joint. So you should know where anatomy is so that you are not flustered when the joint is open. Yeah, good, very good, excellent, well done.
Have we done the markings?
All pass.
All pass. Okay.
5, 6, 7, 8. Depending on how much you pay me, sir. Now we're talking business. 7. Okay, who wants to do this? We'll discuss all these. You know it's a capitulum fracture, right? Give me the classification, Milindu. You thought it'll be easy?
It's going to be undisplaced and displaced with the articular reduction, articular displacement.
If you
less than 2 millimeters.
No. You have capitulum, then you have an osteochondral capitulum, then you have a comminuted capitulum, and then capitulum goes into trochlea. Why am I asking you this classification?
Depending on the time stage of this classification, the treatment will differ.
Correct. How will it differ?
It's osteochondral lesion.
So if it's this fracture, the one I'm showing you is type 1, you can fix it. It's a big chunk. And then if it's 2, osteochondral, then it's not going to take screws. It's a sliver. So if it's very thin, what will you do? Throw it in the bin. But if it's not that thin and not that thick, then suture fixation. Sutures will hold on to it, yeah? If it's comminuted, you deal with it. Whatever you can fix or not fix. And if it's gone into trochlea, you have to fix the capitulum and the trochlea. So either you do a extended lateral approach or you have to combine it with a medial approach to see the trochlea. So that's where this classification has a relevance. It affects your management, yeah? Okay, good. So for this, what approach will you do?
Reduction and fixation.
Good.
And my approach would be a lateral approach.
Good. Describe the approach to me.
So it would be between the Anconius and the EDC.
And the Anconius and the
EDC.
EDC. How many muscles are there between Anconius and EDC?
Sorry,
So in the heat of exam, if examiner is not nice, which I never am, so coccus interval is what? Anconius and ECU. Yes. And yeah. So are you doing a coccus approach? Okay, fine.
On my initial approach, I will skin incision and then I see the mobile board and can cut the fascia in between the EDU and the Anconius.
ED, ECU and Anconius. Okay.
And once I open it, I need to be careful not to go distal more than 5 centimeters because of the injury to the PIN.
Okay. So your proximal extent of its incision is still which landmark?
To the ridge of lateral condyle ridge.
Lateral condyle.
The ridge of
So see, that's your epicondyle. That's your ridge. So where do you, shall I stop the incision here? Shall I keep going up?
To the level
Here,
yeah,
up to there. So it's an extended coccus approach. First of all, it's not coccus. Coccus didn't describe this. Yes, coccus approach was from epicondyle. Like I drew that Anconius muscle. So you have to be clear on that. Yes. Okay, good. So when you've gone right up, yeah, up to there, which you're absolutely right to do that, you have to do it. And distally, you have gone between Anconius and ECU, but that's more to see the radial head. I'm not keen on capitulum. So what else will you do in your approach? So will you do some dissection here also?
it's better not to do a posterior because it will have
Fine, don't do posterior. Anterior, will you do some dissection? You will have to, you won't be seeing capitulum. You'll have to lift the ECRL and brachioradialis. Okay. And once you do that, you put your ring handle spike there, only then will you see capitulum after cutting the capsule. So I want to hear that in this approach. Yeah. And then of course it's easy. You reduce it because I'm looking at you put some wires, you hold it. If it looks good, then these are cannulated wires, put some screws. Make sense? Yeah. So see, even a simple fracture, which you think, they are simple, but you have to just think in your mind the approach, the steps, and then you're fine. So you will know all of it. In the heat of exam, it becomes a bit hard, much harder. Excellent. What else can we ask you here? I think that's pretty much it. Headless screws, you bury them under cartilage, get them going in 2 weeks time.
We mentioned about the blood supply posterior, didn't we?
Yes, Milindu said he won't go because of soft tissue blood supply AVM to capitulum, isn't it?
Not just that you don't need steroids. You've got to be careful.
Collaterals.
To know the classification of the captain.
Name, was it not?
Yes. So the
Milch is not. Milch is lateral condyle. McKeever, I think it's McKeever. McKee.
Yeah. So Cocker Lawrence is where you have the just a shearing fracture. You don't normally do anything with that. One is the large osseous fragment. 4 is, so it's the 1s and 4s that you need to fix. The 3, the multifrag, you often just excise if it's causing problems, but it's mainly the 1s and 4s.
And 2, you fix a suture. Name, I think McKee and McKeever gave type 4, isn't it? Was it not McKee?
McKee modification.
McKee. Now that you ask me, I can tell you a lot more about capitulum. So these are articular surface fractures. And to make it more difficult, if you had done really well, I would have said, okay, now you assume there's a posterior combination also. So now how can you put screws from front to back when there's posterior combination? There's nothing holding it. Then you will say, sir, well, I'm not bothered. I'll further extend my approach. I can add a plate at the back to support it.
So I had an exact case like this where it was comminuted. I tried screws and they just kept collapsing through, so I had to put a plate.
Then I can further raise the stakes. Then I can say, okay, fine, now it's gone into your trochlea and there's a combination at the back there also. Then you're looking at olecranon osteotomy. But osteotomy will only give you 60% exposure of the back of humerus. And in the trochlea, if there's a lot of anterior combination, then even from olecranon osteotomy, you can't address that. You can only address the posterior combination because you can see posterior 60% with osteotomy. Then in those cases, you have to do a transolecranon approach, paraolecranon approach. Yeah. So this fracture, you can sit for 2 hours and talk about it. Then I can talk to you about if there's only one chunk here, there were 10 pieces to this articular surface, both front and back, capitulum and trochlea. Fine, you've done your paraolecranon approach, but these are all avascular fragments. There's no supply to it. They're hanging in thin air. So how will what will happen? They can die. And with paraolecranon, you have to do elbow replacement if you can't fix it. So then how AVN bone regenerates? That's what I'm trying for you to tell me. So see, AVN, dead bone is a hard, strong bone. Why should it collapse in fragments like your kind box? So I want you to now tell me how bone revascularizes. So what happens is body tries to, like your Perthes and kind box and prisers, and if blood supply comes, it revascularizes. It wants to regenerate bone. That's how your osteoclasts come. They start eating a bone and laying down new bone. So when that osteoclast is eating up my dead bone and trying to put new bone, that bone is soft. And if at that stage patient is loading the elbow, that's when collapse happens. So this X-ray, I can take you anywhere for next 2 hours. So, but idea is to understand the pathology and then you're fine.
That's a silly question.
No, there's nothing silly, sir. I don't know how to give local and carpal tunnel. You are saying silly question.
Blood supply at the back. But when you put a plate on it, is it still not
I know. I always wondered about it. Somehow, you're right. We completely skeletonize it, don't we? But blood supply comes. These ulnar collateral vessels, they come. You're right. My next question in a big meeting is the vascularity of distal humerus. I know it's radial and ulnar collateral vessels, but I want to know about this case, 10 fragments, how they revascularize exactly.
I suppose the one that I had where it kept collapsing and I had to sort of extend my approach. I had to go a little bit more posterior to get the plate. I just sort of went very, very slowly, taking as little as I needed just to get the plate on. So I didn't just like completely skin it. I just kind of was using my periosteal little, just to make sure I could see good bone to buttress. So no, what they
retain
yeah, no, sorry.
Yeah,
they just want to see that. Do you have basically what they want to do? Day one consultant to get you up to a 7 or an 8. Can you deal with the salvage scenario? So it's normally like, can you deal with some sort of complication on the table? So, for example, I'll be honest. I did a hemiarthroplasty a week ago, my Trum week. It was a lady who was rheumatoid, had cancer in the neck, very poor bone. So I said to the registrar, I'll have to do this. And I ended up cracking the GT. So I'd never done one of those before. I had to do a circulation wiring and tension band. It was absolutely fine. But that's something they could give you in the exam. They could say, right, you've got a hemi, the GT breaks, what do you do now? Or your registrar breaks the femur, what do you do now? These are things that happen. Or you're cementing, the anaesthetist says the blood pressure has dropped suddenly. They'll give you some sort of complication. They don't want to know like the big details, operative things. They want to know, can you think logically? So all you need to say, as Mr. Agarwal said, is look, my screws are not purchasing, so I probably need to buttress plate it. That's the thinking, and that's probably far enough. Yeah, but I need to be aware that the blood supply comes in posteriorly. That's enough, man. That's
Once
enough.
you've thought about it, they're happy.
They're just looking for thought process, basically. It's like if let's say we were doing the distal radius, and you found on the table, your druge kept dislocating, or maybe there was still a big dorsal chunk, and the carpus is going with it. Are you going to close up and be unsafe, or are you going to recognize, no, this is still an unstable wrist. I need to maybe dorsal plate, or I need to check my reduction if the druge is dislocating.
100%.
That's the sensible. They're not checking are you a post fellowship hand surgeon? They're just checking, will you do the sensible thing on table? Does that make sense? Will you screen the elbow in anybody you're fixing a distal radius and you're concerned about druge injury? Will you also screen the elbow? That's checking if you're safe. Does that make sense, guys? Yeah,
100%. Yeah, it's taken us about 7-8 years to reach this level. How can I expect you to know this? But it's something sensible. That's all. Nothing. It's the thought process. Yeah. And they always give you a chance to bail out. Oh, Caucus, where are you? Where is your proximal incision? So if examiners say something, listen very carefully. They're trying to get you out of hole, but they will not make so much. They only give one, like say once and then they become quiet. Always listen very carefully. They'll give you a chance. Yeah. So next, do you want to go, Rishi?
No, you're doing fantastic. I'll just keep pitching in like this.
Oh, brilliant. Fantastic. Who wants to come now?
You've got some better cases, Saurabh.
I've got no better cases.
I love it.
No better cases.
I love that. It's fantastic.
So it's very easy to stand here, as you know, Rishi. It's very hard to sit there.
These guys are doing great. So
I know, they're doing wonderful, actually. So you know that distal radius plating, lady comes at year and a half, 2 years, says, oh, all of a sudden I can't do this. I had a lot of pain here, pain here, pain here. All of a sudden pain is gone, but trade-off is I can't do this. So what do you think is going on, Kazi?
So I would suspect a flexor pollicis longus tendon rupture in that case.
Fantastic. Why do you think that happened?
Would be mainly down to technical surgical factors.
Which could have been?
The most likely scenario would have been that the plate has been is distal to the watershed line.
Yes. Or what if it was proximal to it? Could it still have caused it?
It could still cause it.
How? If it's very prominent, still can be very prominent still, or screws are prominent. Yes. Okay, good. So you got a FPL rupture. She's young. She wants her movements back. What can you offer her?
So I would offer her a tendon transfer first.
Okay, fine, good. So what are the principles of tendon transfer?
The principles of tendon transfer are the tendon that is being transferred should act in a straight line of motion.
Straight line of pull, very good.
We should try to preserve the neurovascular supply to the tendon.
That will be preserved, I hope. So that's not a principle.
One tendon should be used to replace a single function.
Okay. You lose one motor power.
You lose one motor power.
Joint where transferring should be supple.
Syllogistic, ideally.
Action. Okay, good. So where will you take this tendon now from? What are your options?
So you can take flexor digitorum superficialis of the
From which finger?
ring or the middle finger.
Okay, good. Why not index finger?
The index finger FTS.
So the reason is simple reason. Thumb needs index finger to work. So you try and not fiddle with index finger. And if something happens to index finger, then it needs middle finger to work. That's why we go for ring finger, nothing more. Yes. Okay, very good. So you'll take FDS. So FDS to your ring finger is your very good friend. Where all can you use it? Give me a few examples. So one you've told me FPL. Where else can you use it, Kazi?
You can use it in wrist drop.
Wrist drop, okay. And where are you putting it?
EDC transfer,
Okay.
FDS to EDC transfer.
And what will your EDC do for you once you've transferred it? Like what function are you trying to restore?
Trying to
You're
restore
right.
the MCP exchange.
Very good. So you can do that. Tell me more, since you're doing so well. Where else can you use it? Carpal tunnel? In a young person, you can use it. There you go. Von Jackson's, we just discussed. So see how many. So in tendon transfer work, bring out FDS to ring finger. You can practically put it anywhere. Within the heat of exam, you can't remember 20 tendons. Think of FDS, just do it. You've seen how we do it actually. You've seen it practically. Okay, let's stick to FDS. Forget about this case. Show me the FDS function to your middle finger. How will you check it? If I'm the patient.
So what I'm trying to do is that I need to hold the other fingers in extension.
Okay.
And then ask, can you bend this finger for me, please?
Why are you holding my three fingers in extension?
In order to neutralize the function of the FDP to the other fingers.
But you're checking FDS. Why are you utilizing FDP? You may be right.
Because there's a common
FDP has mass action. So unless you do this, FDP would have caused this, isn't it? Okay. So how will you check FDS to ring finger?
Yes.
So careful. Okay, good. How will you check FDS to index finger?
Index, so I can just ask the patient to.
FDS to index finger, anyone?
That's got a separate belly.
Come again?
It has got a separate belly, so just join.
It has a separate belly. Okay, fine. Enough. What separate? Separate. Kazi, well done. Pass. Come along, sir. Have a seat. FDS to index finger. So see how this Viva could have gone anywhere. And these are simple. Is it a harsh question to check FDS to my index finger? Any question that we have asked is harsh. Other than that, article survey. That was more for knowledge. So these are simple day-to-day things, isn't it?
So just ask that when you're
yeah. So checking. My FDP may be doing it because you yourself said 10, 15, 20% is a separate FDP. So how do you check? Anyone? So you ask patient to do this. What am I doing by doing this? What am I doing to my DIP?
Extension.
Hyperextension. Is FDP acting at the moment or not? Hyperextension. It's not flexing. So neutralize FDP. So if I'm flexing at VIP, it can only be FDS because FDP have taken it out of action. So simple thing.
What was that question? Sorry.
So we're just talking about tendon transfer, and I said, how do you check FDS? Because they've seen these slides. So I first entice them to come here and I change the scenario.
I don't think it's going to be easy. Very nice.
That's how we do business. Have a seat, sir.
I like this.
This is the only time I feel powerful, you know. Come tomorrow, SHO will abuse me, houseman will. I'm at their mercy from tomorrow morning, 8 o'clock. Next half an hour, however, is a different story. Okay. Oh, how come we have run out? Okay, let's talk about this. So you see on an X-ray, we know that styloid fracture, lunate injury, open fracture. I've given you a CT scan. You can see lunate in this. So you are in A&E now. What will you do for this patient? He's diabetic with an open injury.
He's diabetic, but so clinically I assess the patient, take a history from the patient, age of the patient, mechanism of injury.
77, he had a simple fall. He was walking the dog, fell down.
And assuming it's an isolated injury, I would like to clinically assess the patient. It's a closed injury, assess the neurovascular status.
Open injury, you can see the wound here and lunate is sticking out there. So you're still with him in A&E.
Yeah, I'd like to manage according to POA background guidelines. So,
okay, which are for open fracture?
Open fracture, so I'll give take out all the contamination, take a photograph of it, cover with wet gauze,
good,
and splint it, give antibiotics and tetanus prophylaxis.
Good.
Take an X-ray post-reduction to make sure.
Okay, good. So you've done all that. Now what will you do?
So I'd like to get further imaging in the form of CT scan.
You've done CT, I've given it to you.
Yeah. So
that's the unit, that's the unit.
So I'd like to discuss with the hand surgeon principles of management.
Good.
I would like to restore the articular surface, so joint, stabilize the joint surface and correct the couple instability.
Brilliant. So you are in theaters now. In terms of consenting, what will you discuss with him?
So discuss with the patient regarding the plan of the surgeon. That's fixation of the wrist radius and ulna, and also the ligament reconstruction, okay, and risk and complications involved, and doing surgery or not doing the surgery.
Okay. Will you do the surgery?
I'd like to discuss with the hand surgeon because it's a complex.
That you've done. We're just now discussing the principles. So will you do the surgery or not?
I will do the surgery. It needs a
Okay,
surgical
good. So
fixation.
we will do surgery. Now I'm the patient. I'm worried. I'm looking at the lunate sticking at me for last 12 hours. I've seen it. I'm worried. I'm saying, oh, doctor, will I lose my hand?
So we'll try, like, chances are very less because we'll try to, most of the time, once we get the restoration on the joint surface, we'll close the skin. Most of the time, it will feel better.
Other
But there's
times?
the chances of infection also. We have to keep in mind because
Are they high in my case, doctor?
there is high.
Why are they high in my case?
Because comorbidities is called diabetes. It's open injury and it's more than 12 hours.
Okay. Why should I, if I'm diabetic, why should I have high chance?
Because they have an immunocompromised status because of the diabetes.
Okay, fine. Fine. So this is the main thing that, so it's an open injury, high chance of infection, diabetic, high chance of infection, will be sticking wires. If infection goes in, it becomes a big issue. You can have infection in the bones, which can be for the whole life. Of course, we're going to be careful. We'll do a thorough washout. We'll keep you on antibiotics. We'll keep a close eye on your K-wire. It a few more times. Yes. So this is the main consenting bit, isn't it? Which you've rightly said. Okay, good. So now you are in theaters. You've done the whole list and everything. What will you do now?
So the first main thing is to debride the wound.
Good.
Take out all the
You've done a beautiful debridement. What were you worried about when you were debriding?
the neurovascular structures.
What neurovascular structure? Which vessel?
It's a radial artery.
Radial artery on the ulnar side?
Sorry, ulnar artery.
Ulnar, where is ulnar artery?
So
Tell me the relation there.
It's
You said it. It's artery followed by nerve followed by tendon. Artery is radial most. So are you worried about ulnar artery? Artery is far. Artery is somewhere there. Your wound is here. So it's the dorsal cutaneous ulnar nerve. Yeah. So you look for it because again we know neuromas can be very disabling. So in your zeal to do a thorough debridement, you may take the nerve out. Isn't it? So you look for it. Yeah, it was there sticking. I clearly remember nerve was there. You have to look for it and protect it. Good. So then you're going to reduce your lunate, isn't it? Okay. So you've got this wound. You've done a beautiful debridement. Your artery, your cutaneous nerve is fine. What will you do next?
Next is I would like to expose the.
Can I reduce it from here? It's come out after all. I could push it in.
You can reduce it and stabilize initially with the multiple care wires.
So yeah, you do an extended carpal tunnel approach because from here it's very hard to see the space of poiria. You want more space. So you go there and you reduce it. Okay, brilliant. What will you do next?
So stabilize the radial styloid with the K wires.
From the so you just stabilize it from where? From there? That's ulna. So you can stabilize it from there. Okay, fine. What will you do next?
Then stabilize the radius, scapholonate,
And where will you do it from?
From the dorsal approach.
You'll do another approach, isn't it? Okay, brilliant. Thank you very much. Did very well. 7. Who's going to come next? Who's left? Mr. Mufi. Okay, so Mufi. Okay, yeah, that's a good one actually. What do you see here?
So this is a radiograph of AB and lateral of the right forearm, include elbow and wrist. Shows
okay.
Type of Galeazzi fracture dislocation.
Good. What will you do now?
I need to examine the patient, make sure neurovascular intact.
Okay. Which nerves are you worried about, if at all?
The nerve usually at risk is ulnar nerve.
Why ulnar nerve?
I mean, there is also the cutaneous nerve. Just now we spoke about the cutaneous nerve over the under head.
Do you think any nerve in a closed injury with a fracture like this should be damaged? No. It will not stretch that much. It should not be. Yes? Okay, good. But you will do a neurovascular. 100% agree.
Yeah.
Everything's fine. Closed injury, you're on table now. What will you do?
Okay, so I will manipulate the fracture.
Close manipulation.
Then I will see the draw.
Close manipulation or open manipulation?
It's a plan obviously to open reduction fixation of the radius by a volar approach.
Okay. So you will not, yeah, okay, good.
Yeah.
So you'll do a volar approach. There's no need to manipulate. You can open and reduce it.
Yeah.
Good, very good. So you've done a volar approach. No, hang on. You've done a volar approach. Describe the approach here to me.
Is Henry approach, Henry volar approach or FCR approach. I can go by modified or Henry traditional approach, which is between the FCR and radial artery.
Good.
Right?
Very good.
And try not to devitalize the tendon, the FCR. Go on the side of it. Usually, so this is the Henley approach. Actually.
You've done that. FCR comes here, and then brachioradialis goes there with the artery.
Yeah.
What next?
Next, I protect with.
You protected it beautifully.
Yeah.
What next?
Okay, so next, reduce the fracture.
No, you can't. I don't see the bone.
At the muscle of PQ.
Are you?
It's not really. It is more.
Or is it only PQ? Let me put it this way. Is it only PQ? PQ is going to be distal to the fracture, where the fracture is.
Yes.
So which is the other muscle sitting here?
Brachioradialis.
From the styloid that you've retracted.
Yeah.
Flexor pollicis longus.
Yeah.
Where does it come from? Origin?
Flexor pollicis longus coming from the opposite side of the thumb, which is
That's insertion. Origin.
From the
Origin is here. Radius, volar surface, middle third, if you like. Yeah. So you'll have to take off FPL to put your plate. Where will you take it off from? You have three options: radial side, mid substance, ulnar border.
radial side.
I want to take it off from ulnar side. Why do you want to take it off from? Why do you want radial side? Show of hands. Radial side, ulnar side, mid substance.
Because of the nervation of the nerve coming from the radial side.
Show of hands. Okay, mid substance. Ulnar side. You stay quiet, Kiran, okay? So what did you say? Don't stay quiet. What did you say? Okay. I'll one last parting thing I'll draw here, something for you. Then you'll put a plate, isn't it? What plate are you using?
Small fragment.
Okay, drill size, screw size?
3.5 screws.
Drill?
Drill 2.5.
Okay, for cortical or locking?
It's bicortical screws.
And for locking screw, what's your drill size?
Either locking or non-locking.
For locking screw, what's your drill size?
Locking screws, it's 2.3.
What's the drill size for a locking screw for a small fragment? 2.8. Okay, what plate are you going to put what mode are you using your plate here? Bridging plate? You want absolute stability, compression plate? How will you put it?
It depends if there is fragmented.
What do you see there?
Might be a small fragment.
Might be, but you can still compress it. You aim to compress it. Absolute stability, okay? Can I just ask one last very quick? Oh, sorry. No,
I was going to ask you a quick question, right?
Yes,
So
yes.
imagine that fracture there. You're going to put your plate in compression mode, okay? If you were able to put a lag screw and then put the plate, what mode would the plate be in there? Neutralization. Okay, let's imagine you cannot lag it. Let's say it's too vertical to lag. What I want you to do is, I'll see if maybe Hitesh can't see it, but what I want you to do is I want you to tell me which screw you're going to put in first and why, and how I'm going to put it in. So that's the fracture there. What am I going to do first?
That screw should be perpendicular to the fracture.
So I'll put, let's say I'm going to put a screw here, and I'm going to put a screw here first. Okay, so you can't lug it. What are you going to do first?
No.
Okay, concentric, aren't you? It doesn't really matter which, but let's say you go concentric here, okay? Because you always start concentric first, because you need something to compress against, don't you? Is that right? Yeah? Okay, where's that one going to go?
Further away from the fracture.
So eccentric here?
Yes.
Okay.
As the screw head engages in the inclination part of the plate.
So give me the words. Why does an eccentric screw give you compression at the fracture side?
To slide the plate to the fracture.
Why? Why does it slide?
Each of the screw hole, it's on an incline.
Yeah.
It's designed as an incline, so it's.
So the buzzword to use in the exam is the screw is shaped like an inclined cylinder. It's not straight down, it's diagonal. So when you tighten the screw head, it slides and takes the plate with it. Okay, so that's a question that they may ask you. Okay, the other thing they might say is, let's imagine the same thing. This time, let's say we can't lag it, but there's an oblique fracture like that. Let's just say it's not laggable. Okay, where am I going to put the first screw, concentric screw, and why?
The one towards yourself.
This side or that side?
The one towards yourself.
Here.
Yeah.
Why?
So that to create a sort of an axilla at the fracture side.
Okay.
And then when I compress, it doesn't slip off.
Good. So you're right, yeah? So you can do another one here, aren't you? Okay. And that's because when you do that, it will slide this way and it will compress into this axilla here. So these are little variations that they can give with the Galeazzi fracture, okay? Even if, and then the next thing they might ask you in the exam is, let's say you've managed to fix it on the table, where do you think the question is going to go next? So the question will say, it still keeps dislocating. It's the same with Monteggia. There's no other way that question will go. Okay, so what are you going to do now?
So What is with your ulnar joint dislocation?
Yeah,
So,
you fix the radius and it's still dislocating on table.
So I need to, must be something interposing.
Okay.
The droge. So
what's the very first thing you will do? Assess your reduction, yeah? Okay, have you got the rotation correct? So always go back to step A. What's the easiest thing to do? Assess your rotation, assess your reduction. Assuming that's correct, what's the next thing? We think maybe something's interposed. Okay, what could be interposed?
Extensor carpi ulnaris.
Okay, what else?
Or might be TFCC.
Could be TFCC as well, yeah. Okay, so you could potentially fish that out. You could also check the position of stability, couldn't you, as well? Okay, so check prosupination, check if that reduces it as well. Would you ever put KYs across?
No.
No,
shouldn't need to. Raj, you need to know. Mid-prone, Raj is more stable. So your contact of sigmoid notch to ulnar head in mid-prone is 60%. 60, not 100. Your full supination and full pronation is only 10%. That's why I was asking you before, what's a true lateral X-ray? Because if I do a lateral X-ray in full supination, it will look as if it's coming up. Same it will look in full pronation. So unless you have a mid-prone, so you need to have a true lateral to know. Otherwise, you think it's out. That's one thing to know. Second, as Rishi said, you've never put a wire through grudge. Same if infection tracks is septic arthritis. If you ever have to put a wire, put proximal to grudge.
Yeah.
If you ever have to. So what you do is, if you cannot remember, because I forget also, mid-prone above elbow plaster, easiest for sugar. Mid-prone to 60%. But if my ulna had come out dorsally, yeah, then if I do full supination, head will tend to come very molar, like having 10% contact, which is what I want. Reverse the whole damn thing. That's why if it comes out dorsally, you do supination, and the other way around for molar. Rishi did a very, very
good
very
nice case. I mean, it's fine. Can I borrow your thing? Is that all right? The USB. Have you got it again? So
while you're doing this, can I drill them for 5
Yeah, drill them for 5 minutes. And I'll do that.
Who's going to come next? Mufi, you're done. You have 8 now. How many marks do you want? My goodness.
Yeah, about the droge. So you can fix it also.
Oh, Drudge, so even I don't understand. Come, go sit. Don't worry. Drudge is very. If you understand Drudge, you become a hand and wrist surgeon. I'm a shoulder surgeon.
Don't worry about it.
One question to you, sir. If the fracture is here, where the arrow is, yes. So you want to put a plate. Let's say you're putting a plate from tuberosity, not going up to head and neck. I'm not that mean actually. So you're putting a plate from there to there. Can you describe the approach to me?
So the approach will still be the proximal. So it's the extensor approach for Henry, so the proximal aspect.
Good.
And your internervous plane will be through supinator.
So which approach is between which 2 structures here now?
Skin, so with brachioradialis and.
Henry described this approach between which 2 structures in Hoppenfield? So artery, ulnar side, nerve, radial side. So that's what I was asking you. Okay, you've done that. So you've gone through skin and fat, arteries protected. What next?
So then the main structure, it was brachioradialis is lateral.
Good.
And medial, it's your
Pronator teres.
Sorry?
Pronator teres. Good. So where will you take your pronator teres now? Medially or laterally?
Pronator teres, I will take it ulnarly and brachioradialis radially.
Okay, so now my question to you. Now my question to you. How will you mobilize brachioradialis? And you will think this examiner is mad. But this is still the question, and I'm not willing to move.
How will mobilize the brachioradialis?
You must be thinking, oh, I'll put a Langenbach's and mobilize. What's wrong with this guy? I'm still not moving. Open to audience. How will you mobilize brachioradialis?
Social radial nerve runs under it, so you need to be careful. Also, there's a leash of Henry there as well. So you need to give the leash of Henry laterally.
That's the answer. So I cannot touch brachioradialis with Langenbach's. Until I look for leash, I ligate them, only then can I retract laterally with the Langenbachs. Very good. So that's why, so if examiner asks you something, there's a reason, by and large, 90%. So listen to them very carefully, yeah? So only then can you mobilize, because if you retract forcibly, whichever, leash can break. There's a tunicate, same problem, plaster, tunicate comes out later, compartment syndrome. Very important, yeah? Good. And then
so when you're down to grade, so you have to.
Then you take your supinator off and put a plate, isn't it? Easy.
You have to make sure that you're not blocking rotation, so you have to ensure.
Good. So my last diagram here. So I still have 3 minutes out of my 7. We're done. Let's draw another radius now, other way around. That's radius, that's the head. We agree?
Do you need any more slides at all or not?
No, we're done. You can.
Okay, please pop this in.
Radius. We agree?
Okay.
So now, so we're talking about which is this muscle. That's for supinator. Pronator teres come from here. And where will it sit? Anybody? Where does it insert? Where? Here? Here? Well done. Very good. I like that. Pronator teres, which is this muscle. Good. FPL, which is this muscle. Beautiful. Okay, good. So now, FPL, we were all saying ulnar border, 1% said mid substance. I said radius. You change now, like your K wires. Okay. Am I harsh? Thank you.
Harsh but fair.
So see, this is your anterior interosseous nerve, correct? Yeah. This is where it pierces PQ. This is where it supplies FPL. So where will you take it off from? Simple answer. So once you know the anatomy, how easy life is.
Just trying to find
yes. So if they ever gave me that Giliazi, I'll just say, can I draw this? In 20 seconds, literally, I can tell you whole radius split.
Can you go to substance now?
So see, if you do mid substance from here, this half you've denervated. Half thumb function gone. Thumb function very important. So you gone. You agree with me? So now plating is so easy. PQ comes off here, you put a plate. FPL comes off here, you put a plate. Pronator teres is not on this surface. So you mid-pronate, you start seeing PT, you incise it, PT goes there, you put a plate. Supinator, where will you take it off from?
On the side.
Correct. Because supinator will come from origin or insertion. So it's a ribbon-shaped muscle. It originates like this, ribbon goes into the supinator crest and have some things coming from superficial defect. So that's how it supinates, isn't it, when it contracts. So either it comes from the origin or insertions. It can't come anywhere else. Simple as that, isn't it? So see, you can plate the whole radius. Easy now. Anatomy is important. Okay, good. Thank you.
Great.
Sorry, Rishi.
No, it's fine. So guys, is that the last case? Sorry.
Yes.
Everybody's had a turn up,
Yes.
yeah. So I just want to finish off, guys. First of all, thank you so much for coming for the course today. And thank you to everybody in India as well, and to Hitesh especially for all your help today. It's been absolutely fantastic. I just wanted to discuss a case very quickly, Hitesh, which I think will be very interesting for our viewers. So I had a case last month, which I saw just about 6 weeks ago. And this is a 33-year-old lady who works as a childcare nurse, fit, active, who basically fell onto her outstretched hand, seen by ED, and basically found to have some pain over her left wrist, and it was reported as a query radiolucent line, query undisplaced scaphoid fracture. So she was sent home with a splint and to fracture clinic, okay? So these were the x-rays on the 26th of September, okay? Any comments, guys, so far? What do you notice?
I think the head of the online system came forward.
Okay.
It's not a true lateral.
Yeah, probably not a true lateral, but so possibly something going on there, but possibly something here with the ulnar styloid. Now, it's very easy with the retrospectoscope as well to have a look at certain things. So it's not very obvious if there's anything there. Patient was examined, had some scaphoid views done. Okay. Can you see any scaphoid fracture? So no obvious scaphoid fracture seen. Clinically, there was no tenderness over the scaphoid tubercle or anatomical snuff box. So patient was seen by resident and then sent home basically with reassurance and to mobilize. She started driving, presented with ongoing pain in the wrist, and then x-rays of the wrist were repeated. She came back to fracture clinic, and this is what it's shown now. We're now about 17 days post-injury. What can you see now? Okay, a volus bony fragment, but what's the big thing you can see? There's a drudge dislocation. And which way has it gone? Volar. Is that common? Yeah, it's unusual, isn't it, for it to go volar? Okay, so and obviously they x-rayed the elbow as well, very sensibly. Patient, I think, I don't know if they were seen in ED, but they came back to the fracture clinic on the 18th, which is now about 22 days post-injury. Okay, back slab was applied and they were referred to the upper limb surgeon. And typical post-COVID times, they came to me 29th of October. Okay, so almost 5 weeks post-injury. Okay, when I examined her, the position this time, patient was just locked in this position here. So I don't know if you can see that hit dish as well. So kind of locked in the sort of mid-pronation picture, not a jog of movement at all. Okay, so we've got quite a challenging case here now, haven't we? We've got a high demand patient, young, who's now got a locked 5-week-old volar druge dislocation. What are you guys going to do? Give me some suggestions. Apart from calling Mr. Agrawal and crying.
So I have faith. I say pray.
Exactly.
It's all pray.
See, I'm a year 1 consultant, so I cry when I see cases like this. He's very experienced. So.
I cry inside. I don't show it.
I want to look at the bony and the soft tissue structures. For the soft tissue structures, I would get a further imaging MRI scan.
MRI imaging. Okay, that's very sensible.
Look at the
Yeah. So
radial ligaments.
So I haven't got very clear MRI images here, but and then actually it's not the greatest images, but basically the crux of it is what the MRI images showed was no obvious fracture. TFCC was intact, but basically TFCC is avulsed from the fovea. And actually, which structures do you think have gone, the dorsal or the volar structures?
Volar, so this is the volar.
Think of PIPJ dislocation.
Think of PIPJ dislocation. So when the PIPJ dislocates dorsally, which structures go? Okay, when it goes volar, which structures go? So which ones do you think have gone here? Dorsal. Okay, and the axial perhaps illustrates it better. I don't know if this is a great image, but just showing you guys, orienting you. That's the radius. That's the ulna, which has gone volar. But actually, these structures are intact. This stuff here is all gone. Okay, so you can see that white there. That white indicates it's a T2 axial weighted image. So it indicates actually the structures have all gone dorsally. Can you guys see that? Yeah? No, this is native MRI. Native MRI. No arthrogram. These pictures are better than I thought it would be. so basically, and it was reported like this: complete dislocation of the druge, fracture of the ulnar styloid, complete tear of the dorsal radio-ulnar ligament. Remember I told you about those ligaments earlier in the biomechanics lecture, with stretching of the volar radio-ulnar ligament. So stretched, but not torn. All the dorsal structures are gone. So what made me feel a little bit better, because I obviously had to plan this for surgery almost at 6 weeks now. We're now into the 6th week, okay? With this locked druge dislocation for the year 1 consultant who's never seen this in his life. What made me feel a little bit better is sending it to discuss with 30 consultants around the country, hand surgeons. Only 3 of them had seen it. Okay, so it's a very rare thing. But the general consensus was go in the direction where the structures have gone. So if they've gone dorsal, you're going to go dorsal. Okay, so surgery was done that day. And the first thing I did was I tried to reduce it on table. And what do you guys notice? Pre-reduction, post-reduction. It actually reduced quite easily. So first thing I want to show you is how would you reduce a druge? Because you guys may be asked to do this in the middle of the night. You know what I mean? Even as registrars, you might be asked to do this. Like it's actually a very easy maneuver to do. I've never done it before, so okay, if I borrow you. So Hitesh, can you see that? You can see us okay?
Slightly more closer to the screen.
Come closer to the screen. Can you see now?
Yeah, a little bit, yeah.
Right. So you put the arm in, and in fact, Saurabh, can I borrow you as my second person? So you try and do it as a two-person technique. Imagine you've got him in the wrist arthroscope. Come closer, guys. So the elbow at 90 degrees of flexion. So as if you're doing a wrist arthroscopy. Now, I'm Saurabh's registrar. I'm going to basically clasp my hands around the forearm like that, like you're clasping together in that position there. Okay. Why am I doing that, guys? What does that do? Yeah. So that separates the radius and the ulna, doesn't it? You're kind of making the deformity worse before you make it better. You're unlocking it. So now, what will Mr. Agarwal do as a consultant? What's he going to do when I do that? If it's gone volar?
Pronate.
Pronate with a bit of volar pressure, isn't it? So do you want to show the maneuver that you would do, Saurabh? So I'll be your registrar. I'm doing that.
Is this pronation or supination? Pronation. Huh?
Pronation, yeah.
Pronate, and on the other hand, if you put pressure,
yeah,
it should reduce.
And actually, it went very easily, as you can see from these pictures. So I did this first before I even opened up. And my plan was, okay, look, I don't expect it to have gone. I don't expect it to be stable. Even if it goes back, I'm probably still going to need to open up because I've got to repair the TFCC back. So that was my kind of plan. But let's just say, let me hope I'm good at poker and I get lucky or whatever. You know, maybe you don't even need to open up at all. But actually, as soon as I did that, it reduced very easily. That is me just applying about 10 degrees of supination, popped out straight away. Very, very unstable. Okay, so you don't really want to put this now in plaster for another 6 weeks if possible. Or I don't like to put wires across the druge, as Saurabh said already. So next step was to go open. Okay, so I've actually shown you it a bit later. Let me go show you the pictures there. Okay, so intraoperative photography. So we did what's called a Garcia-Elias approach, kind of like a zigzag approach. Okay, dorso-ulnar. And this video kind of demonstrates it a bit better, shows the dislocation. Showing his hands on the thing. So can you see he's doing that maneuver, my registrar? So he's providing interosseous pressure. Okay. And then what I want to do is I'm going to then try. I'm pressing the volar with my finger and watch the. Okay, it's dislocated at the moment. Do you see it reduce? Then watch it dislocate. Push back again. Dislocate. Also, you can see the red. There. Can you guys see that? Yeah. Yeah. It's a bit subtle, but I'm just showing how you dislocate it, how you reduce it, how you dislocate it, reduce it. So the tip people said to me is they said, right, you know, make your incision, your zigzag approach. Remember that basically you've got to find sort of your EDM tendons. You've got to retract those one way. You've got to retract your EDCs the other way. And then basically you've got to be very careful because the capsule is just below. So find your dorsocutaneous branches, your ulnar, protect that. Go between EDC, EDM, okay? Open the tendon sheath so you can then mobilize it, and then be very careful. The capsule is like a slither just beneath. So you want to just open that, put stay sutures either side to repair that afterwards. And then you're going to come onto your gap. And for me, it was just a rent. There's a gap because remember, it's gone volar. So the tip that I was told was basically put a stitch into your TFCC before you reduce it. Otherwise, you won't find it afterwards very easily. So I put a stay stitch into the TFCC. I reduced it, and then I found the fovea, and then basically just put like a little 2.7 millimeter anchor into the fovea, just aiming slightly radially, and then tied the stitches. And remember, the TFCC is a triangle, so you need to get both the volar and dorsal limbs to pull it down. I showed you earlier, which is basically where you do the lasso type technique. You drill 2 holes, but I'm not technically good enough there, so I just thought I'll just bring a nice anchor, and it actually came quite nicely. And then I checked the stability on table, and you know, it was touch wood quite stable, so didn't need to do any wires, just plastered it in position of pronation. See if that's there. So this is just some intraoperative photography, and then I just want to go back to the imaging as well. So I did some intraoperative imaging, and what I wanted to show here is that's where the anchor is. So you can see how that anchor is basically into the fovea. Ignore that little styloid fragment, that's attached to, but basically you've got the anchor aiming slightly radially, pulling the TFCC down, okay? And all I was doing there on the table is I was pushing with the basically something metal just to see if I could sublux it, to see how how stable or unstable it was, and it was actually quite stable. So I was just testing that on the table, and then basically checked the position in plaster afterward just to make sure it hasn't dislocated once you put the plaster on. So let's wait and see. Let's wait and see. But basically, I put her in the above elbow back slab, and then I saw her on after 2 weeks. I've changed it to a sugar tongue splint for another 4 weeks. So the sugar tongue allows a bit of elbow movement, but it won't allow any prosupination as well. So yeah, so I just thought that'd be an interesting case just to show you guys how you deal with a Druge dislocation. So typically, remember, if it goes volar, you're going to need to pronate. If it goes dorsal, you're going to need to supinate. Okay, and remember that maneuver, get your registrar to squeeze to separate the interosseous membrane. You have to unlock first before you can reduce it, sorry.
100%.
Brilliant.
Just beautiful stuff. 5 weeks.
Yeah, 5 weeks, yeah.
But it's already open. There's still risk of.
Absolutely. And actually, when I saw her on Friday, I did the X-rays, and it's not a perfect lateral, as Saurabh said. It looked on that one like, oh, it was slightly dorsally subluxed on the latest X-ray, but I think it's probably just because they took it in a plaster, the position. I wouldn't be worried about it being dorsal because it went volar originally, so I think it's okay there. But I'm going to see her again in another 3 weeks and then take the splint off.
People are currently also doing tightrope to this one.
No. The tightrope is for your interosseous membrane, S6 low
Yeah.
not for DI.
Because you've got to think, what's the problem here, Ross? The problem here is the dorsal structures are gone. The TFCC has basically avulsed. It's still intact, but it's avulsed. So all we do is we're bringing those limbs back, we're reattaching them, and then actually when I prosupinated, it was actually quite stable. So you effectively restored normal anatomy.
But your best stabilizer is your TFCC. Once it that's why for all your other distal radius, you do nothing.
Yeah.
Once radius heals, styloid will heal.
Okay.
How many unstable drugs have you seen so far? Rishi himself checked 3 cases, people amongst 30 surgeons. It's a very rare injury.
And these were big cheeses across
Very
the
rare
country.
injury.
Yeah.
And our thinking was right, better PDM.
Yeah.
Like after bounce, better feed.
Yeah.
But these are very rare. Because TFCC bounces in the position, it will heal up and drug will be stable. So as Rishi said, once he's put an anchor, TFCC heals, drug is stable. All the dorsal rip off will slap down and heal, like in elbow dislocation or shoulder dislocation.
So I don't think, guys, you need to know loads about Druge for the exam at all. I think all they will ask you is recognize the Druge. You know, has it gone dorsal? Has it gone volar? Know to look for it. Okay, that's what they want to check is, will you look for it? And also, if it happens, would you know how to do it? So just remember, 2-person technique. Somebody squeeze with both hands. Somebody basically pro or supinate and just a bit of volar or dorsal pressure. Okay, if it's gone volar, pronate and volar pressure. If it's gone dorsal, supinate and dorsal pressure. Okay, and that's more than enough, guys, for the exam. Seriously, I didn't know about Druge for my exam, so now I know about it. I shouldn't say that. I never understood Druge for my exam. Hitesh, do you want to say some closing words, sir?
Absolutely amazing. I mean, I really appreciate Saurabh and Rishi and Arjun for staying, taking the pains for such a long course. It's 9 hours, right? Close to 9 hours. Am I right, Arjun? 9 hours?
Yeah. Count 2 hours, I got a 5 to prepare some slides. 11 hours.
Yeah, I know. That's a lot of hard work, isn't it? So, and last time I remember Saurabh did it all alone. So it was 9 hours entirely by Saurabh. This time he was lucky that he could share some of his time with Rishi as well.
I was very lucky.
He's got good stamina.
Less burden this time.
I know. No, I'm used to Rishi. He's coming in all the courses.
Yeah, amazing. This is so great. I could see thousands of watching. I could see it should be close to 3,000 plus views. We already have like 40 to 50 concurrent viewers, and it should hit around 3,000 to 4,000 views altogether. So it's amazing. And the power of internet, look at the beauty. You guys are sitting in London, 2 upper limb consultants, 2 highly trained consultants, trainees, and the whole world is watching. What more could we do?
All thanks to you, Hitesh, and your technology and your reach to the doctors.
Yeah. Now, ultimately, it's education, and a lot of people are going to be benefited, especially those who do not have access. For example, someone in Africa or someone in South America or some remote part of the world where they don't have access to good education. You guys have courses every day, but that is not the scenario in other parts of the world.
That was the idea, Hitesh, because upper limb, with due respect, is a bit less understood. I still wonder, like I still think how to do things. So I hope, as you said, it goes to remote parts of India and other places, and yeah, people get to learn and benefit.
Great.
Thank you very much.
Thank you so much, guys, and all the trainees who sat through. I mean, it's not easy to listen as well.
No, Hitesh, we are very grateful. You took out your day, you sat there. We are extremely, very grateful.
And I love to listen to you guys.
And we're thankful to all the other doctors listening to this. Thank you for your time, and thank you for listening to us.
Yeah, thank you so much. Thank you, Hitesh. Thank you, all the people in
Thanks,
here.
Hitesh.
Bye-bye. Thank you.
Thank you. Thank you very much.
Thank you, guys. Take care.
Guys, thank you.